for data analysis. We found that 4.52% elderly people aged 60 years and above had cognitive impairment, and people aged 75 years and above had highest prevalence of 13.1%. Now coming to socio-demographic factors, females currently not married, illiterate, currently not employed, elderly of middle socioeconomic class, and elderly living alone had higher prevalence of cognitive impairment. Marital status, education, socioeconomic status, and living status were significantly associated with cognitive impairment. Coming to addictions, current smokers had highest prevalence and non-smokers had least prevalence. Similarly, current alcoholics had highest prevalence and non-alcoholics had least prevalence. Both smoking status and alcoholism were significantly associated with cognitive impairment. Now, elderly with visual impairment, hearing impairment, and ADL impairment had significantly higher prevalence of cognitive impairment. Now, we applied binary logistic regression analysis to determine independent risk factors for cognitive impairment in the study participants, and illiteracy, living alone, smoking, alcoholism, and ADL impairment were found to be significant predictors of cognitive impairment among study subjects. The prevalence of cognitive impairment in our study was 4.5%, which is almost similar to other studies carried out in other North Indian populations. And cognitive impairment among elderly is significantly affected by socio-demographic factors, tobacco and alcohol addictions, and presence of ADL impairments among them. Now, cognitive impairment among elderly people is a major concern as it affects their physical, mental, and social well being. This results in increased dependence and reduced productivity of the society. So, early identification of cognitive impairment and intervention in the form of medications and behavioral therapy may slow disease progression, delay functional decline, allow for pre planning, and postpone nursing home placement of elderly people. Thank you.
Dr. Himani, please.
Yes, sir. You are not audible.
I think she's
Yes.
on. Yeah.
Is it okay now?
Yes, yes.
Yeah, we can.
Yeah. Thank you, Dr. Zaid, for the presentation. It's an important component that is very prevalent among elderly, which we need to take care of. When was the study done? Was it done recently or was it a little earlier?
It was done a little earlier.
Okay, no, because now that we have COVID,
Yeah.
that also would have been a very important component to take care for cognitive impairment.
Yes,
So this was during the pre-COVID era.
Yes, ma'am. Yes.
Okay, so that's not this. Now the mini cog scale, and doesn't it require permission to be used?
Ma'am, permission from?
Does it have copyright issues?
No, ma'am.
Is it an open access scale?
Yes, ma'am. Yes, it is open access.
Okay, and which are the other scales that you could have considered?
No, another is this mini state mental examination.
Which you mentioned that
Yes,
was
yes,
and what are the components of the mini cog?
it has a clock drawing test
Yes.
and memory test.
So how did you find the elderly comfortable with it? Were they able to do it or they could
Yes,
understand
ma'am.
the instruction?
Yeah, this was a simple test, memory test. We gave them some this name words. They were
In
made to
their own
recall.
language.
Ma'am?
It was in, you would describe it to them in their own language, right?
Yes, ma'am. Yes, ma'am.
Okay. So, how do you plan to carry the results of this study further? Are you planning any intervention or anything that you could do to the study participants back again to improve their condition?
We can do rehabilitation. Them those who had these impairments like this visual hearing, they need to be improved. Like visual hearing, they need to get their vision corrected.
Yeah. So,
Those
are
who
you referring them accordingly
Yes,
to
ma'am. We have
consult?
referred them to this college
Very
hospital.
nice. Okay. So, at least they'll benefit from the finding that.
Yes, ma'am.
Thank you, Dr. Zaid. Very
Thank
nice
you.
of you to see that, you know, they are taken care of and then you have referred them also. Thank you.
Welcome.
Dr.
Yeah,
Vineet, any question
yeah.
from your side?
No, just this comment that this rehabilitation part, what has been taken care of, it is the most important thing as far as the
Exactly. Yeah.
community. The thing you have very relevantly brought out this. The study is one part of it, and taking it to logical conclusion is more important, which they have done, and it's
Which
commendable.
appreciated, yes.
Yeah,
Thank
Thank
you.
you.
thank you, Dr. Ray. So now we request Dr. Snigdha Patnaik. She's professor of community medicine at Apollo Institute of Medical Sciences and Research, Hyderabad. And she's going to speak about her study on a population-based global physical activity surveillance for prevention of non-communicable disease in urban slums of Hyderabad. Dr. Snigdha Patnaik, please.
Uh, Good morning, sir.
Morning.
I hope. Okay, sir. I'll play my presentation. It will be played from the background, sir.
It will be played by the technical team. May I request the technical team to come in, please,
Yes, please.
and start the
Thank you, sir.
presentation. Yeah.
Good morning, everyone. I'm Dr. Snigdha Patnaik, Professor in Community Medicine in Apollo Institute of Medical Science and Research, Hyderabad. I'll be presenting the paper, A Population-Based Global Physical Activity Surveillance for Prevention of Non-Communicable Disease in Urban Slum of Hyderabad. My co-author is Mr. Mohammad Asad, who is a student of our institute and who helped in data collection during his posting in community medicine. Physical activity is defined as any bodily movement produced by skeletal muscle that requires energy expenditure. Physical inactivity is a major independent modifiable risk factor for non-communicable diseases like cardiovascular disease, ischemic stroke, type 2 diabetes, colon cancer, and breast cancer. It is also associated with important health outcomes including mental health, injuries, falls mainly in elderly individuals. They have a more tendency to fall if they are not physically active. So sudden physical exercise, they are very prone for falls and obesity. Non-communicable disease, primarily the heart and lung diseases, cancer, diabetes are the major killers. So about 38 million deaths were reported annually because of non-communicable diseases. So the non-communicable disease now they are in focus because of corona pandemic, because of COVID-19 pandemic. Those who have the comorbidities in the form of diabetes mellitus, other obesity. So the outcome of COVID-19 is very bad in them. So NCT is back in focus. So this is the invisible epidemic. And so it is an invisible epidemic that affects the economy of a country. So mainly the productive age group, that is between 30 to 40 or 40 onwards, they suffer from non-communicable diseases like diabetes and its complication. So the economic development of a country is hampered because of the disease burden of non-communicable diseases. Strong evidence exists for the benefit of physical activity for older people in enhancing physical fitness, quality of life, well-being, cognitive function and physical function. So studies have shown that elderly individuals, those are physically active, onset of Alzheimer's is delayed or they don't have any dementia if they are physically active. The study was undertaken with aims and objectives to do physical activity surveillance in the urban slum of Shekhpet, which is the largest slum of Hyderabad, to collect information on physical activity among the participants of the slum so that is the slum dwellers, to create awareness regarding the ill effect of physical inactiveness among the study population. So it's a cross-sectional study which is conducted in urban slum of Shekhpet. Shekhpet is the largest slum of Hyderabad. The health need of the people residing here is catered by the Urban Health Center of Apollo Institute of Medical Science and Research, as well as the Government Primary Health Center. So above, the study was conducted amongst the slum dwellers who were above 40 years of age. The study tool was Global Physical Activity Questionnaire. So which has a question developed by World Health Organization. This has a set of 16 questions that collects information on vigorous work, moderate work, travel and recreation. So physical activity that is related to work, commuting and recreation is collected through this Global Physical Activity Questionnaire. The study was conducted from the month of May to August 2019. Sample size was estimated to be 267. Informed consent was taken from all the participants, and the data collection tool is the Global Physical Activity Questionnaire, which is developed by World Health Organization for surveillance of physical activity in the member countries. Study result: about 273 participants were there. So out of this 273, about 38% were females and 62% of males were there in the study, participated in the study. And vigorous intensity work, about 83% of females and 71% of males participated in vigorous intensity activity in a day. More than 150 minutes of vigorous activity was done by 47% of females and 43.2% of males in the study area. Moderate intensity activity, it is prescribed that adult should do about 75 minutes of moderate intensity activity cumulative in a week. So in our study population, all our adults they were above 40 years of age. So about 31% did moderate intensity activity in a week, females, and 23% of males did above 75 minutes of work in a day. So vigorous activity above 75 minutes, it was done by total 55% only were involved in more than 75 minutes of cumulative physical activity, vigorous activity in a week, and 26% were involved in moderate physical activity in a week. And travel time, so females travel less in the study area. So implication of this study is now that in the study area, because of the modern gadgets and all, physical activity have come down. People are using all the electronics gadgets, so physical activity have come down. And in the study population, non-communicable disease like diabetes mellitus, cancer, falls in the elderly age group is more, and more so depression and all the mental health issues are rising up. So it is advised that people should be aware of the good effect of physical activity and involve themselves in some kind of physical activity voluntarily. Thank you.
Thank you, Dr. Snigdha.
Thank you.
Yes, it is an important problem in the geriatric population that physical activity should, be promoted. Now,
Yes.
I just wanted to know how did you choose the participants? What was your sampling frame from which you could choose them?
It was from the Urban Health Center, which is located in the urban slum of Shekhpet, that is the largest slum of Hyderabad. There, those like above 40 years. above 40 years, those who volunteered to participate, we give them the like we took informed consent, and we
Right, but where was the study setting? I mean, you went house to house. I mean, you went to the slums and
yes,
got, or you had a list of them at the center?
uh, we went door to door, house
Okay,
to house.
okay, and then you pick them up. Right. Could you interact with their family members? It was not part of your study, but could you interact with any of their family members at that time when you went to the this house?
The question, Madam, I didn't get the question.
No, when you said you went to their houses,
Yes,
to the
ma'am.
slum to be able to take the data
Yes,
amongst
ma'am.
those who volunteered. At that point of time, were you able to interact with any of their family members who were present?
Yes.
It was not part of your study as such, but
Yes.
incidentally, could you interact with them?
Yes, ma'am. We interacted with the family members and about their physical activity, because so many like all the patients we see in the urban health center, diabetes, obesity, then chronic mental diseases, they're present in the slum. We went to their houses, and when we saw such type of people in the houses, we told them to involve the person in all the household activity. No problem if the person is having mental disorder, he can help in the gardening or in any other work. So he or she will feel included in the family affair, and in this way, physical activity can help his mental health.
Right. Was there anybody who would have needed psychiatric or psychology intervention, any counseling?
Yes, ma'am. Some of the participants, they're already with diabetes, they're bedridden, they have complications of long-standing and uncontrolled diabetes, because even if they're treated, they're not properly taking the medication. Follow-up treatment is not there. Already they're having the complications of this peripheral neuropathy and all. So they're confined to bed, and they're into depression. Like above 65 years, they're into depression. It is like as if the life has come to an end. So our counseling was really helpful to them, to the family members, as well as to the person itself. They at least they got someone to talk to, confide to their what they're scared of, their apprehensions, like they're old now, they're having diabetes and they can't do their work. So all this they could confine in us.
Thank you, Dr. Snigdha.
This was
Thank
really
you.
nice, Dr. Snigdha, that you could draw collateral benefits out of your house-to-house study. It's really wonderful that you could achieve that as well. Compliments to you.
Thank you.
Now, I would request Dr. Divya NR, a postgraduate student, the young budding community medicine specialist from MS Ramaya Medical College, to speak to us about her study on prevalence of chronic obstructive pulmonary disease among elderly, a community-based study, she says.
Good morning,
Technical team
everyone.
to, good morning. Technical team to please come in.
Good morning, everybody. I'm Dr. Divya Anar, postgraduate student, Department of Community Medicine, MS Ramaya Medical College. My study is on prevalence of chronic obstructive pulmonary disease among elderly, which is a community-based study. Chronic obstructive pulmonary disease is a non-communicable progressive lung disease. It is characterized by chronic airflow limitation of lungs, which leads to restriction of normal breathing. By early initiation of the treatment, it can reduce the progression of the disease and also the complications. By estimating the burden of COPD, we can aid in decision making, planning preventive strategies, and also policy making. COPD is mainly associated with exposure to preventable risk factors like smoking, exposure to biomass fuel. Hence, by creating awareness and diagnosing the disease at initial stages, the burden of the COPD can be reduced. So, this study intended to estimate the prevalence of COPD among elderly in Devnalli Taluk, Bangalore Rural District of Karnataka. This was a cross-sectional study conducted between February to July 2019 in Devnalli Taluk, Karnataka. The study population were those aged 60 years or above and who were residing for more than 6 months in that particular area. Those with acute infections, glaucoma, facial palsy, cardiac arrhythmia, surgical procedures within the 6 weeks and edentulous persons were excluded from the study. We used a pre-tested structured questionnaire which collected the history regarding socio-demographic features and also assessed regarding the exposure to risk factors. Weight, height and body mass index was calculated. General physical examination and blood pressure measurement was done. The pulmonary function test was performed using a handheld portable spirometer. Here we conducted baseline spirometry and bronchodilator reversibility test, for which we used 400 microgram of inhalational salbutamol, and the pulmonary function test was performed 20 minutes after giving the inhalational salbutamol. The sample size was calculated by using a study done by Salim et al. In Tamil Nadu, where the prevalence of 55.9% was seen among elderly. It was calculated at 95% confidence level and an absolute precision of plus or minus 10. And an additional response of 10%, non-response of 10% was added. So this sample size calculated was 110. Coming to the sampling method, among the 28,051 population in Devnalli, 3 census enumeration blocks were selected randomly, which consisted of 613, 337 and 994 population respectively. Based on census 2011 elderly population, that is 8%, the expected elderly population was found to be 49, 16 and 79 respectively, and hence the probability proportionate to sample size was calculated. For the statistical analysis, for descriptive statistics analysis, percentage, mean and standard deviation was used. To find the strength of association between the risk factor and outcome, chi-square test of significance was used. The strength of association was expressed as univariate odds ratio with 95% confidence interval. Logistic regression analysis was done to find out the independent predictors. Coming to the results, the overall prevalence was found to be 23.7% with a 95% confidence interval of 19.7 to 27.8. The prevalence of COPD was slightly higher in males, that is 26.5%, when compared to females, that was 21.3%. This table shows the distribution of study participants with COPD based on world classification, that is the 4 grades of COPD. 3.9% were in the grade 1, 26.9% were in grade 2, 69.2% were in grade 3, and none of them were in the very severe category or grade 4 classification of COPD. Those who were aged more than 70 years showed a higher prevalence of COPD when those who were aged between 60 to 69 years, and this was found to be statistically significant. Other factors such as gender, education, socio-economic status, occupation were not found to be statistically significant. Smokers and those who were exposed to biomass fuel showed a statistically significant increase of prevalence of COPD. In the multivariate analysis, smoking was significantly associated with COPD with an adjusted odds ratio of 5.1%. By concluding, the current study showed a higher prevalence of 23.7% of COPD among elderly. It also showed that as age increases, prevalence of COPD also increases. Smokers and those exposed to biomass fuel showed a higher prevalence of COPD. The recommendations are: primary prevention plays a major role by creating awareness about the disease and role of risk factors in contributing towards the development of COPD. And health educational programs should be conducted regarding the reduction or cessation of the exposure to the risk factor. And early diagnosis of COPD is required in order to reduce the burden of COPD and improve the quality of life. In order to achieve this, effective screening programs should be conducted. These are my references, I would like to acknowledge my guide, co-guide, my department and IAPSM for giving me this opportunity. Thank you.
Thank you, Dr. Divya. I must say you have drafted your presentation very well with a lot of clarity and every detail put in so well that there's almost no question left for you. You have you put across everything very clearly and it was really well structured. You it's a very nice way of putting the presentation across. Very impressive. Dr. Vineet, sir, would you like to ask her any question?
No question. It's really heartening to see her putting a presentation in this manner and going right down to the references. These are
Right.
these small little details. Yeah.
Exactly. Even that flow chart was so nice.
Yeah. So, credit goes to her teachers as well, who have motivated her to get into this kind of research work. And all the best to you, Divya. And now, last but not the least, Dr. Sonam Lepcha from Vardhman Mahavir Medical College and Safdarjung Hospital, New Delhi. Her topic is prevalence of diabetes mellitus among tuberculosis patients attending a directly observed treatment short course center in Delhi, India. Technical team to come in, please.
Good morning, everyone. The title of my study is Prevalence of Diabetes Mellitus Among Tuberculosis Patients Attending a Directly Observed Treatment Short Course Center in Delhi, India. I am Dr. Sonam Lepcha, PG1 from Vardhman Mahavir Medical College and Safdarjung Hospital, New Delhi. Introduction. Tuberculosis is one of the top communicable causes of death worldwide. 7.1 million people with TB were reported to have been newly diagnosed and notified in 2019. 8 countries accounted for 2/3 of the total cases, with India contributing 26% of the cases. There are several medical conditions that serve as risk factors for TB and are associated with poor TB results. Subsequently, TB can complicate many diseases. TB and diabetes comorbidity is of utmost importance in countries like India, where both TB and diabetes are a huge burden. The risk of TB and diabetes is 2 to 3 times higher than those in non-diabetics. Diabetes causes dysfunction in the immune response to any infection. Studies show that patients with poor glycemic control have an increased risk of TB activation as compared to patients with normal glycemic level. TB increases the risk of unfavorable treatment outcomes like delayed culture conversion, death, treatment failure, recurrence among TB patients. Since the risk of developing TB is more likely in diabetic patients, this association between diabetes and TB could have a negative impact on TB control programs. There is scarcity of research to ascertain the prevalence of diabetes among TB patients in South Delhi. Against this background, this study has been conducted to investigate the prevalence of diabetes in TB patients in a UPHC South Delhi. The objectives of the study is to find out the prevalence of diabetes mellitus among TB patients attending the directly observed treatment short course clinic at UPHC South Delhi. Second is to find out the factors associated with it. Materials and methods. This is a record-based study which was conducted at a directly observed short course clinic for TB at an urban primary health center in South Delhi. All the TB patients who were registered from December 2019 to November 2020 were included in the study. Information of all the patients regarding socio-demographic details, site of the disease, type of patient, case definition, HIV status and diabetes status were obtained from the case records maintained at the center. The total number of diabetics and pre-diabetics were calculated and variables prevalent among diabetics, pre-diabetics and non-diabetics were noted. Ethical approval was obtained from the Institutional Ethical Committee. Data was entered in Excel and was analyzed using licensed SPSS 21. Variables were analyzed using Fisher's exact test and chi-square test, which is the test of significance for difference between two proportions. P-values less than 0.05 were taken as statistically significant. Results: out of 252 TB patients, A total of 252 TB patients were registered over the course of 1 year. Out of 252 patients diagnosed with TB, 141 were males and 111 were females. Out of the total 252 patients, 7% were diabetics and 1% were pre-diabetics. Table 1 shows a socio-demographic profile of tuberculosis patients visiting the DOT center. Out of 252 patients, 142 were less than 30 years of age, 141 were males, 143 were unemployed, 163 were married, and 150 were below poverty line. Figure 1 shows the prevalence of diabetics and pre-diabetics among TB patients. 92% of the TB patients were they didn't have diabetes. 7% had diabetes and 1% were pre-diabetic. Table 2 shows the disease profile of patients visiting the DOT center. Out of 252 patients, 154 had pulmonary TB, 103 were clinically diagnosed, 203 were new cases. Figure 2 shows the distribution of TB patients according to extrapulmonary tuberculosis sites. Lymph node, 45.9% had lymph node as extrapulmonary tuberculosis site followed by pleural effusion. Figure 3 shows the distribution of TB patients according to sputum positivity. 59% was sputum positive and 41% was sputum negative. Table 3 shows the factors associated with diabetes mellitus among TB patients. 0% of those with age less than 30 years had TB with diabetes as compared to 17.3% of those more than 30 years of age, and this difference between them is statistically significant. Out of 163 married individuals, 11.7% had TB with diabetes mellitus as compared to those who were unmarried, and the difference between the two is statistically significant. 11.7% of patients with pulmonary TB had diabetes as compared to 1% of those with extrapulmonary TB, and the difference between the two is statistically significant. Limitations: documents may lack authenticity. Parts of the document might be missing because of age, and we might not even be able to verify who actually wrote the document, meaning we cannot check whether it's biased or not. Representativeness: documents may not be representative of the wider population. Conclusions: 100% screening of TB patient for diabetes at DOT setting demonstrates the feasibility of screening for diabetes at a routine setting. There is a 100% screening of TB patient for diabetes at the DOT center. The prevalence of diabetes is 7% and pre-diabetes is 1%. Those patients with age more than 30 years, pulmonary TB, sputum positive TB are the factors with statistically significant association with diabetes in our study. Implications: in this study, the prevalence of diabetes and pre-diabetics were found to be 7% and 1% respectively. It was higher in patients more than 30 years of age, male gender, pulmonary TB, and sputum positive TB. Tuberculosis and diabetes mellitus are both public health problems of India. Early diagnosis of pre-diabetes can help with primary prevention, and the status of comorbid conditions would guide the clinicians in deciding the appropriate treatment regimens and comprehensive management of at-risk individuals. And early treatment, if initiated, would improve the outcome of such patients. Thank you.
Thank you, Dr. Sonam. Good morning. Your study is on a very pertinent issue of tuberculosis and diabetes association. A small feedback on when you're presenting, try to see that you don't have your slides so cluttered, and having so much information put together on one slide. And also, when you read from the slides, it becomes very monotonous. So besides that, your study is very good. You have definitely gone into the depth and tried to find out various aspects. Only, would you call it a prevalence or a proportion? You've been mentioning that it's prevalence everywhere, right?
Yes, ma'am.
So would it be a proportion, or it's actually a prevalence? Just think over it and let
Yeah.
me know. Dr. Vineet, sir, any other comments?
No, just I think we have come to the end of our session, and very well thought out spectrum of topics which have been given for this session. And I was really impressed by the selection of by this technical team that right from budding specialists to senior faculty, those studies and those presentations have been put together. Dr. Vivek Sagar, please convey our gratitude and compliments to the organizers
Thank you,
for
sir.
this kind of thought.
Yeah.
And only thing which is there for me to say, maybe that it is a reiteration a number of times this has been talked about, that what are the ethics of research? We must not lose sight of it. Whether it is informed consent or permission from any ethical committee, and the issue of copyright. In today's time, these two things I feel they have a lot of relevance, and young researchers, especially, they should not lose sight of it. Dr. Himangni, my teacher, you must have the last word.
Sir, my introduction by you has been very humbling. You have been referring to me as a teacher all the time, but we are all learning. And, we are long life, like we say now, all the IMGs are going to be lifelong learners. So are
Absolutely.
we. And congratulations to the team, Dr. Vivek.
Thank you.
You have a great team with you who have, been coordinating with us and have done an absolutely wonderful job. They are so courteous, they are polite, and they are so helpful and cooperative. Do convey all this to them.
Thank you,
And
ma'am.
the presenters were all very wonderful, very good studies, and definitely this can be carried forward further into more of intervention.
Yes,
So
ma'am.
that would be, a 360-degree kind of
Yeah,
intervention where we could complete the loop. So thank you very much, and thanks to IPSM organizers for giving us this opportunity to get to know all of you and share the session.
Yeah. So thank you, ma'am. So now, before closing the session, I think it is my honor to propose vote of thanks to Dr. Uh, Vineet Rastogi and Dr. Himangini Shah, ma'am, for
oh, thank you.
sharing your time. And I know these days schedules are a bit busy. And again, thank you very much. And I propose thanks to all the speakers for putting efforts to make this session successful, and
Wonderful. Wonderful.
also to our HOD for continued support to us, and Dr. Kadir, who all compiled all these um, uh, abstracts, and then he put all the recordings in place, and we are thankful to him also. And in the last, to my team, who is putting a lot of efforts to make these sessions successful, and the vendor also, which is playing the recordings and helping us, I think. And thank you again to all. And with this,
It was really seamless, huh? The recording was really seamless.
Yeah,
yes, yes, ma'am.
wonderful.
Absolutely no, very nice. Yeah.
And recording was, I mean, we proposed recording just to stick the timing also, because
No,
it,
and playing it out over here was seamless.
yeah,
There
yeah,
was absolutely no lag anywhere.
yes, ma'am. Even it gives liberty to speakers also to make it better by recording again and again. Thank them also, and
We have saved 6 minutes.
yeah, we can discuss
We
more.
we can like the participants who have
Yeah, yeah.
presented to share their
Hi.
experience,
Experience.
Yeah, if they
anything
can
that they would
come
like
in.
to
Yeah,
say.
since we have time. Yeah.
Yeah. Maybe we can start with Dr. Deepak if he's here. We
Yeah.
can have his views, and if he has some question for other participant, he can ask that also.
Right, definitely.
Yeah.
Dr. Deepak, are you here?
Yes, sir.
Yeah. So
Sir,
anything?
I would like to thank everybody, in particular the chair, because I got a very good feedback regarding my study.
Okay.
So just as ma'am said, I'll incorporate that part in the study also. So it was really a great experience, ma'am. And sir, thank you so much. Thank you.
Thank you.
And then Dr. Zahid.
Yeah, absolutely. Very nice session. Learned a lot of things. Hope we'll carry it forward in future.
Thank you. Dr. Snigdha, would you like to comment?
Yes, sir. Like I'd like to thank all those in the chair. You are very encouraging. In fact, we are reporting to WHO. This is our project we got from WHO, and this is a pilot study. So now, like, what is the physical activity to create awareness in the slum is the motto, and so that it will bring down all the non-communicable disease. And we are reporting to WHO. And now, after this presentation, I'm really encouraged to carry forward because of the situation right now, pandemic. We are like work is stalled, but like after this, once the cases come down, soon we'll start it. And in fact, this presentation, all of you were so encouraging. We'll definitely carry it forward, and I hope like we can extend it and we can have a good publication, and we can I mean, influence the policy makers to have some recreation area where they can play or do some physical activity in the urban slums, because they're all unplanned areas. So after the pandemic, we are trying to influence the policy makers to have some physical activity space dedicated to the I mean this underprivileged section.
Okay,
Thank
Dr.
you so
Snigdha,
much.
I must just before you proceed, I must say, Dr. Snigdha, we like your ever smiling attitude. I'm
Thank you
sure
so much.
it's so nice to have that smile on all the while. I'm sure when you go to the field area also, they would love to be interacting with you.
Thank you.
Can we have a comment from Dr. Divya? Very quick comment. We are just having 1 minute.
Yes, I would like to thank IAPSM for giving this opportunity, like a virtual conference amidst this COVID, and I would also like to thank the judges for their appreciating words for me.
Yeah, thank you. Dr. Lipeksha?
No.
I would like to thank the chair, and I would like to thank PGI for selecting this oral presentation,
Great.
and I'll and for the feedback also, that how I should make the slides and all.
Wonderful.
Thank you very much. With this, we
Thank you, Dr. Sunam.
Thank you.
With this, we can conclude, and we extend a very warm thanks to Dr. Vineet and Dr. Himangini, ma'am. And we request you all, and along with our participants, for a photograph. So if we could all have our smiling faces and a thumbs up, and we could record this for our PSM website. Thank you so much for attending the session, everyone. With your screens,
Yeah.
still not being visible here. Please, everyone, switch on your videos and let's have a thumbs up and thank our chairs for being here. I am still unable to see some of our participants. Could you all please join in and show your videos? Switch on your videos, please. Yeah. All right then.
Thank you. Thank you.
thank you.
Thank you.
Thank you, everyone. Have a pleasant
Thank you
day.
so much, sir. Thank you, madam.
Thank you.
Thank you. Thank you so much.
Thank you so much. Bye.
My video is on actually. अब तो वीडियो चेहरा नहीं दिख रहा था, अब वो नहीं आया फिर नहीं सेकंड सेशन में नहीं। चलो कोई नहीं, हो गया अब तो। नमस्ते।
Hello, good morning.
Good morning, sir. A very warm welcome to you, sir.
Thank you very much. But just I was checking that am I audible or not. Thank you. Thanks a lot.
You're audible, sir. So we'll just upgrade you to the host. Waiting for Dr. Swaroop.
Yeah, no problem. No issue.
घनश्याम जी मेरे पास आपकी प्री रिकॉर्डेड वीडियो है तो वो प्ले कर दूं?
No sir, actually it's not showing my PPTs, so I would like to present online, sir. If
Yeah,
you
okay,
permit.
done. Yeah, sure.
Okay.
Dr. Ghanshyam, if you are presenting online, then please
Yes,
keep in the mind this time frame of the 7 minutes.
Okay, sir. Okay, sir. Good morning, respected chairs, co-chair, and one
Just
and
wait.
all. Oops.
Are we starting?
Sir, we'll wait for Dr. Swaroop to join in.
Definitely.
I'll share along with you, sir.
Then we will invite Dr. Ghanshyam, and then you start.
Ji, sir.
better.
Myself.
Times did we ensure they have got the link? You called him Atma yesterday.
Minutes late. A very good morning to all attendees, and we extend our warm welcome to Dr. Hitesh, who is our chair for the session. Dr. Swaroop Kumar Sahu will also be our chair and will be joining us shortly. Dr. Hitesh is an associate professor at the Community Medicine Department at GMERS Medical College, Valsad, Gujarat, and his expertise are reproductive and child health, nutrition, mental health, and tribal health. Sir is a rapid response team member for the COVID pandemic control and also a contributor for the IAPSM textbook of preventive and social medicine. He's a member of State Advisory Committee for the CCCH course for MLHP for Health and Wellness Care Centers, and will also be working on a project on mental health and SHSRC funded project on health and wellness care centers and HPNC in tribal area. So represents the Western Zone as governing council member of the IAPSM, and also he is a member on the AEFI Casualty Assessment Committee for Gujarat. We thank you very much, sir, for acceptance of chairing the session for us on mental health, sir. And we look forward to seeking your expertise on mental health for this session. So shortly, Dr. Swaroop will join us for the session, and then we shall start.
Thank you for the generous introduction. Shall we start with the opening or should we wait?
So, okay, we can go in and just start with Dr. Ghanshyam's presentation. And then when Swaroop sir comes, we'll have a break and have sir step in.
Okay, so good morning.
Over to you, sir.
Okay, thank you very much. Good morning, one and all, and thanks a lot for the generous introduction. At this juncture, I would like to thank the organizers of the 48th annual conference of the IAPSM, and IAPSM to provide me the opportunity to chair the important session on the mental health. As you all are aware that mental health is one of the iceberg phenomenon disease, and cases of the mental diseases and disorders are reported from all the stratas and classes of the society. You all are aware of the media reports of the cases of the mental disorders amongst the celebrities. Some of them are portrayed as success stories, and some of them are portrayed or some of them are uh, unfortunately uh, going for the untoward outcomes. But it proves that the mental health need of the mental health is perceived at all stratas of the community. uh, Along with this, let me say that this COVID-19 pandemic, which we are facing since last 1 year, or you can say that more than 1 year, is creating the community more susceptible to the mental health. So the mental health is converting into the huge challenge in our country. Different evidences, if we go through the different evidences and different research, it suggests that a sustainable mechanism to screen, diagnose, counsel and treat the mental disorders is still either in the infancy phase, or you can say that in the early neonatal phase in our country's health system. So, and along with these complexities, stigma is also attached with the mental disorders. So this creates, and this all complexities creates the mental health issue. To address the mental health issue is as the challenge to the public health experts. And with this background, I would like to say that this session, we both chairpersons are expecting to address some of the important issues of the mental health. Along with this, which can provide or which can open up the future research area, as well as to guide the policymakers for the future strategies to strengthen the mental health interventions. Now I am just as you all are aware, then also I am just revisiting the rules of the presentations. So once we a chairperson invite an individual for the presentation, there are 7 minutes pre-recorded presentation. After that, 2 minutes discussion regarding the study, and then we will move ahead for the next presenter. And we request all the presenters to stick the timelines during the discussion session, because as almost all are the pre-recorded sessions for the 7 minutes. So
Thank you, sir,
these are the rules. I am now handing over to the Dr. Swarup Sahu. Thank you. Thanks.
Thank you, sir, for informing the participants. And I extend my very warm welcome to Dr. Swarup Kumar Sahu. And sir, we do apologize on our end because you were having a glitch in opening up the session, sir. We apologize on our end. Dr. Swarup Sahu is also our chair for the session, and sir is an additional professor in the Department of Preventive and Social Medicine in JIPMER Pondicherry, and sir has worked extensively on tuberculosis, HIV, non-communicable diseases, childhood malnutrition, and also projects related to health system strengthening. Sir has provided his technical expertise for the implementation of the RNTCP as WHO RNTCP medical consultant. Sir is a member of several scientific societies, and which includes Indian Society for Medical Statistics, International Union Against Tuberculosis and Lung Disease, and he is an associate editor of the Journal of Public Health Action, an official journal of the International Union Against Tuberculosis and Lung Disease. Sir has numerous contributions as a resource person in the field of epidemiology and research methodology. We really thank you, sir, for acceptance of chairing the session for us, and we look forward to again from your expertise, sir. So I will hand over to you now, sir. Sir, you're muted, sir.
Yeah. Namaskar.
Morning, sir.
And very good morning to all. And thank you, Avruchi, and all the. And I must thank the management for giving us this. IAPSM management for giving us this opportunity. So I think introduction is over. So we will straight away go to the presentations. Let me introduce the first presenter. Should I? Can I do that, Dr. Hitesh?
Yes, sir. Definitely, sir. You can proceed with the first presentation.
Thanks for the introduction. Sorry, somewhere I missed it, part of it. No problems. We are on time. So let's start the first presentation. So I think the first presenter is the case control by Ghansam Singh.
Yes, sir.
Has he presented?
Yes, sir.
Yeah. You have presented already?
No, sir. He is going to present now, sir. He is going to present now, sir.
Yeah. So let's welcome Dr. Ghansam Singh. He will be presenting a study titled A Case Control Study on Substance Use Disorders among Adult Participants Visiting De-Addiction Centers of IGMC in Himachal Pradesh. Welcome, Dr. Ghansam. Please go ahead with your presentation.
Sir, good morning, sir. Respected chair, co-chair, and all the members, organizing members, as well as other senior faculties. I am going to present my presentation as live. Sorry for the technical difficulties. So, shall I share the screen?
Sure, please.
Yes, sir. This is a case control study on substance use disorders among adult participants visiting de-addiction center of IGMC Shimla. It was, as we know, substance use, abuse, and substance use disorders are the cause of great concern all over the world, including India. As we know, more than 7 million people died of use of tobacco, and more than 3 million due to harmful use of alcohol in 2017. Most common drug use disorders were cannabis dependence and opioid dependence. In India, there are 22.4% of people more than 18 years of age are suffering from these disorders. In Himachal, this scenario is even higher due to large tourist influx and borders attached to the drug use hubs in the vicinity. So we try to elicit the various risk factors at the personal, family, peer, school and community levels, which were associated with the substance use disorders. This study is an attempt to find the gaps in the knowledge about the risk factors of substance use disorders among adult participants. Our objective was to determine all the risk factors of substance use disorders among the participants visiting the de-addiction center of our tertiary care hospital at IGMC Shimla. Methodology was, as already mentioned, it was a case control study conducted in the de-addiction center. Our sample size was 176 participants, 1:1 ratio of cases to control. Inclusion criteria was for cases all new billing adult stable patients of substance use disorders less than 40 years of age, which were diagnosed using the ICD-10 DSM-5 criteria. Controls were billing, paired, age and sex matched peers, family members, relatives, who were either non-substance user or occasional substance user but never have developed any substance-related problems. With exclusion criteria of serious, unstable, non-oriented substance use disorder patients were excluded. Coming to the results, first the socio-demographic profile. They were all matched as per this age and sex matching. So most of the participants were between the age of 20 to 30 years, mostly males from rural background, mostly Hindus, non-married, educated with more than 10 years of schooling, agriculture by occupation, belonging to upper or upper middle class. This is my first table of socio-demographic distributions. Coming to substance use disorder distributions, most of the cases were of polysubstance abuse, with 35% having 2 drugs in combination, 16% more than 2 drugs. Alcohol was in about 9%, and in the illicit drugs, the heroin abuse was the most common with 16%, and alcohol use disorders were about 10%. Coming to the reasons of why they started substance abuse, the participants cited as the curiosity being the most common reasons among cases, followed by peer pressure and easy availability of substances, whereas the reasons of addictions among the cases were peer pressure was the most common, followed by this was family substance abuse and personal reasons. Then we did the paired univariate analysis, as this study was a paired case controlled studies. So we found that involvement in aggressive behavior, frequent violence in the adolescent were significantly associated with substance use disorders in later life, whereas lower education, non-working status, non-joint family, non-married status, belong to low socioeconomic status, and starting substance before the age of 16 years were not significantly associated with substance use disorders.
Dr. Ghanshyam Singh, sir, you have 2 minutes left for your presentation, sir.
Lack of hobbies, having comorbidities, depression before substance abuse, high peer pressure, bad parent-adolescent relationship, poor parental monitoring were the factors, other factors which were significantly associated with substance use disorder. These factors, involvement in aggressive activities, faced violence in the adolescence, depression prior to substance abuse, and bad parent-adolescent relationship were the factors which were found to be significant in multivariate analysis also. So we conclude that substance use disorders were associated in the present study with aggressive behavior, bad family relations, high peer pressure, and complacency to that pressure, whereas adjustment problems, lack of determination, depression, other comorbidities, as well as family substance abuse were not associated with these disorders. Most commonly reported substance use disorders were the polysubstance abuse, whereas among illicit drugs, heroin use disorders were the most common disorders. Coming to recommendation, aggressive behavior need an early detection and correction through counseling and remodeling techniques like meditation, yoga. Involve children in discussion, things with problems on a regular basis, maybe a daily session, and need a wide IEC. Heroin and other illicit drugs, import and illegal selling need to be strengthened surveillance through strict law, early detection of indulgence, and easy availability of the treatment facility in those having substance use disorder. Resilience to peer pressure can be developed by having good peers and denial. Thank you. Thank you.
Swarup sir, you are muted, sir. Swarup sir. Swarup sir.
Yeah. I am. Thank you, Dr. Hitesh. Yeah. I must congratulate Dr. Ghanshyam for this nice presentation, and he is dealing with a most important topic, which is a real problem which needs to be addressed. Just few questions from my end.
Yes, sir. Yes.
What is the sampling technique you have used?
We have just this consecutive sampling, sir.
Okay.
Okay.
All the participants, we during study period, whoever visited the substance use this de-addiction center during our study period, but they were adult participants.
Yeah. So
below 40 years.
Thank you for that.
Yes.
You had some exclusion criteria. So
Yes,
severe cases you have excluded. Any reasons for that?
Sir, one thing was we couldn't able to elicit the various risk factor from the serious cases, unstable cases. We won't be able to assess them. One reason was that.
Yeah. Okay.
Yes.
Fine. Just my last question from my end.
Yes, sir.
Have you, let's say, at the primary care level, what can be done to address this issue? Because it's astonishing, actually. Opioid is more prevalent as compared to smoking and alcohol. But do you think that this is a real problem in the community also? Or is it that people with opioid are coming to your center?
Sir, actually in Himachal, it's a real problem, sir. It has risen very to the higher level in the recent times, sir. Recent 2-3 years have seen an enormous rise in this heroin use, especially that mixture of heroins.
Yeah. So any plans you have to take it, extend it, this study to the community so that people benefit out of it?
Yes, sir. We are planning to conduct such studies in the different de-addiction center, because our is a tertiary care center. Most of the patients are the serious, come here at the end stage, where they have serious problems. So we are planning in the lower centers, maybe primary care level or district levels, we can have such studies.
Okay. Thank you so much. That's all for my end.
Thank you, sir.
Thank you. And it's a nice study, and we are anticipating that it goes beyond the hospital-based setting to the community level, and your recommendations.
Yes, we are planning for that.
Yeah. I know your institute, so you can convince the policy makers to do the certain interventions to reduce the substance abuse in the community. Thank you. Thanks a lot.
Yes, sir. Thank you, sir. Thanks.
Now I would like to invite Dr. Betsy Varghese for the presentation on the association between the internet addiction and sleep quality among the medical students, a cross-sectional study. Please, Dr. Betsy.
Hello, am I audible, sir?
Yeah, you are audible.
Yes, you are audible.
Okay.
Clear.
Okay. So I have prepared the pre-recorded session. Hello.
Yes. Yeah.
Hello.
That's fine.
Your pre-recorded session will be, it's there.
To all the judges and delegates of IAPS in 2021, myself Dr. Betsy Varghese, Junior Resident, Department of Community Medicine from Government Medical College, Trivandrum. Now I'll be presenting my study on association between internet addiction and sleep quality among medical students, a cross-sectional study. My guides were Dr. Indu PS, Professor and Head, and Dr. Tony Lawrence, Associate Professor from the Department of Community Medicine, Government Medical College, Trivandrum. So we all know that internet is an unlimited space for information exchange and social networking, and now it has become a source of development of cyber behaviors. The pathological use of internet, or we can say the problematic usage of internet, or in other terms, the internet addiction, it plays a crucial role in health. We all know the basic definition of health, right? It is the state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. And internet is now influencing every dimension of this health in both positive and negative way. With increasing popularity of smartphones and its advanced technology, use of smartphone before sleep is now becoming a habit for adolescents and young adults. It prolongs sleep latency and decreases the sleep duration. Many of the studies show that of all the factors affecting sleep quality in college students, internet use is among one of the most prevalent. So with this, the objective of my study was to find the association between internet addiction and sleep quality in medical students of Government Medical College, Trivandrum. Coming to methodology, the study design was cross-sectional study. Study setting, the Government Medical College, Trivandrum. Study period, 1st October to 30th November 2020. The study participants were the undergraduate students of Government Medical College Trivandrum, and I had recruited 102 participants into the study. The participants who gave consent and submitted their response were consecutively recruited to the study, and the study variables were the demographic variables, the details of internet usage, the internet addiction level, which was assessed by Young's Internet Addiction Tool, and the sleep quality, which was assessed by Pittsburgh Sleep Quality Index, that is PSQI. Now, Young's Internet Addiction Test is a 20-item scale that measures the presence and severity of internet dependence. So, based on the scoring, it is divided into four, that is no internet addiction, mild internet addiction, moderate internet addiction, and severe internet addiction, and the score differentiation can be seen. Now, PSQI, that is the Pittsburgh Sleep Quality Index, is an effective instrument which is used to measure the quality and pattern of sleep in adults. It differentiates the poor quality sleep from good quality sleep by measuring 7 areas, which I will be showing in the further slides. So, a total score of 5 or greater is indicative of poor quality of sleep. The data collection method was using an online questionnaire form which was distributed among the undergraduate medical students. The data was then entered into the Excel sheet and analyzed using the SPSS software version 22. The important statistical tests used were the independent t-test, the chi-square test, the correlation, and logistic regression. So the results, the mean age of 102 participants were 21.61 years with a standard deviation of 1.32. The gender distribution, females were 58% and 42% were male. Coming to the internet addiction level in the study participant, 43 participants had no internet addiction, 32 had mild internet addiction, 26 had moderate internet addiction, and 1 had severe internet addiction. For further analysis, I have combined these last two groups of moderate and severe internet addiction into one group. Now, assessing the sleep quality, about 53% of the participants had poor sleep quality and 47% had good sleep quality. The Pearson correlation coefficient was computed to assess the relationship between the IAT, that is the Internet Addiction Test score, and the PSQI score, and a positive correlation was established between these two with the p-value less than 0.001, and it can be seen from the scatter plot diagram which is shown here. Now, on doing ANOVA to assess the PSQI score between the three different addiction groups that I had mentioned earlier, there was a significant effect of internet addiction on sleep quality across the three different internet addiction groups, and the p-value was significant. The post-hoc comparison using the Hochberg test indicated that the mean PSQI score for normal students was significantly different than the score in the students with moderate or severe internet addiction, and we can see the mean value and the standard deviation. A chi-square analysis was done between the three internet addiction group and the 7 components of sleep quality. These 7 components are the subjective sleep quality, sleep latency, sleep duration, habitual sleep efficiency, the sleep disturbances, the use of medication for sleep, and daytime dysfunction. And of these 7, 4 of them, that is the subjective sleep quality, the sleep duration, sleep disturbances, and daytime dysfunction, were associated with poor quality of associated with the internet addiction, the 3 internet addiction group. On doing the logistic regression, the internet addiction score and the number of years in college were significant predictors of quality of sleep. To be more specific, poor quality of sleep, and we can see the adjusted odds ratio, the confidence interval, and the p-value, which is significant, that is less than 0.05. So, in conclusion, the results of this study demonstrated significant associations of internet addiction with most parameters of the sleep quality. Poorer quality of sleep in those with moderate and severe internet addiction than that in normal internet users and those with mild internet dependency can be seen. Now, and the internet addiction was also found as a significant predictor of poor sleep quality. So, it can be implied that the controlled and healthy use of internet must be encouraged to prevent its addiction, as its role is associated with poor sleep quality, which in turn can deteriorate the physical and mental health of the users. The internet addiction should be recognized as an established disorder for early detection of moderate and severe internet addiction, so as to prevent further deterioration in mental health and prevent few psychiatric disorders. And further research should be done to establish the role of internet addiction in affecting the physical and mental health. With that, I come to the end of my presentation. Thank you.
Thank you, Dr. Betsy.
Thank you, sir.
Yeah, it's a very important area or aspect nowadays we are facing, that the overuse of the internet, or you can say that sometimes justified use of the internet to reach the various research work and everything in the medical students. So first of all, I'm congratulating to you for to do a research in a much needed area, because sleep quality is one of the essential part for the quality of the life. So just I have one or two questions. That your sample size is 102 students. So how did you selected that 102 students out of the all the students?
Sir, I had taken one of my parents' study, was a study which was done in Bangalore. So on the basis that the prevalence of the moderate and severe internet. So the study was the prevalence of internet addiction among these college students. And from that, I had taken this 102. When I had distributed among 150 participants, but only 102 complete responses were obtained back, because the study was done using an online questionnaire. Because of COVID, the students have not yet joined. So I distributed the online questionnaire and I distributed among 150. And by the time of this study period, I got 102 responses only. So I included all of them.
So you answered my second question also, that what was the non-response rate? Because in online studies we are facing these issues, that they are not giving answer in a with the sincerity, as well as the non-response rate is also high. So one more question, one last question, that your desired sample size was 150, and you will get answers from the 102 students. Is it? Am I right?
Yes, sir.
Okay. So why did you calculated that?
The actual was 145, so I had rounded about to 150.
Actually, have you calculated the expected non-response rate for this particular study?
Yes, sir. I had calculated that.
What was it? What was the calculation? Because recently we are doing the internet study in our college also, and we calculated higher non-response rate.
Okay, I had taken it as 20%.
20% is fine. 20% is fine. Okay. Okay. Thanks. That's all from my side. And once again, congratulations for doing a great study. Thank you.
Thank you, sir. Thank you, sir.
Let me welcome then the third presenter, Dr. Mukul Maheshwari. He is doing a study. He has done a study on mental health concerns among students and staff of a medical college in Madhya Pradesh and their association with socio-clinical factors. Welcome, Dr. Mukul. Nice to see you.
I've made a previous recording already. If the system
fine,
you are traveling, sir.
Play it, or I can just do the live presentation right now.
It is being played, sir. You can hold.
Hello everyone. Myself, Dr. Mukul Maheshwari, presenting for Iapsmcon 2021. My title is Mental Health Concern Among Students and Staff of Medical College in Madhya Pradesh and their association with Socio-Clinical Factors. Myself from Department of Community and Family Medicine, Iapsmcon Bhopal. Introduction to what my study is. As India is on verge of harboring mental health epidemic as per NHS data, and rigorous training and expertise among doctors and nurses come through a dedicated courses and overworked training schedules. Mental health morbidity is more common among productive age group and those who are overworking. A study highlighted mental health service utilization in university students through a web-based survey found that 37% to 84% of treatment gap among students who screened positive for depression and anxiety. Rational toward my study is, in the last decade there are many reports of attempted and contemplated suicide among medical students that is concern for campus authorities and Ministry of Health. Though many developed countries have highlighted the role of various measures in this regard and highlighted important concern of medical nursing students, rigorous attempts are required to do the groundwork before policy making and making paradigm shift in the management of these concerns in India. Objective regarding the study is screen campus students and employees of Iapsmcon Bhopal for common mental health concern, their association with clinico-psychological history. Methodology: study design is cross-sectional facility-based survey. Sampling units are students, MBBS in nursing, professionals, and maintenance workers. Study setting is Premier Tertiary Care Teaching Hospital of Central India, which is in Bhopal. Ethical clearance was from Institutional Research Review Board and Institutional Human Ethical Committee. Data collection tool was pre-structured and pre-tested and was uploaded on a web-based Kobo toolbox, and it was a self-administered questionnaire. The privacy and confidentiality of data and patient information was strictly maintained. The data was compiled and analyzed using R 4.03, and the packages used were RStudio, GTSummary, and SQs. The results were expressed in the percentage proportion. The association between different independent variables was determined using Pearson chi-square test. Results: 563 participants filled the questionnaire. Out of 38 people denied the consent, and final analysis was done on 525 participants. Descriptive characteristics of the participant is with the age mean of the 24.27 with SD of 6.81, with mostly of more than 25-year age group, which was 54% of the total. Gender was approximately equally distributed, with more preponderance toward the female, which was 54%. Most of the participants were from the urban area, which was 65%. Most of the participants were Hindu religion, 82% of the participants, and out of all participants, 75% of the participants were living in a nuclear family structure. Out of all participants, most of the participants were students, which were MBBS, nursing students, or intern, which was 70%, and rest of the participants were from administrative officer, clinical and paramedical staff, faculty, nursing officer, and residents. Diagnosed medical condition was present in 9.9% of the participants. Diagnosed psychiatric condition was present in 5.3% of the participants. Physical activity was seen in 68%, and substance use was seen in 50% of the participants. Analytical results: significant association was found between age and decreased concentration and increased use of time in unproductive work, which was mostly in age group of more than 25 years. With the 61.9% out of all with the decreased concentration were from the more than 25-year age group, and 60.8% from people which were increased use of time in unproductive work were from the more than 25-year age group. Also, there was an association was found between gender and frequent pain during stress, which more preponderance toward 67.9% in the female group. Like most of the people which was having the frequent pain during stress were from the female gender. Significant association was found between religion and being depressed and being anxious and unable to stop worrying. More preponderance toward Hindu religion, with 71.2% being depressed and 71.9% being anxious out of total anxious people, and 77% out of which were total participant which were unable to stop worry, with p-value of 0.001, 0.03, and 0.04 respectively. Significant association was found between stream and being anxious and increased use of time in unproductive work, with more focused on the students, as out of all participants being anxious, 77.4% were students, and out of all participants which was seen with increased use of time in unproductive work were mostly 83.7% were students, with p-value of 0.016 and less than 0.001. Significant association was found between stream and being unable to stop worrying, decreased comfort in public places, and decreased concentration. And it was also samely focused on the students, as out of all people, 76.4% students were the student which was unable to stop worry, and 71% out of all which was having decreased comfort in public places were students. Yep. Significant association was found between permanent residence and increased use of time in unproductive work, just focused on urban area, like with urban being 71% people were associated with the unproductive work. Significant association was found between type of family and increased use of time in unproductive work. Similarly, like 81.56% of the people who were having increased use of time in unproductive work were from nuclear family structure. Concluding my study, as the prevalence of the mental health issue among health workers is on the rise, with substance abuse being a notable problem, efforts should be made in this domain to promote healthy mental state among health workers. Probably due to academic burden, high self-expectation, students have tendency to overwork, which lead to high level of anxiety and decreased concentration in the same group. Thank you very much.
Thank you, Dr. Mukul, for the nice presentation.
Yes, sir.
Yeah, just
Thank you, sir.
a few suggestions. Because of want of time, I will restrict my comments also. Just again, the same problem, what I expected, that sampling. So denominator is actually missing for each age group, each category of people who have included in the study, is it not? So out
Yes,
of
sir.
total students, how many were included? Out of staff, how many were included? And various cadres of staff. Maybe that will, maybe that is better to present. Okay, what proportion from each group? Second thing is, I think my personal opinion is maybe because you had a chunk of people from nursing and a students group, maybe separate analysis for students would have been better. That's my personal opinion. That's all.
Yes,
Because
sir.
why I'm thinking like this is a staff proportion of people from staff, I think, is less representative.
Yes, sir.
So that's one thing concern. Anyway, you can do when you publish or something, you can do the necessary modification. That's a different thing.
Yes,
Yeah.
sir.
And one just comment is not a question, but just a concern. People who are students who are high tendency to work, that means they want to work. Why they are they have more problems related to mental health? What is any comments about that?
Sir, it's maybe sir, the more work, they overburden themselves. They want to do things more perfectly. It should be perfect in their own way. So they try to do it much more, and so they try to work much easily anxious.
Yeah. So that's actually that's a
my
question
comment,
that is yeah. So that is a question concern we have. See, those people who are really good, they want to contribute. They should not be depressed, is it not? So
yes, sir.
something is missing, and that is the area. That's the reason your work is so important. We need to understand why these people, nice people who want to contribute, are depressed. So some changes are necessary, definitely necessary, where we can change, make a change. Thank you so much. Thanks for your presentation.
Thank you, Dr. Mukul.
Yes, sir.
Now I would like to invite Dr. Smitha for presentation on parenting stress and coping strategies adopted among the working and non-working mothers and its association with the socio-demographic variables for cross-section study. So it's over to you, Dr. Smitha.
So thank you very much. Sir, I have a pre-recorded video which I would want it to be played.
Sure.
Your video will be played shortly.
The title of the project that I will be presenting today is Parenting Stress and Coping Strategies Adopted Among Working and Non-Working Mothers and its Association with Socio-Demographic Variables, a Cross-Sectional Study. The presenting author is Dr. Smitha Chandrasekharappa, and this study was funded by JSS Academy of Higher Education and Research as a part of Student Research Program. Firstly, the introduction. The status of the women in India has seen major changes over the past few millennia. The National Data Collection Agencies accept that statistics seriously understate women's contribution as workers. In urban India, women participate in workforce in impressive numbers. About 30% of the software industry workforce is by females, and in agricultural and allied industrial sector, women account for as much as 89.5% of the labor force. They remain the primary caretakers of the family, and they are also trying to expand their life to include their careers. They also have to keep their traditional roles at home. This dual responsibility intensifies the stress with respect to childcare and rearing in working mothers. And this not only has impact on the mental and the physical health of the mother, but also the growth and development of the child. And hence, this study was undertaken with the following objectives: to determine and compare the parenting stress among working and non-working mothers, To determine and compare the coping strategies adopted by working and non-working mothers or to combat the parenting stress, to assess association of socio-demographic variables with parenting stress among the working and non-working mothers. Coming to methodology, it was a cross-sectional study conducted for a duration of 6 months, and the mothers of the children attending the routine immunization center at a tertiary care hospital who were having children between 1 to 6 years of age were included in the study, provided they provided the consent, and then the questionnaire was administered in the local language. The mothers who had their children between 0 to 1 year of age were not included in the study because it was thought that in such scenario the mothers might be in the maternity leave, and this might have its impact on the outcome of the study. Then related to sample size, we were not able to find any appropriate study which would help us identify the sample size for our study, which were conducted in India, and hence we initially conducted a pilot study with 20 working and 20 non-working mothers in the who attended the immunization clinic. And with the data that was collected, we were able to identify that 80 working and 80 non-working mothers had to be interviewed. But we estimated that 10% attrition or no, a missing or non-response rate might be there, and because of that we rounded off the number to about 100 in each group. And the sampling method, the universal sampling method was adopted, and hence all the mothers who satisfied the inclusion criteria were consented and included in the study and interviewed till the required sample size of both the working and the non-working mothers were reached. Then the questionnaire, the socio-demographic variables were collected, which included the variables that has been listed here. Then related to parenting stress, parental stress scale 13 questionnaire was used, and the median score for this questionnaire was 54, and anybody who had the parental stress scale score less than 54 were considered to have lesser stress, and more than that was considered to have the higher stress. And coping strategies, this data was collected using the COPE inventory. Ethical consideration, the institutional ethical committee clearance was obtained before the start of the study, and informed consent was obtained from all the mothers before they participated in the study. The data after it was collected, it was entered in Microsoft Excel and it was analyzed using SPSS version 25, which is licensed to the institution. And then descriptive statistics was used, in which the data was represented in the form of mean, standard deviation, the percentages, median and interquartile range. And inferential statistics was used, which included the independent sample t-test to compare the working and non-working mothers with respect to the study variables, and then association of categorical data with respect to parenting stress to see that the chi-square analysis and the Fisher exact test was used, and for comparison of the quantitative data and the coping strategy scores with the parenting stress scores, the Mann-Whitney EU test was used. And a univariate logistic regression analysis was also used, but none of the variables showed any statistically significant result. So this diagram is showing us that the working mothers had higher parental stress scores. Almost double of them had it, that is 26% has in comparison to that of the non-working mothers. So this is the table representing the comparison of the socio-demographic variables between the working and non-working mothers. The number of children and the birth spacing were the two variables which showed comparability. The rest of the variables did not show comparability when it was seen statistically. But definitely when we look at the mean and the standard deviation represented in the table, it doesn't show much amount of difference, and hence we thought that the group were still comparable, and then we moved on to the analysis. But still it can be considered as one of the limitations of the study, and it might be also for the reason that it was conducted at a tertiary care hospital. So this can be overcome with the help of a community-based study. And this is the table representing the statistically significant difference seen in the score of parenting stress between the working and non-working mothers. This is the logistic regression analysis. And this is the differences in the coping strategies that were adopted by working and non-working mothers to combat the parenting stress. You can see that religious coping and behavioral disengagement were the two important coping strategies which showed significantly different scores between the two groups. Then the scope for future research, definitely community-based studies have to be done in this direction. And then the conclusion and the recommendation. The present study showed that both the working and non-working mothers had a significant amount of parenting stress, but it was double in the working mothers when compared to non-working mothers. And the coping strategy adopted by the working mothers was mostly restraint, while that by non-working mothers was focus on and venting of emotions, use of instrumental social support, denial, religious coping, and use of emotional and social support and suppression of competitive activities. This study definitely helps us understand that there is a high necessity for interventions in the form of promotion of mental health at workplace and also for provision of daycare facilities at workplace. Thank you very much for providing me this opportunity. And this study has already been published in Clinical Epidemiology and Global Health Journal in the citation that has.
So, thank you, Dr. Smita, for a nice study. And one of the emerging issue, or you can say that one of the untouched issue or less touched issue of the parenting stress among the working mothers in comparison to the non-working mothers. Actually, we all, you must be agree that parenting should be a pleasant experience instead of the
Yes, sir.
stress. But due to this social structure and working and expectations of other than the parenting from the mothers, we are facing this issue since long, and we need a strategist to cope up with the working stress and to convert it into the pleasurable experience. So once again, I thank you, and almost all the scientific aspects and you can say that the study design aspects regarding this refusal as well as your statistical analysis are at the satisfactory level. So no question from my side, but a suggestion is that please go ahead in this direction and please work in the, please go for the future research work, continue future research work in this direction. Thank you. Thanks, Dr. Smita.
Thank you so much, sir. Thank you so much for all those great inputs. And definitely, sir, I would really wish to take it forward.
Yeah,
And as noticed in the review of literature also, I think there are very few studies which are conducted in this direction. And as I think women representatives being in research, I think we should do part of our contribution as well. Thank you so much, sir. Thank you so much.
Don't spare the males also.
Yes,
we can also contribute in this same
yes,
direction.
sir, sure.
Definitely. And I promise that I will go through that article from
Yes,
which
sir.
you published in the journal. So I will
Thank you.
definitely go through it. Thank you.
Thank you,
Thanks for providing me this.
Thank you, sir. Thank you so much.
Thank you, Dr. Smita. Nice hearing you. And definitely, I will also go through your article.
Thank you so much, sir. Thank you so much.
Thank you so much. So for want of time, we'll move to the next presenter. Thank you. So our last presenter is Dr. Mariam. So he'll be presenting on perceived stress level and its sources among residents in a tertiary care teaching hospital in central Gujarat. Welcome, Dr. Mariam.
Morning, sir. Sir, I have already a pre-recorded video, so I would like you to play. Hello everyone. I am Ms. Mariam Kadiwala and I am a third year UG from Medical College, Baroda. And the topic of my study is perceived stress levels and its sources among residents at a tertiary care teaching hospital of central Gujarat. So as we all know that the modern medical workplace is a complex environment and all the doctors respond differently to it. Some may find it very exciting to work in such an environment, while others may find it exhausting and tiring to work with such a heavy workload. Stress experienced by the residents may affect their job as well as their career. Resident doctors nowadays have to face tremendous workload. Sometimes they have to work from 24 to 48 hours together in a shift, and this could drastically affect their health as well as their performance. Work-related stress is a potential cause of concern in resident doctors with decreased work satisfaction, anxiety, depression, and sleeplessness, which may lead to medical errors. Stress is typical during residency because of the heavy workload, sleep deprivation, difficult patients, and financial concerns. Also, doctors treat the patients with varying degree of illness, and thus are at an increased risk of acquiring nosocomial infections. Studying specialties not compatible with their skills, interpersonal problems, and gender related issues on the job may further worsen the situation. Effects of stress can lead to anxiety, depression, OCD, hostility, alcohol, and substance abuse, and thus there is a need to measure the stress level among the junior resident doctors. So, the objective of my study is to assess the level of stress among resident doctors across various specialties and to find the effect of stress on their health. So the study conducted by me was a cross-sectional one, and all the residents from first, second and third year of a tertiary care hospital were included in the study and interviewed. The total number of residents in our college were 355, out of which 173 responded. The investigator explained the objectives of the study and consent was taken before starting the interview. So, the data was collected using simple interview techniques and a pre-tested, pre-designed, self-administered general health questionnaire was used and the resident doctors across various specialties were included. Participants were asked about the demographic details, work hours, stress relieving activities, and questions related to health, work environment, and psychosocial stressors were asked. Data was collected using EpiCollect 5, which is a mobile-based data collection software, and the proportions and results were calculated using MS Excel. Prior permission from the hospital and college authorities was sought, and the project was approved by the Medical Research Ethics Committee of the Institute. In order to maintain the data confidentiality, informed consent was taken from the participants, and the data entry and reporting did not reveal any name. Residents from all the departments, that is clinical, preclinical, and paraclinical, were included in the study, and all those residents who did not give consent or were not available due to any reasons were excluded. So here are the results, and as we can see that from the 173 participants that gave consent, 56.6% belong to first year of residency, 28.9% belong to second year of residency, and 14.5% belong to the third year of residency. And here are the proportions of stress in various departments. As noted, radiology, physiology, pathology, pediatrics, microbiology, ENT, and biochemistry were the ones who experienced maximum stress, and forensic medicine and anesthesia were the ones who experienced less or minimal level of stress. Among the various questions that were asked about the factors contributing to the stress, the answers ranged from inadequate support from friends and family to 82%, sleep deprivation 75%, inadequacy of resources and staff in the organization to 73%, inability to cope up with work 73%, frequently missing meals 65%, inability to balance between work and social life 52%, inability to manage time efficiently 46%, conflict among colleagues affecting the performance 41%, confronting constant emotional and physical suffering 36%, time for exercise and other leisure activities 33%, fear committing an offense while treating a patient 32%, high expectations from the patients 32%, and smoking contributed to 6.35%. So the conclusion of my study was that inadequate support from friends and family, sleep deprivation, and inadequacy of the resources are the primary factors contributing to stress. And thus, the implication of my study is to try to know the magnitude of the stress and the factors affecting it, which could help us create a proper counseling tool and conduct various stress relieving programs. Proper counseling, better facilities, fixed duty hours, and making the policies to decrease the stress in doctors is the need of the hour. Thank you.
Thank you, Mariam. It's a nice topic and is an important topic also. And quite often we doctors take care of everyone, but somehow we neglect ourselves. So just to comment about your findings, methodology.
Yes,
If you
sir.
see the anesthesists are very relaxed, is it not? So,
Yes, sir. But sir, it may be because of lack of sample size, and in a few subjects like biochemistry and anesthesia, I got very less sample size, and also my study was restricted because of this COVID-19 pandemic. So
very nice. Actually, you have that's was the only comment I had. That's a nice. We can take it forward. You can collaborate with the maybe nearby medical colleges. So
yeah,
collaboration will
definitely.
further improve further. Okay, so nice.
One word from my side. First of all, I congratulate you because being a undergraduate student, final year undergraduate student, you are presenting it into the national conference. So I am congratulating you.
Thank you so much, sir.
Please keep this zeal of the research activity throughout your career. It is much needed. So congratulations for the good study. But one comment is that your non-response rate is quite high. That is approximately
Yes.
50%. And
Yes, sir.
most of the time, the persons who are non-responding, they are facing more stress, and
Yes, sir.
that part is included. So it should be included into the limitations of the study. And once again, I am congratulating, being a UG student, you are presenting a paper in this national forum. So please keep this attitude on, and please, and best of luck for your future.
Thank you so much, sir.
And in a lighter mode, that you are creating a conducive environment for your future also on
Yes.
studying the resident doctors. So once again, congratulations and best wishes.
Thank you so much, sir.
Thank you.
Thank you, Dr. Mariam. So nice. Yeah. To conclude, actually, I think we are running short of time. So I'll just conclude in few sentences. Actually, what we observed is it's a beautiful study. All of you have done, and all these, most of it were cross-sectional studies. What I will urge the young researcher is, can we take it forward, to do an intervention study? Even if it's not possible to do RCTs, can we do maybe before and after study and take it to the community so that we will see the results of it in a better way? That's one thing. Second thing is, when we're designing a study, it's important that, as all of you have understood, importance of sampling. We need to take care of this sampling so that we'll be able to understand, interpret the results in a better way. And Ian, secret of happiness. Actually, we should be working for happiness. One of the study, that's what. So even if people are wanting to contribute more, they are not happy. So we need to really think, and this is an area, mental health is one of the areas which we need to collaborate. So collaborate by doing collaboration, and you people have already collaborated with other departments, especially psychiatry, and but mainly at the institute level, if you can take it to the community level, I think good, nice research questions can come up, and we can address these mental health problems in a better way. Thank you so much.
Thank you, and congratulations to all the presenters. You touch the various domains of the mental health in a very effective manner. I request all of you to go ahead with this domains, because it may be the first step, but we need to convert the research into the action to reduce the problem or to address the problem of the mental health. Once again, I am thankful to the organizers to providing us the opportunity to chair this particular session. Thank you. Thanks a lot. This is from our side.
Thank you, Sahu sir and Hitesh sir, for accepting to chair our session on mental health. And we would also thank our attendees for the session. And could we all have a photograph together? Could you please switch on your videos and give us a thumbs up and smiles? I hope this session has improved all our mental health levels.
Definitely.
Is everybody?
I think few more can join.
Yes. Could you please join? Yeah. Thank you, everyone. Thank you, sir. Our chairs. Thank you again.
Thank you all. Thank you so much. Thanks
Thank
for
you.
the opportunity.
Thank you. Thank you. And please share this photo with us also. Thank you.
Sure,
Yeah.
sir.
Thank
Sure.
you. Thank you. Thank you. Thanks a lot.
Thank you, sir.
Thank you.
Hello. So notice to all attendees here, our next session starts at 11:30. So we'll have a short break in between. Message for all attendees. Our next session starts at 11:30. So we can all go in for a break now.
మన టేకింగ్ ద్వారా కన్నీ ఉంది ఓకే 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 థ్యాంక్ యూ आवाज है ना आवाज पसंद है
Good morning, all. So it is my honor to welcome you all in this session of geriatric health. I take my opportunity to introduce you Dr. Purushottam Giri. He is professor and head of Department of Community Medicine at Indian Institute of Medical Sciences and Research, Medical College, Badnapur. Sir is elected Vice President of IPHA and Executive Committee member of Iapsmcon of Maharashtra. Elected Executive Committee member West Zone of National IAPSM from 2017 to 18 and 18 to 19. He has more than 175 scientific research publications to his credit in various Indian and international journals, written a chapter on international health regulations, medical book, awarded Venus International Medical Award for Outstanding Clinician in Medicine under medical specialty. He's got International Excellence Award 2020 as a Dr. APJ Abdul Kalam Research Award in the field of research in community medicine. So with this brief introduction, I now take my opportunity to hand over this session to before handing over this session, I also want to introduce Dr. Rupali Barua ma'am. She is professor and head of Department of Community Medicine at Assam Medical College, Government of Assam. She is Inspector of Medical Council of India for both UG and PG courses of medical colleges of India from 2010 to 20, WHO consultant to revise National TB program, WHO fellowship in epidemiology, biostatics, Johns Hopkins University and University of Michigan, USA, awarded DBT fellowships, involved in major public health programs in the country, editorial board member and peer reviewer of Journal of Community Health Management and Journal of Health Policy Programs and Governance, contributed extensively as a faculty and guide to over 20 PhD scholars, expert and examiner of Guwahati University and Srimanta Skandreva University of Health Sciences, Naipur. With these words, I welcome you all and hand over session to the chairs of this session. Over to you, sir and ma'am.
Good morning. It's my pleasure, along with Professor Giri, to be chairing this session on this very important subject of geriatrics. We all know that geriatric population increasing every day. In every household, we see geriatric groups people suffering mentally, physically, and how they're coping, how the family is coping, how the society is coping to give them a long, healthy life and for healthy aging. So since we should give time, should we get Dr. Professor Giri, please? You may say a few words and then we can start with the presentations because we have to maintain the time. Professor Giri would like to say a few words? Or should we start with the presentations? Audible or not?
I think Dr. Giri is not visible in the.
Then should we start with the first presentation? He can wind up and do the concluding part because we have to maintain the time. I think the first presentation is on assessment of social problems in geriatric population of Rewa city, Madhya Pradesh. The speaker is Dr. Kanika Gupta and you have a time of 10 minutes, 7 minutes for the present. Okay, please start.
Video will presentation will be played for her.
Good morning, ma'am.
Okay, good morning.
I have a pre-recorded presentation.
Yeah, I request vendor to technical team to play the video for Dr. Kanika Gupta.
Good morning, everyone. I'm Dr. Konika Gupta from Shamsha Medical College, Rewa, Madhya Pradesh, the presenting author of the oral presentation on assessment of social problems in geriatric population of Rewa city, Madhya Pradesh. The corresponding co-authors are Dr. Ambrish Mishra sir and Dr. Shubhangi Naik ma'am. Elderly or old age consists of ages nearing or surpassing the average lifespan of human beings, so the boundary of old age cannot be defined exactly. As such, the Government of India adopted national policy on old persons in January 1999. The policy defines senior citizen or elderly as a person who is of age 60 years or above, from 5.6% in 1991 projected to rise to 4.4% of population by the year 2026. The reduction in fertility level creates a steady increase in the life expectancy has produced fundamental of the population, which is to the aging population. The needs and problems of elderly vary significantly educators and other this study was in conjunction with analysis further exploration so many studies focus on various social problems in geriatric population. The objectives are as follows: to know the social problems of the geriatric population in urban Riva as well as to determine the functional impairment among them. This community-based cross-sectional study was carried out at the field practice area of Urban Health Training Center located at Bodabag, attached with our college and comes under the Department of Community Medicine. The study population comprised of geriatric population aging 60 years or above, and it was a house-to-house whole survey. After excluding the non-respondents and logged homes after at least 3 visits, 300 elderly respondents who gave consent were recruited for the study. Ethical approval was obtained for the conduction of the study. All study subjects were interviewed using pre-designed questionnaire for 20 to 25 minutes, and standard precautions were taken in view of COVID-19 guidelines during the interview. This study was carried out from August 20 to November 20, and appropriate statistical tests were applied for the analysis. Informed consent was taken for the same. After the study, it was seen that 41.4% males, while there were 58.6% females in between 60 to 64 years of geriatric participants. Loneliness was seen in about 62%, while abuse by family members was seen in about 41%. 21% elderly participated in social activities, and feeling of being neglected was seen in 47%, while exploitation in familial tasks was seen in 31% of study participants. Other findings from the study are described in the following tables. First, it was seen that maximum of the geriatric participant aged between 60 to 64 years. Among them, 60.3% were illiterate and 39.6% lived in joint families. When it came to the social problems faced by the geriatric population, it was seen that 64% had apathy and negative reactions from their family member whenever they used to get ill. Out of them, it was seen that 61.4% were on financial dependence and maximum about 38.4% didn't wanted to talk about their intrafamilial relations. When it came to psychological impact, so it was seen that 30.3% had stress, while merely only 3.6% were worried. Then, when it came to the functional status of the geriatric population according to the gender, it was seen that 32% females as compared to 22% of males were fully functional and 21% of females had moderate impairment. About 5% in females and 4% in males there was severe impairment. Similarly, the functional status as well as the functional status according to the gender has been depicted here in the form of graph. So in the present study, as I have already explained, that moderate and severe functional impairment was found to be in 36% and 9% respectively, out of which female respondents were noted to be more functional than male respondent. A similar observation was reported by a study conducted by Kamar et al. At the end of the study, I concluded that awareness regarding regular medical checkups should be ensured among geriatric population so that prevention and early detection of the chronic diseases is possible. Implication of social problems should be minimized among them so that the promotion of better geriatric health remain the focus of society. There is a need to have geriatric wards having specialized professionals with psychiatric and medical social workers along with subsidized healthcare services. Also, there is a need to train both medical and health professional to handle the specific illness associated with aging. Awareness about nutrition, health-related issues of the elderly are of great importance, and health problems of elderly should be tackled with psychosocial intervention. Healthy tradition and values of Indian culture should be protected, promoted by developing a good intrafamilial and social relationships. That's all. Thank you.
That was a very good presentation. If there are any questions in the question box from the audience?
Ma'am, there is no questions as yet.
Thank you, ma'am. So, Dr. Kanika Gupta, it was a nice start to the geriatric health. And it was a good presentation. And you have maintained your time also. Should we go on to the next presentation? I think next presentation is on depression among elderly orphans in a private orphan home, Kanchipuram district of Tamil Nadu. It's a cross-sectional study. And the speaker is Dr. Nithya Viramuthu. So Dr. Nithya Viramuthu, you may please start your presentation.
Good morning.
The presentation will be played by the host.
Postgraduate from Department of Medicine, Biology Medical College. I'm going to present my topic on depression among elderly orphans in a private orphan home, Kanchipuram district, Tamil Nadu, cross-sectional study. My guide is Dr. Iapsmcon, Professor, Department of Medicine, Biology Medical College. Introduction. Elderly in orphan homes are more prone to psychological problems, especially depression. Geriatric mental health is an important public health problem as there are lack of community studies in Tamil Nadu. The study was undertaken. Clinical gerontology or geriatrics deals with the provision of comprehensive care that is given in preventive, clinical, remedial, and social aspect of illness that occur around them. As they age advances, the person is subjected to emotional turmoil due to social maladjustment. The key feature of depression or depressive mood, which includes pervasive sadness, persistent sadness, and depressive ideations, which in turn includes hopelessness, helplessness, and worthlessness. It can extend to become a multi-system disorder with physiological, biological, and psychomotor changes. Depression is both underdiagnosed and undertreated in primary care settings. Symptoms of depression in older adults are often overlooked and untreated because they coincide with other problems encountered by the older adults. Objective to estimate the prevalence of depression among elderly orphan in a private orphan home in Kanchipuram district, Tamil Nadu. Material study design, cross-sectional, it is a cross-sectional study. Study area in select private orphan home in Kanchipuram district. Study population, all the inmates of the select old age home in Kanchipuram district with the study participant consisting of consenting elderly greater than 60 years of age. Inclusion criteria, people among the study population who gave consent to the study. Exclusion criteria, people who are different, non-responsive ones, and those who are not willing to take part in the study. Sample size of 150 was taken by purposive sampling method. Assessment tool interview was conducted in a language which is familiar to the subject, that is Tamil, for which the purpose of consent form and assessment tools were translated in the language. Depression was assessed using a 15-item geriatric depression scale, which is a 15-item self-report assessment used as a basic screening measure of depression in the elderly. Accuracy of GDS-15 is not influenced by the severity of medical burden, age, or other socio-demographic characteristics, and even the very old and ill can be screened appropriately. Study duration: the cross-sectional study was done from August 2020 to November 2020. Statistical analysis data was collected and compiled in MS and analyzed in cases software. Descriptive statistic was used as equivalent. All qualitative variables were presented as frequency and percentages. Result of the total 150 people who were questioned, 86, that is 57 percentage, were male and 64, that is 43 percentage, were female. This shows that males are largely admitted in old age homes due to various reasons. Figure 1 shows the sex distribution among the inmates. Figure 2 reveals the religion-wise distribution of the study population. That is, the 90 percentage were Hindus, constituting about 120 people, followed by 5% Christians, that is 18 people, then followed by Muslims, 4 percentage, 12 people. It does not imply that the Hindus are largely abundant to old age homes. Rather, it shows that majority of the population living here belongs to Hindu religion. This is the GDS 15 questionnaire. Here it shows 42.7 percentage people answered that they were satisfied with their life. 56.4% said they dropped many of their activities and interests. 43.6% said they feel their life is empty. 50% said they often get bored. 48.6% said they are often in good spirits. 59.1% said they are always afraid something bad is going to happen to them. 40% said they feel happy most of the times. 55.5% said they feel helpless most often. 50% said they would prefer to stay at home rather than going out and doing new things. 40.9% said they have problems with memory. 45.5% said they feel it is wonderful to be alive. 54.5% said they feel pretty worthless. 38.2% said they feel full of energy. 44.5% said they feel hopeless in a situation. 52.7% said they think most people are better off than them. So the scoring is done from 0 to 15. The score less than 5 suggests no depression. 5 to 10 suggests depressive syndrome. More than 10 suggests depression. The table 2 shows the score-wise distribution of depression among the inmates. The class intervals are given as 0 to 5, 6 to 10, and 11 to 15. 28 people were scored from 0 to 5, that is 18.6%. 66 people had scores 6 to 10, that constitute about 43.9%. 56 people scored from 11 to 15, that constitute about 37.5%. Result: Table 1 shows 50% of people were feeling helpless, worthless, social isolation, feeling that others are doing better than them, feeling of something bad happened to them. Table 2 shows that 37%, that is 37.5%, that is 56 inmates were depressed. 43.9%, that is 66 of the inmates were having some depression or showing signs of depression, and 18.6%, that is 28 people had no depression. Implication and conclusion: more strength of association for depression was seen with no family member, low socio-economic status, low intensity work, death of the family member. Nearly 80% of the elderly in orphan home had some amount of depression. These findings show the need for proper care by the family members and counseling for the elderly, which are much importance in preventing depression. These are my references. Thank you.
Good morning.
Any, ma'am, there is no question in the chat box as yet. Ma'am, can you please unmute yourself?
Really great importance. This depression among elderly orphans is a topic which has been taken up well by Nitya Viramuthu, because this is seen even staying in a family. Elderly are isolated and feel depressed, and this is really something, and it's a good presentation by Dr. Nitya Viramuthu. Thank you for the presentation. Congratulations. Dr. Giri, should we go on to the next presentation? I think we have crossed this time. So the next presentation is on gender inequalities in prevalence, pattern, and predictors of multimorbidity among geriatric population in rural West Bengal. And the presenter speaker is Dr. Sima Gumuthu Sambaya. Should Dr. Sambaya start the presentation to maintain time? Gender inequalities.
I request technical team to record participants. The speaker.
दो रह गए, ये चल रहा है, ये डैश करता है फिर इसके लिए ना जो
Geriatric population in rural West Bengal. Now, what is multimorbidity? Multimorbidity is defined as the coexistence of two or more chronic health illnesses or conditions in an individual. As due to significant increase in life expectancy, nowadays people live long enough to suffer from the health-related diseases or loss of function. So, because of which chronic illnesses are more prevalent in the older ages. Multimorbidity increases the risk of functional limitation, premature death, hospitalization, depression, and polymorbidity. It also worsens the quality of life and imposes a substantial economic burden on patients and overall health systems, because of which it is considered as a major concern in primary care. Actually, worldwide, health system was designed around single disease or body system. So there are many missed opportunities when a patient comes to a specialist, comes for specialist consultation. They may be missing opportunities to provide care for the coexisting conditions, because of which taking care of the multimorbidity is a big challenge nowadays. Now, why I use gender inequalities? Because when we go through the data of this chronic illnesses, we found something called as male-female health survival paradox. As females are more likely to survive more than males, and because the females are suffering from pain-related conditions like reproductive cancers, depression, whereas the males are suffering from cardiovascular disease and diabetes, like which is more often a killer type of disease. There are various factors which influence the gender-based inequalities in health. With this background, my objective of my research is to assess the burden pattern and determinants of multimorbidity among the elderly people in the rural part of West Bengal, and to find out is there any difference between the male and female gender in terms of multimorbidity. It is a community-based cross-sectional study conducted between 2017 to 2018, and study setting is Singud, the rural field practice area of AIPH Kolkata, and the study area comprises of 64 villages, among which only 6 villages were randomly chosen for study purpose, and the study population of the elderly people who are aged 60 years and above. No studies on multimorbidity from rural West Bengal. A pilot study was conducted and the prevalence was found to be 41%. Using the sample size formula Z alpha by 2 the whole squared PQ by L squared, with L being the 15% relative error, the minimum sample size was found to be 246. Probability proportional to size sampling was used to select the participants from each village. Ethical approval was obtained from the Institutional Ethics Committee and informed written consent taken from all the participants. The outcome variable of this research is the presence of multimorbidity, that is 2 or more chronic illnesses for a duration of 3 months, and the data was obtained as self-reported. And for each chronic illnesses, the question was asked whether it is affecting the day-to-day activities, and if it is affecting much or severely affecting the day-to-day activities, those chronic illnesses were taken into count. Independent variables of socio-demographic characteristics and functional status was assessed using activities of daily living and instrumental activities of daily living using CALS index questionnaire and Lawton IADL scale. And depression was assessed using questions which are framed from DSM-4 criteria used to elicit depressive symptoms in a study by Tamakoshi and Ohno. Cronbach's alpha for Bengali version was elicited to see the internal consistency. Statistical analysis was done by SPSS version 16, and chi-square test was used to find out any difference between this male and female respondents in terms of multimorbidity. And univariate multivariable logistic regression was performed to identify the factors associated with multimorbidity. So, coming to the result section, this table shows the distribution of study participants according to the self-reported chronic illnesses. Like eye problems consisting of cataract and loss of vision is the major major chronic illness, followed by the arthritis and low backache, followed by the urinary disorders. In males, eye problems are the major chronic illness, followed by the arthritis and low backache, whereas in females the major problem is arthritis and low backache, followed by the urinary disorders. This table shows there's a significant difference between males and females in terms of frequency of self-reported chronic illness. From this table we can understand females are having more number of chronic illnesses when compared to male. And this table shows univariate and multivariable logistic regression. As we can see, for both male and female, age, education status, source of income, and dependent for activities of daily living were factors which are significantly associated with the multimorbidity, whereas depression is the factor significant for female and not in males. When we go for the multivariable logistic regression, we found out age is the age remains a single factor after adjusting with other variables for both the male and female, which is associated with the multimorbidity, whereas for female additional depression is also important factor which is associated with multimorbidity. Being Negelka score 0.23, it shows that 23% of variance in multimorbidity is explained by the age factor itself in male, whereas 42% of variance in multimorbidity explained by age and depression in the females. So around 82% of the study subjects have multimorbidity with significant difference between males and females, and from this study, which is necessary for every conduct a morbidity screening at each visit when we are getting this geriatric population in OPD, and to address gender inequality, family level counseling and awareness in the community regarding health needs of elderly women, who are generally a neglected population in the society. So we have to bring more awareness regarding taking care of this elderly women, and more insight into the epidemiology of multimorbidity is necessary to upgrade our protocol or standard guidelines for management of chronic illnesses. And after this research, we try to introduce special geriatric OPD days, like in a week 2 days will be, or 1 day will be specially for geriatrics, and a chronic illness register was maintained to track down this multimorbidity burden. These are my references, and thank you.
There is no question in the chat.
Hello. Hello.
Hello.
Yes, sir. You are audible, sir. Yeah.
Hello. Can you listen me?
Yes, sir. I can hear you, sir.
You are just telling that in gender equality, depression is more in females than the males. What is the probable reason why the depression is more in females?
The more the problem with the females is like due to that mental pressure they are going through in all the domains. Like when you see they are economically dependent on others, and they are not able to fulfill their needs. Like whatever they want to get from what they want in their life, they are not able to get it from get. So they have to be dependent on others. When their wishes are not yet fulfilled, so they are into depression and loneliness, and being females are having more survival than males, so they are being more lonely.
But if you see the suicidal attempt, males are more doing suicidal as compared to females. Though the females are more depressed. In Indian culture, females are the secondary part in our Indian culture. It's a male dominancy country, right? It's a male dominancy country. So females are always neglected, or they count as a secondary part. But if you see the suicidal attempt, the males are more than the females. Then why this? Vice versa.
Sir, I prefer that from this research, I come to know that if you go through all of the data, I think the females are going through more mental distress than male, as far as I know, sir. It is my point of view.
Okay. Anyway. Good presentation. Good presentation. Okay. Thank you.
Thank you, sir. Thank you.
Can we go the next presentation?
Yeah.
Dr. Vivek Sagar.
Yes, sir.
Okay. The next topic of the presentation is the prevalence and determinants of the ADL and IADL disability among the elderly in a coastal village in Kerala, a cross-sector study, and the presenter is the Dr. Sneha Georgie. Hello.
Yeah. Yes, sir. May I request technical team?
Dr. Sneha.
Sir, can we put the video? Okay, thank you.
My study is titled Prevalence and Determinants of ADL and IADL Disability Among Elderly in a Coastal Village in Kerala, a cross-sectional study. Coming into the introduction, the extension of lifespan has led to an increase in the number of older people and an increase in the prevalence of disability in people over 60 years of age. Longer aging stages, acute illness, worsening chronic illness, and hospitalization can contribute to a decline in the ability to perform tasks necessary to live independently. One of the best ways to evaluate the health status of older adults is through functional assessment. ADL and IADL are the tools for assessing the functional status and cognitive function. ADL, which is activities of daily living, is the most appropriate instrument to assess a person's ability to perform activities of daily living independently. It mainly assesses 6 functions, which is bathing, dressing, toileting, transferring, continence, and feeding. And subjects are scored 1, which is for can do independently, 2 if they need assistance, 3 if they are completely dependent, and a score of more than 9 indicates poor ADL. IADL, which is instrumental activities of daily living, assess a more complex activities which is necessary for living in a community. So competence such as shopping, cooking, cleaning, driving or using public transport, laundry, managing finances, using telephone and handling medications are assessed here. A score of more than 12 indicates poor ADL, IADL. IADL functions usually lost before ADL function, so assessment of IADL may identify incipient decline in physical and cognitive aspect in an older adult who might otherwise appear capable and healthy. Coming into my objectives are to assess the prevalence of ADL and IADL disability among people aged 60 and older age in Kerala.
Can't hear to
The
Sneha.
objective is to find the determinants of poor ADL and IADL among the same population.
Technical team.
It's community-based cross-sectional
Dr.
study.
Dr. Vivek sir can't hear to Sneha.
Above 60 years in Alapad, in
asking the
Kerala. By sampling method, it is I've done a universal sampling because this
Rupali
study
ma'am, can you hear Dr. Sneha?
In all the wards in Alapad Panchayat. Methods, initially the
Rupali
pilot
ma'am, can you hear to Dr. Sneha?
and questionnaire was
I can't
pre-tested.
hear to Dr. Sneha.
Training of ASHA workers were
Something,
done.
I
Then the
think,
questionnaire was administered to all
has
the
it been muted?
by the ASHA workers. Then data was tabulated and analyzed.
Sneha itself.
Actually, this is a part of a bigger project named Transforming Alapad,
hear.
which aimed to develop an age-friendly panchayat with a special consideration for the elderly population. And the team consisted of my institution together with Alapad local self-government and many other voluntary groups. Coming into the results of my study, the age group 60 to 69 people, 61% of the population were in the age group of 60 to 69 and 52% of population were female with a total population of 2,768 with a sex ratio
Sneha ka mute ho gaya. Sneha itself is muted.
17%
Yes, I am here, sir.
and 39%
Okay.
IADL.
Now start.
Coming into the determinants of poor activities of daily living score, you can see that age, bedridden, and currently in age of hypertension of the major children. Actually, all the factors were actually high-score test was done, and all the significant factors were taken. We did a linear regression test, and these factors came out as significant.
Rupali ma'am, can you hear the presentation of Dr. Sneha?
7.9 and coming into currently in page job, you can see that it has a registered odds ratio of 0.302 with 95% confidence interval of 0.196 to 0.46, which has got a very protective. And hypertension and psychiatric illness also has a very significant effect on. Coming into IADL, we can see that age, education, color of ration card, any pension benefits currently in paid job, alcohol, smoking, and psychiatric illness are the major determining factors. With age, more than 80 had a adjusted odds ratio of 11.4. Then coming into any pension benefits and currently in paid job, you can see that looking into the adjusted odds ratio, we can see that it has got a very protective effect on IADL. So in conclusion, a huge proportion of elderly population is found to have poor ADL and IADL scores and thus poor quality of life. As we can see that in IADL, a huge proportion, that is around 39% had poor IADL. So rehabilitating elderly with small income generating jobs and providing elderly pensions could bring a huge difference in their lives, and giving adequate care in treating non-communicable diseases such as hypertension, diabetes, and mental health. Giving importance to mental health is also important in avoiding poor ADL and IADL. So urgent and preemptive measures are needed for the state or local self-governments to address the issues of aging and thus become closer to the goal of healthy aging. So these are the proposed interventions to promote healthy aging, to provide minimum level of care to all the individuals above 70 years, individual care plan in a phased manner, initially to be given for more than 85 years of age, then providing services for people with reduced mobility, strengthening the existing meal plan, then exclusive program for elderly women, developing neighbor groups, then starting daycare homes for elderly. So these should be the goal of every local self-government. Thank you.
Hello. A good relevant presentation on prevalence and determinants of ADL and IADL disability among elderly Kerala. It was a cross-sectional study. Are there any questions in the question box?
No, ma'am, there is no question.
Mr. Vivek Sagar.
No,
I don't know, people are not finding geriatrics important, but we are all going towards the geriatric age.
Yes.
And, since we have time, we can also, because I was expecting 6 presenters, but I have 5 presenters in the list, and we have still time because Dr. Sneha
Yes, ma'am.
giving time up to 12:15, and it's just
Okay.
we still have 5-6 minutes. Would Dr. Giri, Dr. Konika, Dr. Vivek Sagar would like to comment on this presentation of Sneha, because we were rushing in the first 2-3 presentations. But now I see, since we have 5 presentations with 10 minutes and our time is from 11:30 to 12:30, we can go a little bit relaxed, not pushing for fast forward. So Dr. Sneha,
Yes, ma'am.
where did you do the study?
Actually, we did it in the year 2019, before the start of COVID. With the onset of COVID, we had to stop the study, but we could collect we could cover almost all the wards in that village by that time. So the study was almost over, but the interventions were we were not able to fully implement all the interventions we were planning to do.
Okay.
Yes, ma'am.
Are
So
you
actually,
planning
this study
to
was
continue the study?
Yes, ma'am. Yes, ma'am. We are planning.
You presented a
Right now,
part
we are
of
in
it
a
today.
different. Yes, ma'am. I have taken a part of the study actually. It is we have taken the data from almost 2,700 people in that village. Almost all the elderly we were able to cover all the elderly of that village. So actually, this was a project which was done with the help of many organizations. We were a part of the team, and this was actually to make the village a better and be more friendly to elderly. So that was the main aim of this project, actually.
I think Kerala and Assam, there are a lot of similarities in the way of
Oh,
living.
ma'am, I'm not able to hear you, ma'am.
Am I muted? Please, Dr. Vivek Sagar, unmute me.
Your voice is not audible actually.
Should I speak louder or I am muted? Can you hear me, Dr. Sneha?
Ma'am, it is very feeble. I can make out, but it is very feeble. The voice is very feeble.
Can you hear me now, Sneha?
Yeah, it's okay, ma'am. Now it's okay.
Okay. So I was just commenting, I have visited Kerala and
Okay.
I have Kochi and other places, and the living and lifestyle of people in Kerala and Assam are quite similar. We are present.
Ma'am, please remove the cord of the headphones and insert it again. I think that would help.
Okay. Oh, without this. Am I audible without the cord?
Yes, ma'am.
Yes,
Perfect.
ma'am. Yes, ma'am.
Then I'll not
Perfect.
use this.
Okay, ma'am.
Can you hear me?
Yes, ma'am. It's perfect.
Yes.
I was just wanted to ask Dr. Sneha,
Yes,
like
ma'am.
generally, you people in Kerala live in joint families or nuclear families?
Almost 3-generation families, actually. The
That's very
parents,
good.
son, and with their grandchildren. It's almost like that. Or nuclear. Joint is there, but it is very less.
So it's a good support, a good
Yes,
family
yes.
support. But I have seen in many families, I know living in a 3-4 generation family also, the elderly feel isolated and depressed. Living within a joint family, they live in their own room. People don't go and talk to them. Just provide the food, or maybe they have to take their own food. Does it happen? In your study, did you notice this also? In spite of
It is
living in
there
a
in some.
joint family, you are lonely and
Yes, it is
isolated.
there.
Does it happen?
It has happened, but it is not in a huge scale. But it is there in some families. It is there.
Is elderly abuse common in your
Elderly
study?
abuse is not common. No, I have not found much cases here. Maybe in remote few, maybe less than 10 or something. But abuse is not that common here.
Okay, then it's good. Then I think, Dr. Giri, can we go for the next presentation? I think that will be the last presentation.
Yes. So next.
Sneha, I was expecting 6 oral presentation. I think the
Okay.
last presentation is on validity of KICON checklist for evaluating frailty status, a cross-sectional study among elderly in a rural community of West Bengal. And the presenter is Dr.
Suryadipta Ghosh.
Yes, ma'am.
He has been given a time of 12:15 to 12:25, 10 minutes, 7 minutes, followed by discussions.
Yes, ma'am.
Should we continue and ask Dr. Suryadipta Ghosh to make his presentation?
Yes, ma'am.
I hope I'm audible now.
Yes, ma'am. Perfect.
Better not to use the earphone then.
Going to present my study is on validity of the checklist for evaluating frailty status, a cross-sectional study among the elderly in a rural community of West Bengal. In India, elderly population is fast growing with 7.4% elderly person according to population census 2011. So there is an emerging need to pay greater attention to aging related issues and to promote the holistic policies and programs for dealing with the aging society. Frailty is one of the most challenging aspects of population aging due to its association with increased risk of poor physical and mental outcome. Frailty is a multidimensional geriatric syndrome that increases with age and it leads to high risk for adverse health outcomes such as falls, hospitalization and mortality. Thus, early detection and possible prevention of frailty will help in improving the quality of life of elderly people and decreasing the social, psychological and economic burden of their families and caregivers. Although there are many scales for diagnosis of frailty, easy to apply frailty scales are rare and which these are required for early detection. Keown checklist is one of such scales which can be used by any healthcare worker. The objective of our study is to estimate the proportion of frailty by Fried criteria among the elderly population in a rural area of West Bengal, to measure the validity of a Bengali version of the KCL in determining the frailty defined by Fried criteria among the study population, and to find out the cutoff values for frailty and pre-frailty in KCL according to Fried frailty phenotype. This was an observational community-based cross-sectional study took place in rural field practice area of All India Institute of Hygiene and Public Health, Singur, in Hooghly district, West Bengal from November 2019 to January 2020 among elderly people aged 60 years and above residing permanently at the rural field practice area of AIIH and PH. All the individuals who are aged 60 years and above and are resident of that area for at least 1 year were included in our study, and those who did not give informed written consent or critically ill at the time of study or had any history of major psychiatric or neurological illness were excluded from the study. According to Buderer's formula, the sample size was calculated based on a study which was in Pune. Thus, anticipated sensitivity and specificity was taken as 90% each. So there are two different formulas by which the two different type of sample size calculated, that is 133 and 47. As 133 is greater than 47, the minimum sample size is taken as 133. And after considering a design effect of 1.5 as simple random sampling was not possible, the sample size came to 200. The number of clusters, that is villages, was decided to be 20. Cluster sampling was done. 20 clusters were selected from 64 villages under Singur RHUTC. All the population available for villages were listed. From that, cumulative population of each village was calculated. Then probability proportional to size method was used to select 20 villages, and from each village 10 elderly were taken. Our study tool were Fried frailty phenotype. The translated Bengali version had Cronbach's alpha of 0.787 and Keown checklist Bengali version, the Cronbach's alpha was 0.851 for the translated version. After taking institutional ethics committee approval, home visit was done and informed written consent was taken from participant. After that, both FFP and KCL were applied by the investigator to the elderlies. In FFP, that is in Fried frailty phenotype, there are 5 scores, 0 to 5, 0 for robust, 1 to 2 for pre-frail and greater than equal to 3 for frail. So according to these scores, the cutoff in KCL was determined for pre-frail and frail. Data was analyzed using MS Excel 2019 and SPSS 16 software. Mean age of the study participants was 67.6%. More the half of them were females, where majority of them were Hindu, and mean years of schooling was 4.05 years with 37.8% illiteracy. Proportion of frailty was revealed by Fried frailty phenotype criteria, that is 28.5% were frail and 36.5% were pre-frail. When we look to check the validity of Pihon checklist from the frailty phenotype, the area under ROC curve was 0.899 for frail, which is depicted from this figure, and 0.902 for pre-frail, which can be seen from this figure. The cutoff value in KCL is for frailty is 7 with an anticipated sensitivity of 80.7% and specificity of 86.7%, and for pre-frailty the cutoff value is 4 with 84.6% sensitivity and 80% specificity. It was also worthy noted that there is a strong positive correlation, that is 0.783 between frailty phenotype score and KCL score. So when the current study compared with different studies in different part of the world, in a study by Iapsmcon et al. At Turkey, they found the frailty cutoff is at 9 and pre-frailty is same as ours, like 5. Satake et al. In Japan found frailty cutoff at 7 like our study, and they found pre-frailty cutoff at 3. Seo Sampaio et al. In Brazil, they found the frailty cutoff at 6. So though FFP is the gold standard for detecting frailty, it needs expertise for its execution. Here comes KCL, which can be easily used in community setup by grassroots level healthcare workers. Therefore, use of this tool is strongly recommended by the researcher for rapid and easy screening of frailty. In the long run, it will help in building up of appropriate, effective and timely intervention for the prevention and delaying of frailty. And at the beginning of the decade of healthy aging, that is 2020 to 2030, according to WHO, this study might provide a small contribution for bigger good of older people. These are my references. Thank you.
Okay, thank you, Dr. Suryadipta Ghosh, for the presentation. And are there any questions in the box?
No, ma'am, there is no question in the box.
People are not interested in geriatrics, so everybody is thinking we'll be young forever and ever. But I think we'll also go to the geriatric group. Yeah, because we have 8 halls. Maybe there are more interesting talks in the other halls, or maybe people are recording to go through later. But anyway, these were very good presentations, oral presentations. Each one, Dr. Konika Gupta, Vidya Viramuthu, Dr. Simbia, Dr. Sneha, and Dr. Suryadipta Ghosh from different parts of the country. And geriatric is an upcoming topic and subject because the elderly people are increasing. Increasing in our place. Initially, Italy and Japan have the highest elderly population. And I think there are so many things to learn about their lifestyle. People, especially the elderly people living in Japan, where more than 40,000 population are over 100 plus centenarians. They're very active. I was lucky to visit Japan on 2-3 occasions. I was surprised that 90 plus people used to work and they would feel ashamed to stay at home and not work. But we retire at 58 years, 60 years. I don't think we should retire from life. We should be active and keep on, on different jobs. I remember one 90 plus person cleaning the park in Kyoto, in Japan, Kinkakuji. And I was so surprised. My professor who was accompanying me, I asked her, please ask him why he's still working when he's 90 plus. He said he doesn't like to sit home doing nothing and coming. Am I audible? Am I
Yes,
audible?
ma'am. Yes, ma'am. Yes, ma'am. Yes.
Okay.
Perfect.
So my visit to think we should indeed take up these things about re-aging, home support, family support, and now these old age homes are increasing. But if within the family, elderly person can live happily, which does not happen in most homes, mainly due to property. When there are 2-3 children, they fight for the property. I have even heard children snatching the pensioners' ATM card to be demanding. So these things happen. And it depends upon upbringing from region to region, the culture of different parts regarding respect for the elderly. And I think this is the since certificate of the healthy aging, government is having these policies and programs, but we as individuals, I think we should change our mindset to respect the elderly, because one day we will also be in that group, physically helpless and depending on others. Dr. Giri, would you like to put your comments regarding the presentations?
Yes, yes, ma'am. Yes, ma'am. There is there is one question for audience for the Dr. Ghosh.
Yes, sir.
How
Yes, sir.
frailty can measure using a KC? How frailty can measure using KCL?
Using KCL.
Is it a respondent driver question?
Actually, sir, it is a.
Can you hear me?
Yes, sir. Yes, sir. Sir, am I audible?
How frailty can how frailty can measure using KCL?
Yes,
is it
sir.
a respondent question?
Yes,
driver
sir.
questionnaire?
Yes, sir. If the respondents are literate enough, they can fill it themselves, or a simple grass level healthcare worker can administer it. It is a 25. It is a sum of 25 questions, and ultimately upon this, that decide if the person is frail or not frail. Till now, there is no cutoff of KCL. Because of that, we are taking frailty phenotype as a gold standard, and upon that figure, we try to make the cutoff level in KCL. In KCL is 7
Then
out of
how
25.
the level
That
of
is
impairment was judged?
That is, sir, I am saying that in frailty phenotype, we are taking as gold standard of measuring frailty that has 5 things, and of them greater than or equal to 3, that persons are taking as frail, and 1 to 2 pre-frail, and the 0 who are 0, they are non-frail or robust. According to that, we set the cutoff in KCL. That is, we found that greater than 7 in KCL will be called frail, and 4 to 6 rather, that is called pre-frail, and less than 4 will be normal or non-frail rather.
Dr. Ghosh, what is this Bengali version?
Yes, ma'am.
Did you make it innovated, or is it available?
No, ma'am. No, ma'am. It is available in English. I am translated it in my mother language, that is Bengali, and thereafter pretest it and measuring the Cronbach's alpha, which is 0.851, and thereafter I only administer it.
There is a question forwarded by our technical team. How the level of impairment was judged?
Level of impairment was judged means, madam, according to I am just checking the validity of the instrument. There is no fixed cutoff in that Kihon checklist. That's why I have to compare this with a gold standard, that is frailty phenotype, and I found that whoever scores greater than 7 in KCL, that is Kihon checklist, will be considered as frail.
There are no question from the chat list or question answer side. So,
should I do the conclusion, or?
Yes, ma'am.
So these 5 presentations on geriatric health was very interesting, and all the presenters, Dr. Kanika Gupta, Dr. Nithya, Dr. Simbia, Dr. Sneha Georgie, Dr. Surya, Dipta Ghosh, all the topics were interesting, and all the studies done were interesting. And I think geriatrics is a very upcoming topic, and there should be more studies, cross-sectional studies in the community, because this population of geriatrics is increasing in the community in India also, where it was 6-7%, but now it is coming up, and probably maybe for healthy aging, we need to, government will have to put forward these policies, programs, but we at individual levels, at household levels, at community levels, we have to practice compassion towards the elderly and not ill-treat them, abuse them, which is so common. Children throwing out their aged parents on the roads because they cannot, tend to them, or they think they're a burden to the family. So these things, I think this depends on family upbringing and background. and also the culture present in the community, and also the economy. If the economy is good, but still, even if a person is earning a lot of money, the greed is unlimited. We have seen children fighting for the parents' properties, fighting for the parents' money, even the poor pension they get, the petty pension they get from the government if they were service holders, that too is snatched away by greedy children. So these things are so common and it should not happen. And we as teachers in a medical college or parents in a family, we should, I think, inculcate these habits of compassion towards the elderly, respect towards the elderly. I hope everybody agrees with me so that healthy aging will actually occur and we really will have a healthy aging in the next decade. Because I fear I am going towards geriatric group. I don't know what will be my condition at the hands of society or my relatives or my children. So I hope that all of us will be able to live with respect during our twilight years.
Yes.
So should we conclude? It's time, just 1-2 minutes. Or if Dr. Vivek or anybody wants to say a few words, we still have 2 minutes to end the session.
Dr. Giri, do you want to say?
Yes, sir. Yes. All the presentation, whatever the given by the presenter Konika Gupta, Nithya, Dr. Sembia, Dr. Sneha, and Dr. Ghosh, all presentations was very good, very nice. My suggestion to all the my suggestion to all the presenter, they are doing all the cross-sector study. But in future, if you think this is a qualitative study or sometimes an interventional study, that will be the better for the geriatric health. Because the geriatric health nowadays in upcoming branch, in our institute, there is a geriatric department and there is a special head of the department for geriatric department. So this is upcoming, ma'am has already told, health aging is a nature in future. So it's already 7.4% nowadays, but it goes going up in future. Now this India is now a youth, but aging also geriatric problem is also very, very important. And they take care of all these things. So once again, I congratulate all the presenters who have presented very nicely.
Thank you.
Yeah. Now.
Thank you.
Thank you, ma'am.
So thanks. And thanks to the my chairperson with my chairperson Dr. Rupali Bharu ma'am also, and Dr. Vivek Sagar.
Yeah. So in the end,
Thank you.
I would like to make a quick vote of thanks to our chairpersons and also to speakers and delegates, and also to our head of department, Professor Amarjeet sir, who is also listening along and he supported us, and also to our team who is backing us and technical support. Thank you very much. With this, we close this session and move to next session. Thank you.
Thank you. Thank you.
Thank you.
Thank you. Thank you, ma'am. Thank you.
Thank you all. पटकन घे.
To just mute. Dr. Giri, can you 2 minutes?
हेलो. हाँ सर, सागर सर.
Can you
बोलिए सागर सर. Hello.
I want to start next session, Dr. Giri. I request you to just mute your.
Okay. Thank you.
Hello. So we would request all participants to have a photo together with the chairs, and we thank the chairs for honoring us with their esteemed presence. So can we have all the participants open up their video cams and show us a thumbs up? Everyone, please open up your video cameras. Okay. I guess we have thinned out our attendance. Anyhow, thank you to all the attendees and extremely grateful to our chairs, Madam Rupali and Dr. Pushottam sir. Thank you, ma'am. Thank you.
Bhuti, Arunima, you have conducted and coordinated well. And Mr.
Thank you,
Vivek
madam.
Shagar also. Thank you so much for the good coordination. Thank you so much.
Vivek sir, Vivek sir, Vivek sir, Vivek sir.
Yes, sir. Yes, Dr. Giri.
Our both the shirting are same, huh? Both shirting.
Blue color uniform for geriatrics.
It's a coincidence. Coincidentally, we are not decided. It's coincidentally.
No, good. And even another blue shirt, third one. Yes, good. Maybe this is the color for geriatrics. A turban, blue turban also.
विवेक को जेनेटिक्स नहीं कहना ना आपको डॉक्टर
Blue turban, blue shirts.
You can call me genetic but not Dr. Giri or Vivek.
We would request everybody to have another photo because our HOD sir, Dr. Amarjeet is here. So let us have a photograph again for this precious moment.
So nice to see Dr. Amarjeet Singh on the screen. All this time, I don't know, maybe you were hidden somewhere. So nice to meet you, sir. And today is World Happiness Day. Let's all be happy and smile.
Thank you. सर मैडम ये मुझे इस बार इतना अच्छा लग रहा है ना कि वर्चुअल में चेयरपर्सन इतना बढ़िया मैनेज कर रहे हैं और बहुत इट इज वेरी नाइस टू सी ऑल ऑफ यू हेल्पिंग अस
थैंक यू
नहीं सर अभी डिजिटल एरा चालू हो गया सर मैं भी स्टेट कॉन्फ्रेंस ले रहा हूँ 3rd and 4th April
and thank you for conducting it so well.
I am conducting also hosting the Maharashtra State Conference on 3rd and 4th April.
Dr. Giri, we are, I think next session is, I think people are waiting for next session.
Yes. Thank you so much. And I
Thank you, sir.
I enjoyed
Amarjeet Singh, sir,
session.
thank you very much.
Thank you.
So next session is...
Amarjeet Singh, sir, good afternoon. Good afternoon, sir. I'm Dr. Sangeeta from Salem. We admitted Dalian. Sir, voice is kindly.
I remember you.
Yes, sir. Thank you very much, sir, for giving the opportunity.
Now I think my voice problem. Hello. Yeah. Now I welcome you all to other session of oral presentation that is on digital health, and it is my honor to welcome Dr. Anshu Mittal, Professor, Head of Community Medicine, MM Institute of Medical Sciences and Research, Maulana, Ambala. Her area of expertise is nutritional deficiency diseases and also geriatric health. And her interest is to work on quality of life in cancer patients and factors influencing the same. She has more than 40 national and international publications, and she had made important contribution towards working for more than 15 years in the field and actively involved in teaching and training and liaison with government agencies for national health programs, and latest being actively involved in surveillance activities pertaining to COVID-19, jointly working with other departments to have deeper insight into the epidemiology of disease, and finally, now nodal officer for COVID-19 vaccine. In addition to that, I also welcome Dr. Rajesh Kumar Kundru, Professor, Department of Community Medicine, Pondicherry, Institute of Medical Sciences. His area of interest is non-communicable diseases and mental health. He authored 3 chapters in IAPSM textbook of community medicine, total publications of 17, and his area of interest is he is in process of writing book on clinico-social case discussions. With these short descriptions and introduction, I would like to invite our chairs, to take over the session, Dr. Anshu Mittal and Dr. Rajesh Kumar.
Thank you, Dr. Vivek. Thank you for giving us this opportunity to chair such a wonderful session on digital health. And a very good afternoon to Madam Dr. Anshu Goyal ma'am and all the presenters. Today we have totally 6 presentations here. I request ma'am to tell a few words and then we will go ahead with the presentation.
Good afternoon, everyone. Thank you, Dr. Vivek, for introducing me to the panel of presenters and chairpersons. And good afternoon, Dr. Amarjeet. Sir, we have been your students and it is a great honor to be on this platform on the other side of the table, I would say. Earlier, we used to be presenter, now we are on the other side of the presentation. Thank you, and I'm very thankful for this thing that you have given me this opportunity to, you can say, judge the presentations on this upcoming topic, which gained much importance during this period of COVID-19. Earlier, rather, there used to be so many hurdles in this field that teleconsultation is either valid or not, but now it became a need of the hour that we had no other option. So let us see that what people have done in this field and how much success we have taken up in this 1 year. And what else we can do. Thank you, sir. And looking forward to the presentations.
Okay, then we will start with the first presentation by Dr. Rabiha Naz.
Request technical team to play the video recording. Maybe it is taking time. I request again technical team to play recording.
Good morning all. I am Dr. Rabiha Naz from the Department of Community Medicine, Osmania Medical College, Hyderabad, Telangana. My topic is on a cross-sectional study to assess patient satisfaction following teleconsultation services in Hyderabad, Telangana. Introduction. Telemedicine means healing at a distance. It signifies the use of information, communication and technology to improve patient outcome by increasing access to care and medical information. The purpose of telemedicine is to provide clinical support. It is intended to overcome geographical barriers. Its goal is to improve health outcome. According to WHO, telemedicine is the delivery of healthcare services where distance is a critical factor by all healthcare professionals using information, communication and technology for the exchange of valid information for diagnosis, treatment and prevention of disease and injuries, and for continuing education of healthcare providers, all in the interest of advancing healthcare of the individuals and their communities. Now coming to objectives of the study. The objectives are to assess patient satisfaction who avail telemedicine consultation and to determine the factors associated with it. Materials and methods. This is a cross-sectional study which is done in Hyderabad, Telangana for a period of 1 month. People who have used telemedicine services in the past 1 month are our study population. 105 is our sample size and the sampling method uses convenient sampling. Inclusion criteria. People who gave consent and people who availed telemedicine consultation services in the past 1 month were included in the study. People who never used teleconsultation were excluded from the study. Data was collected by using Google Forms which were sent through WhatsApp, and data entry and analysis were done in MS Excel and OpenFP Info 7. Now coming to the results. It is seen that telemedicine services are mostly used in the age group of 20 to 30 years, which was about 62.3%. And elderly population was the least who used telemedicine services. Females were using telemedicine services more when compared to the males, which was around 68%. The most widely used specialty turned out to be gynecology, which was 47%, followed by general medicine, which was 30%. Video calling was the mostly used modality used for telemedicine services, which was around 61% when compared to the voice call. 81% of the people never used teleconsultation before COVID pandemic. 81% of the people were satisfied with the duration spent with the doctor, and 92% of the people were satisfied with the explanation of their condition by the doctor. 89% of the people were satisfied with the explanation of their treatment by the doctor, and 66% of the people were overall satisfied with the teleconsultation session. Now coming to visual quality, voice quality, and personal comfort. Only 2% of the people were not satisfied with their visual quality, and 1% of the people were not satisfied with the voice quality. 66.3% of the people were comfortable using teleconsultation services. Now, the factors associated with satisfaction are improved self-care for minor ailments, which was about 31.7%, and 25% of the people found teleconsultations time-saving, and 13.5% of the people said it reduces the number of visits to hospital. Factors associated with dissatisfaction. Examination by the doctor is limited, electronic glitches and expensive. Coming to limitations. The study findings could not be generalized to the whole population as it covers only urban population, and also the sample size is small. Conclusion. Majority of the patients were satisfied with teleconsultation. The present study highlighted the patient's viewpoint with teleconsultation and telemedicine. The COVID-19 pandemic has helped us to unravel the hidden potential of teleconsultation and its future use to reach areas with poor access to healthcare services. Finally, I conclude by saying that our present study goes in line with the current theme of the conference, that is, public health in 21st century, current challenges and future opportunities. Even though telemedicine has been in vogue for the past 2 decades, its potential is not fully utilized. This COVID pandemic has unknowingly helped us to realize the importance of telemedicine and made its usage widespread in just 1 year. With a new initiative of Digital India and National Digital Health Mission as envisaged by our Honorable Prime Minister Narendra Modi, telemedicine is the way forward for future to provide universal health coverage for every citizen of the country. These are my references. Thank you.
I request chairs and to ask any question because there is no question from the chat box or question answer chat box.
Yeah. Since there are no questions, I would like to ask one question to the presenter, Dr. Rabiha. You said like it is, you try to assess the patient satisfaction. May I know what kind of questionnaire have you used? Because satisfaction is mainly subjective. So have you used any validated questionnaire, or you have designed your questionnaire on your own and you have used it among your study participants? Can you please give some kind of clarity on this?
Thank you for the question, sir. Good afternoon, all. We have designated our own questionnaire, but I have used a Likert scale for designing my questionnaire. Like Likert scale have components like I strongly disagree, agree, I don't agree. So by using that components, I have designed my own questionnaire.
Dr. Rabia, please switch on your video.
Okay, thank you. I don't have any more questions.
Dr. Rabia, just continuing with Dr. Rajesh's question that whether this questionnaire was validated or not. Am I audible?
Sorry.
Am I audible?
Yes, ma'am, you're audible.
Yeah. So my question is that as sir has asked that you have used some questionnaire regarding satisfactory to assess the satisfaction of the patient. So whether this questionnaire as it is designed, whether you have got it validated from somebody or it is
Yeah, it's been validated by my professor from my medical college, Osmania Medical College.
Okay. Secondly, one more point I want to highlight, you can just improve upon. You said inclusion criteria is who are using it within 1 month or so, and
Yes.
exclusion is who have never used. What about those who have used it, using it for 2 months or 3 months or something? What about those users?
We eliminated
And why
them.
it was only 1 month?
Yeah, because we were thinking of bias, like they won't be remembering the event. So we just eliminated them. Like about their experiences, they may not be remembering it much. The users who are using the consultation services. Recalling, it would be difficult for people to recall if it's been 3 months or something like that. So we just went for 1 month.
Not very valid, you can say, but let it be, because these are the initial studies in this field. Secondly, you have told us in results that mostly users are in the younger age group. So how do you see that, because majority of the, you can say, morbidity burden is going to come from the higher age groups, then what do you see that, what is the prospects of using digital health or having digital health in future? Rather, the age group which you have shown, 20 to 30, they are comparatively healthier population.
Yeah.
So that means even if we are going to popularize this digital health, we are not going to have much of a, you can say, if we go by whole user pattern, because majority of the users, either they are, you can say, in the age group above 40 or 50 for chronic diseases. Majority, you can say, are you getting my point?
Yes, ma'am.
So somewhere your study is
no, in my study, what happened is the majority users turned out to be females in gynecology specialty. So the
that
age
is
group
okay.
turned out to be 20 to 30. It happened like that. Many were females using gynecology specialty. So in this particular study, it turned
I
out.
will take it as a pilot study, and I would wish that you extend this study to a wider sample size
Yeah.
and everything, so
Yeah,
that we
we are
can have
planning.
a, you can say, universally acceptable results.
Yeah,
All
we
the
are
best.
planning this study on a wide scale for rural as well as urban.
Okay. Thank you, Dr. Rabia.
Thank you.
Maybe we can move to next presentation. So may I request Chair to introduce.
The next presentation is by Dr. Sangeeta. A study on utilization of artificial intelligence in managing respiratory tract diseases in tertiary healthcare setting in Salem, Tamil Nadu. So may I call upon Dr. Sangeeta to present her study or her video, please.
May I request technical team to play video for the same? Technical team, can you play video for the presentation of Dr. S. Sangeeta?
Good morning, everybody. I'm Dr. S. Sangeeta, Professor and Head, Department of Community Medicine, VMKV Medical College and Hospitals, Salem, Tamil Nadu. My abstract ID is S1846. The title of my presentation is An Awareness Study on Utilization of Artificial Intelligence in Managing Respiratory Tract Diseases in Tertiary Healthcare Setting in Salem, Tamil Nadu. My co-investigator is Dr. J. Prabhakaran, Assistant Professor, Department of Community Medicine, Mother Medical College, Chennai. Health sector is supported by many technological innovations like artificial intelligence nowadays. AI is a simulation of human intelligence in machines that are programmed to think like humans and mimic their actions, which uses machine and deep learning tools and algorithms. We need research to identify the themes of algorithmic bias and to develop methods for smooth rollout of AI in the health sector. AI is used in a variety of healthcare domains and research purposes, including detection of disease, management of chronic conditions, delivery of health services, drug discovery, etc. The application of AI in respiratory medicine have been increasing in different pathways of patient care today, but there are challenges prevailing in its implementation. The objectives of my study are to study the various opportunities and challenges in adopting AI in managing respiratory tract diseases in tertiary care institutes of Salem, Tamil Nadu, and to suggest the solutions to use AI generously in healthcare settings. Material and methods. It is a cross-sectional study with mixed methods of qualitative and quantitative methods. It was conducted over 3 months from October to December 2020. The study was conducted in 2 medical college and hospital in Salem, one in Vinayaka Mission Medical College, the other in Government Mohan Kumaramangalam Medical College. 54 medical doctors for quantitative study were selected through convenient sampling method. 2 focus group discussions were conducted based on saturation converge method. The method of data collection were 2 FGDs were conducted with 9 doctors each using a protocol. The questionnaire for the quantitative study was developed and validated the scales. The responses were collected both online and offline mode. Individual consent form was made for quantitative study and group consent for qualitative study. Analysis, we used descriptive statistical measures, and ethics institutional ethical committee approval was obtained. Coming to the results, the mean age of participants was 33 years. Majority of participants were from general medicine, 62%. Males outnumbered the females with 74%. Out of 54 doctors who responded, 58% had heard about artificial intelligence. The sources of knowing AI was from internet 50% and from conference and seminars 28%. Table 1 shows perceptions of AI among the participants. In average, 70% responded positively for AI, while 22% are undecided whether AI tool helps in clinical decision making faster, whether AI overcomes the limitation of human intelligence, AI reduces the healthcare cost. Coming to the table 2, showing the advantages and disadvantages of using AI. In overall, 92% had agreed that AI can be used generally, which was found to be statistically significant, that AI can speed up the process of patient care, AI can deliver clinically relevant vast amounts of high quality data in real time, AI can help in reducing the number of medical errors, and it has no space or time constraint. Table 3 shows the application of AI in healthcare and respiratory medicine. In overall, 88.5% had agreed that AI can be useful in healthcare and 90% in respiratory care. Coming to the table 4 showing the challenges in implementing AI and overcoming it, it was found that 61% had agreed that there are challenges in implementing AI, like issues with the usability or practical aspects of technology, a research that would be needed to address the uncertainties, the criteria to assess such tools are not developed, which was found to be statistically significant. Coming to the implications, despite the challenges, AI might support the clinical decision in areas such as interpreting the variations in pulmonary function test scores, analyzing the images from X-rays, CT scans, and bronchoscopy, and analyzing the breath sounds can help the chest physician. Multiple algorithms for each functional population are some of the challenges. By adding AI to imaging devices, the clinician may be able to make the diagnosis faster and with more accuracy. AI can have a powerful impact on clinician productivity. Coming to the conclusion and recommendation, the use of AI is advantageous in respiratory care, but certain level of resistance is prevailing among healthcare providers and limited availability of tools or algorithm for hospitals. So it is recommended that we have a small-scale algorithm for respiratory diseases can be developed with multidisciplinary participatory mode and implemented in hospitals after sensitizing the healthcare providers. So these are my few references. So this project was funded by the TB Association of India short-term research project with the financial assistance scheme of 2020 and 21. I would like to thank the organizers for giving me this opportunity for this presentation in this IAPSMcon 21. Thank you.
There is no question in the chat box for the time being. So I request chair to ask questions or anyone in the audience.
Okay. First of all, I would like to congratulate Dr. S. Sangeeta for doing research on such a recent topic, which is very new for all of us. We heard about artificial intelligence only in some Hollywood movies, but nowadays we are maybe in near future we will be using it in treating the patients also in healthcare setup. Congratulations, madam, for presenting this topic to all the participants of Iapsm conference 2021. Okay. From my side, only thing is you have assessed the mainly the perceptions among the healthcare professionals about the utilization of this artificial intelligence. Did you get any information about the experiences of those doctors who are using this artificial intelligence in one way or the other?
Yes, sir. Good afternoon, sir. Good afternoon, Dr. Rajesh Kumar, sir, and Dr. Anshu Mittal, ma'am. And at the outset, I would like to thank the organizers for giving me the opportunity for this presentation, as well as Dr. Amarjit Singh and Dr. J.S. Thakur, sir. Well, sir, your question is well taken, that we had conducted an awareness study here, and with the focus group discussions which we did discuss about the about their perceptions and challenges, and we had actually asked whether they were using, but there are limited number of AI being used today in the healthcare, and because of the corona pandemic itself only, we really thought about that whether in the respiratory diseases it can be used and whether the doctors are there, whether they're using it. Right now, only in Chennai for the tuberculosis X-ray AI is used by some Pune-based company. They've started that. So the doctors there, they have started. But now our sample was included only from Salem. So we did not get the people who are using AI for respiratory care, sir.
Okay, thank you.
Thank you, sir. Thank you.
Nice presentation, Dr. Sangeeta. And thank you for
madam.
giving us some insight into the, as sir said, new topic.
I'm sorry, I think there was disturbance in the network, right?
You are not able to hear. You are not able to hear me?
Now I can hear, but slides presentation, were you able to see clearly?
Yeah. That was that was there. No issues.
Okay.
Actually, I wanted to ask that, as you have mentioned that the median age is 33 years or so. That was your result. So what is the take of the senior faculty on use of AI? Any special comments? Because actually, 33-year-old is a senior resident, or you can say new in the field. So those who are experienced, whether they are willing to use or how much difficulty they feel. You have conducted some focus group discussions and everything. So what is the take of the senior faculty on that?
Ma'am, actually, majority were there from the junior faculty only, because only those who gave the consent for FGD and all only we were participated in the quantitative study. Now, because of the corona pandemic, FGD, they had to come for the live discussion. So they were hesitant, senior doctors were hesitant to come to the group discussion. So that's why we participated. We mainly took the juniors, and then we went to the questionnaire to undertake their study. Thank you. Yes, sir. Yes, sir. Thank you very much, sir, for me asking.
Let me, Dr. Sangeeta and Dr. Anshu, we are doing 2 or 3 projects on AI in PGI. So I am counted in as a senior faculty. So we are very much for AI. Already we have written chapters, papers, and 2 or 3 projects on AI. So we are with it.
Okay.
And a good topic, Dr. Sangeeta.
We did not have the seniors, sir, in our group. That's all. In our study.
Thank you, Dr. Sangeeta.
Thank you, ma'am. Thank you. Thank you, sir. Thank you. Sir. Nice meeting you, sir. Amarjit Singh, sir.
Maybe we can proceed to next presentation now.
So next presentation is by Dr. Dharamjeet Faujdar. Is it available? Should I proceed?
Yeah.
The topic is assessment of digital health impact on primary healthcare services, a mixed method study.
So I request technical staff to play the video.
Good morning, everyone. I'm Dr. Dharamjit Singh Faujdar from Armed Forces Medical College, Pune. I'll be presenting my paper titled Assessment of Digital Health Impact on Primary Healthcare Services, a Mixed Method Study. My co-authors were Dr. Tarundeep, Dr. Manmeet, Dr. Sandeep Sahay, and Dr. Rajesh Kumar. Improving accessibility, affordability, and quality of health lies at the heart of primary healthcare. It is hoped that digital health innovations can strengthen and redesign primary healthcare. However, there is need to explore impact of digital health on primary healthcare and perception among user and clientele for its effectiveness. My study objectives were to assess the impact of digital health on healthcare services in primary healthcare and also to understand user and clientele perspective of digital health implementation. The study was conducted in an urban area of a union territory in northern India. A digital health intervention was developed which was primarily aimed at fulfilling the basic primary healthcare services being provided from primary healthcare center. A mixed method design was chosen for the study. Quantitative assessment was done using a quasi-experimental design to study impact of digital health on health parameters. For this, data was collected using structured questionnaire and analyzed using difference in difference method. Qualitative assessment was done through in-depth interviews and focused group discussions to understand the user and clientele's perspective of digital health implementation. An integrated health information system for primary healthcare was developed with an electronic family folder having details of households and all household members. These household members were then enrolled in various digitized national health program modules. The system could send automated SMSs for appointment reminders and provided health education. For the quasi-experimental study, two communities having similar socioeconomic conditions and primary healthcare setup were purposefully selected. For pre-intervention assessment, baseline survey was conducted in both areas, following which digital health intervention was implemented in primary healthcare center of one of the selected communities, while the other communities followed the standard of care. Post-intervention assessment was carried out 6 months later through an independent endline survey. Rapid household surveys were conducted in both the communities, covering 4,098 households in intervention area and 5,900 households in control area. Sampling frame for each of the selected tracer condition was created based on the rapid survey findings. Minimum sample size was calculated for each tracer condition based on assumed minimum 10% improvement in population proportion for each indicator following intervention. The samples were selected through simple random sampling. Qualitative assessment was done to assess digital health perception through in-depth interviews of healthcare workers in intervention area and focused group discussions of clientele with 8 members each for intervention area. As for the results, post-intervention, there was significant net relative improvement in care seeking for chronic illness from primary healthcare facility of intervention area. The net relative improvement in care seeking was also observed for acute illness, but the net relative change was not found to be statistically significant. Post-intervention, among non-hypertensives, there was significant net relative decrease in added salt to food and intake of processed food in intervention area. A significant net relative improvement in adherence to hypertension medication was also observed among hypertensives from intervention area. However, the net relative improvement that was observed for hypertension control in the intervention area was not found to be statistically significant. Post-intervention, mean blood pressure among non-hypertensives decreased for both systolic and diastolic blood pressure. However, only the net relative decrease in diastolic blood pressure was found to be statistically significant. Post-intervention tobacco quitting behavior among tobacco users also showed significant net relative change for healthcare workers advising for quitting tobacco, and also for tobacco users tried quitting tobacco for more than 24 hours. Post-intervention in childhood immunization, only vitamin A second dose coverage was found to have improved significantly, as it was observed that while baseline level of vitamin A second dose was low at around 50%, baseline level of all other childhood immunization was found to be very high, to the tune of 70 to 90%. The themes which emerged during qualitative assessment through in-depth interviews of healthcare providers were: healthcare providers found digital health to be tedious to start with, but useful later. Digital health provided easy access to information. It provided reliable information and also supported decision-making by healthcare workers. However, healthcare workers were apprehensive about dependence on computer system and found IT system to be rigid and not providing flexibility as was there in the manual system. The themes which emerged during qualitative assessment through focused group discussion with clienteles were: they found digital health to improve time management and improve the functioning of primary healthcare system by making it more systematic. Their number of visits got reduced as they got medication for a longer period, and follow-up got improved due to automated SMS-based appointment reminders. The clients also found computer-based prescription to be very useful, as now they are more legible and having reduced errors. Coming to the conclusion and recommendations, digital health use in primary healthcare settings were found to be effective in improving utilization of primary healthcare services and also showed improvement in health indicators which were not adequately addressed. There was a positive perception on use of digital health among users and clientele, but there is need to improve the competency and apprehension of healthcare workers working on digital health systems. Thank you.
There is no question in the chat box, so you can proceed with the session of discussion.
Good presentation, Dr. Dharamjit. I just have one question. In the introduction, you said, like, as a part of the intervention for this, to know the impact of the digital health, you have sent some SMSs. May I know how frequently these SMSs were sent?
Sir, we made a complete chart for sending these SMSs, sir. And we were sending these SMSs as per the disease profile. Like for hypertensive, we are sending these SMSs twice a week. For also for tobacco users, it was similar, sir. It was twice a week. And even for the reminders, is it as per their scheduled visit? Whenever they used to visit, we used to schedule them for the next visit. So one day prior to their scheduled visit, they used to get a appointment reminder, sir, for coming to the clinic, sir.
Very good, sir. Fantastic, sir. And just one more doubt I have. Sorry, I'm asking second question, though in the beginning I told I have only one question. So you have conducted in-depth interviews among the health personnel, and you have conducted the focus group discussions among the clientele. So may I know why this difference between these two, in-depth interviews among the health professionals and
right? Actually, sir, there were only we carried out in-depth interviews of the health workers which have used the system, sir, in our primary healthcare sector. So there were not too many of them, sir. And we have sub-categorization. We have doctor, we have got ANMs and paramedical staff. And there were only 2 doctors in the primary healthcare center, sir. So independently, we carried out the in-depth interview of the doctors. Then we selected randomly selected 2 of the ANMs and carried out this in-depth interview with them. For clientele, sir, there were number of clientele that came to our OPD on daily basis, sir. So from them only, sir, we randomly selected 8 of them, sir,
for carrying out our focus group discussion. And we divided it into 3 groups. One was a mixed group of males and females. One was only of males and one was only of females.
Okay, sir. Thank you, sir. Thank
you. Thank you, sir. Congratulations, Dr. Dharamveer, for the nice presentation. And indirectly, I got some other finding from your study that cutting on salt is even much more beneficial for diastolic blood pressure. Systolic, normally diastolic blood pressure is more of a problem. If it rises, then it is more of a problem. Systolic, we can control with many of the things. But your study is indirectly giving us this hint that cutting on salt will definitely improve. So my take is that you have shown that there was improvement in vitamin A second dose, but there was no improvement for DPT booster. Actually, if I say operationally, the two things go somewhere hand in hand. What I have, so how it was there that these two things are mismatching?
Ma'am, actually what has happened, it's an urban area where we found this most of this immunization that was being done for the first year of age, ma'am. They were of the tune of around 80 to 90%. They were already very high. So it is very difficult to improve it further. Improving vaccination coverage from more than 90% to, let's say, to make it significant, 95 or 98%, it's rather very difficult. But for vitamin 2, vitamin A second dose, it was found to be low. Although vitamin A first dose was quite high, it was also in the around 75% that coverage was there for vitamin A first dose. But vitamin A second dose, because not much of the emphasis is being done for these booster doses and for this vitamin A second dose, we found it to be low. It was around 50% at the baseline level. So with these reminders and telling people, improving awareness about these booster doses that has to be given, and also of this vitamin A second dose that is to be provided at the age of around 16 to 18 months. So this digital health system helped us in improving, which were lower. For the coverage which was lower, we found better improvement in those indicators.
Dr. Fosh, may I interrupt you, because we are short of time. We are already running late, so maybe you can have a one-to-one discussion later.
Okay.
Yeah. So,
thank you, Dharamveer sir. Thank you.
Thank you so much, ma'am.
So, proceeding to the next presentation by Dr. Anish Patel. The topic is evaluation of open source COVID-19 related mobile applications in India and application store based quantitative analysis.
Technical team, can you play video?
Greetings of the day, everyone. My name is Anish Patel and I'm a student of Community Medicine and School of Public Health, PGI, Chandigarh. Today, I'm going to present an article related to COVID-19 mobile applications. Other authors of the study are Dr. Arvind, Dr. Sarane, and Dr. Kadeval. The title of the study is Evaluation of Open Source COVID-19 related mobile applications in India and Application Store-Based Quantitative Analysis. So, by the end of 2019, a new disease caused by SARS coronavirus 2 was discovered in Wuhan city, Hubei province of the China. But after the discovery of the disease, many countries all around the world started to develop preventive measures to stop the spreading of the virus. As on 26 Feb 2021, the global count of the COVID-19 cases has crossed over 112 million and more than 2 million deaths have been witnessed. Multiple vaccines have been developed around the world against the virus, yet the early identification, isolation, and non-pharmacological prevention strategies are still considered the effective way to fight through the pandemic. Information and communication technology, especially mobile phones, has been very useful in COVID-19 management for larger population. Mobile phones have been useful in the collection of epidemiological data, clinical data of the people, and early detection by self-testing in the community, real-time reporting of the cases, and hotspot identification by geospatial mapping in case of super spreader. Various mobile phone applications or technology-based interventions are used worldwide to keep the patient updated and connected with the clinician. The primary objective of the study was to assess the quality of the COVID-19 mobile application using MARS, Mobile Application Rating Scale. The second objective of the study was to assess the reporting of the COVID-19 using COVID-19 data reporting system. And the third objective of the study was to find the association between the features of the application and the MARS score. Methodology. It was a cross-sectional study in which all the open source mobile based applications related to COVID-19 available in India were reviewed. Major mobile application stores such as Android Google Play Store and Apple App Store along with Google search engine was searched for the COVID-19 mobile applications. So this is a process chart representing the searching, screening and assessment of mobile application. So we found 247 applications, out of which 176 applications were available in Apple App Store, 70 applications in Google Play Store and one by Google search engine. 18 applications which are duplicate were removed from the review. All other applications which were not available in India, not related to COVID-19, were developed just to deliver grocery or pharmaceutical supplies, developed to collect the relief fund for COVID-19 were also removed. Some other applications which were having technical issues or were not accessible were also excluded from the study. Finally, 42 applications were eligible for the MARS evaluation. MARS is a quality assessment tool which consists of 4 dimensions: engagement, functionality, aesthetic, and information. Total quality of the app was calculated from mean score of each domain ranging from 0 to 5. Quality of the COVID-19 data reporting was assessed using CDRS, which consists of 4 domains, which are accessibility, availability, granularity, and privacy. These domains are covered using 45 items present in it. Scoring of the domains are based on the presence or absence of the items in the dashboard. The raw scores were calculated for each domain and later normalized to have final score between 0 to 1 in this study. We have discussed this earlier. Results of the study were 42 applications were functional and accessible for MARS evaluation, 20 applications were eligible for the CDRS evaluation. Out of 70 applications, 13 applications could be run on both Android and iOS devices, 49 applications were developed only for Android and 8 were developed only for the iOS device. 39 applications required internet access, 6 applications could run without internet, and rest of the applications information wasn't available. 48 applications were made for general population, followed by 11 for doctors and government officials. Till October 10, 2020, applications had download number between 50,000 to 4.9 million, and 25 applications had less than 50,000 downloads. A total of 55 applications had a customer rating above 3, and rest of the 9 applications had rating below 3. This is a MARS score for open source COVID-19 mobile applications, in which engagement score was the least out of all the domains, and overall MARS score was 3.29. We also found the association between the MARS and the features available in the mobile application. We found that IEC, some of the features such as IEC on COVID, interactive chatbot, a COVID-19 case update, COVID-19 testing lab, hospital bed status, and a relief fund were the features which had significant impact on the MARS score. Agra Sarvam Setu, Odisha COVID dashboard had the highest, and MP COVID response app and WHO Academy COVID-19 had the lowest CDR score. Chandigarh CHD COVID application was the only application which had -1 score for the privacy domain, which should have been improved by that time. This is a figure which is representing the normalized score for all the open source COVID-19 applications, which were representing the data, COVID-19 data. It can be seen that many applications are showing the score of 0.2, which represents the poor data reporting by the applications. Conclusion of the study were many applications have been developed both by the center and the state government as well as private companies to manage the COVID-19, but there is no standardization of the application. There is a need of harmonization and development of general guidelines for COVID-19 related mobile application development. There is also a need for assessment of users' perspective and impact of the application features on prevention and control of COVID-19 individually or as a group. Thank you.
So in the chat box. We can do live discussion with Dr. Anish.
Yeah, there are no questions from my side, just a comment. Dr. Anish, your presentation was good. It's good topic, but only thing is was like a bullet train. So I had little trouble in following up with the presentation. That's all.
So just
Thank you.
because of the time frame.
Yeah, I understand. Thank you.
Thank you, sir.
Ma'am, any question?
No questions.
Okay, thank you. If there is no question, we can move to any next presentation now.
Yeah. It is by Dr. Deepu Palal, real-time cluster mapping in field surveys, a pilot testing during COVID pandemic.
So technical team, can you play the video? Video for the next presentation.
Cluster mapping in field surveys, a pilot testing during COVID pandemic. John Snow. The first epidemiological or earliest use of GI system was spot maps by John Snow in 1854 during the cholera outbreak in London's Broad Street. Even though it is not a GIS system per se, it did serve the purpose of solving the problem through better understanding by using geospatial distribution data. This led to the rise of modern epidemiology and has been an inspiration for the application of GIS in epidemiology. Geographic Information System or GIS is a framework for gathering, managing and analyzing data. It analyzes spatial location and organizes information into layers and visualizing using maps and 3D scenes. One of the examples of using GIS in the medicine is during the Disneyland measles outbreak in December 2014. GIS-based maps were created to help visualize where infected children lived and the potential spread of the disease. Also, a study by Fathiem et al. By using GPS system in identifying the priority areas for maternal care and services found a negative association between maternal death and the number of facilities provided for medical care and services for pregnant women. The aim of this paper is to develop and pilot test a software for cluster mapping using GIS for real-time mapping, assistance and feedback in the field surveys. The objectives were to develop a mapping platform for field studies, field surveys, and to pilot test the developed platform for real-time cluster mapping during the SARS-CoV-2 Zero survey. The first step in doing this was the developing the platform. The residents of the Community Medicine Department, Dr. D.Y. Patel Medical College, developed a software and a mapping platform for real-time cluster mapping. Using this software, the user shares the location. The user, in this case, the field investigator, shares this location, and the server receives and processes the shared location and stores it in a central database. And the output, that is the data analyzed and formatted as per the user need, is displayed real time in a dashboard which is accessible at test.techlabel.in. Here, this figure shows in detail the working of the app that has been developed. Here you could see in the left hand corner of this, the field investigator shares the location. The location is being sent to the Telegram bot via webhook, and the Telegram bot does an API call to the central server, and the central server parses, sorts and intelligently processes the data to save it in the SQL database. And this data is in turn saved real time at the front end, which is accessible at http test.techlabel.in. This shows the working of the data retrieval process in the front end. The data is being retrieved from the MySQL server and being shown at the front end. For the pilot testing, we have designed a population-based cross-sectional studies. The place of study was the pre-selected areas for Zero Survey project in Pimpri-Chinchwad Municipal Corporation, which has been divided into 200 clusters. The project has been done in 10 days from 7th October 2020 to 17th October 2020. And the sample size was calculated to be 4,641, which was rounded off to 5,000. These 5,000 people were divided into 200 clusters with 25 samples from each cluster, and 5 samples from each household, therefore accounting for about 1,000 households for 5,000 people. After taking samples from each household, the field investigators were asked to share the location through the procedure that were mentioned before. An acknowledgement message is also sent to the user, indicating the software has registered their location. And not only the registering location, this software has also provided valuable in maintaining internal validation. Diva Patel Medical College and Pimpri Chinchwad Municipal Corporation together has undertaken. The location of each surveyed household were plotted dynamically with necessary information. The sampling process, progress, and performance of each team were monitored real-time using a central dashboard. And feedbacks were also given in case of any deviation from the planned sampling technique. And also queries were resolved real-time by the observer. And the result of this was the over 6,638 households were plotted using the software. Real-time feedbacks were given, and the households plotted on the maps were verified by the respective field investigator after the study has completed and showed a very good accuracy. The developed software also helped in maintaining quality and internal validity of the study. Here, this figure explains the households that has been sampled during the PCMC Zero Survey project. As you can see, the maps displayed is the PCMC map, and you could see there is an even distribution of the samples that were clusters that have been collected from this. And this figure shows the diagram where the households where each samples were collected. You can see there are different clusters. One is Priyadarshini Nagar, one is Jayasingarur Nagar, one is Power Nagar, etc. And you could see the green dots, it represents each households where the samples were taken. And this is a brief comparison with the existing GIS app and the developed software. The developed software helped in real-time field mapping, which has a shallow learning curve, and it's also easily deployed for small-scale and medium-scale field surveys. The users were also monitored real-time and provided feedback. And there is also a facility for sending SMS without disclosing the investigators or the field investigators' phone number. The conclusion is the use of GIS can provide better visual understanding by geospatial spread of samples, while also acting as internal quality control through monitoring and feedback. Such programs are useful not only in visualizing the data, but also to understand the dynamics of the population and other factors at play. The introduction of GIS software, which is affordable and easy to set up, could certainly bring about a positive impact on current scenario. The quality and internal validity of small and medium-scale field researchers could also be improved by using the developed program without adding to the burden. Additionally, the software can also be deployed in mapping, tuberculosis, leprosy, and other diseases remotely, while at the same time providing an option to monitor the progress of survey or data collection. That's all. Thank you.
Questions?
Yeah, good afternoon, sir. I'm Dr. Deepu Pilal, resident, first year resident, Department of Community Medicine, Dr. D.Y. Patel Medical College, Pune.
I don't have any questions. Ma'am can.
Dr. Deepu, just I wanted to know one thing. You surveyed 1,000 houses, but GIS picked 638.
Yes,
was it a failure or anything else?
No, it was a success only. The problem was some of the team members who were supposed to send the location during the initial few days were confused, and they did not want to send location. They were of the opinion that sending location will delay their sampling process, and they were not willing to try it out for a few days. So that is why we recorded only few households, 640 households.
Actually, because it makes a major dropout. So reliability on this GIS system is under question if it is not able to pick so many locations.
No, ma'am. The reliability is 100% reliable. The problem was initially for first few days, people were reluctant. Some of the field investigators were reluctant because they were of the opinion that this is wasting their time. This is delaying their time. But in fact, actually, the other teams, some of the other teams were using,
And in fact, it was not delaying the time at all because location could be shared under 10 seconds. It was their perception that was a problem. And we counseled them, and later everyone started using. And every data that has been sent has been successfully recorded, and the reliability, we can 100% rely on this thing. And there is no false locations. The locations which are plotted was 100% accurate, which we have verified. After each day we were calling field investigators to look at the data that they were plotting, and they said they confirmed that it is the same location that they have visited. And moreover, if I may add one more point, the entire process was real time. That as soon as the field investigators send the location, it gets plotted on the maps dynamically. And we also have a person, an observer sitting at the community medicine department, looking at the sampling technique. Because as I said, there were 10 clusters spread over 10 days. And we advised all these field investigators to stick to their sampling process.
Okay, thank you, Dr. Deepu. And we wish you all the best that this system works in other programs also. Thank you.
Yes, ma'am. Thank you very much, ma'am. And if I add one more thing, we also have got a copyright for this system by the government of India, which we got just last month only, February. So we are planning to deploy the system on a all India basis. If any medical colleges wants to use the system, we are happy to help.
Okay. Thank you. So moving on to the last presentation of the session, that is by Dr. Jennifer Persis. The topic is comparative effectiveness of two information technology-based educational strategies on maternity preparedness of pregnant women in Northern India, randomized control trial.
Myself, Dr. Jennifer Persis, Junior Assistant from the Department of Community Medicine School of Public Health, is going to present a randomized control trial on comparative effectiveness of two mobile app-based educational strategies on maternity preparedness of pregnant women in Northern India. The study was co-authored by Dr. Seema Chopra, Additional Professor from Department of Obstetrics and Gynecology, Dr. Kadirvel, Assistant Professor, and Dr. Amarjit Singh, Professor and HOD from the Department of Community Medicine School of Public Health, VJMER.
May I request technical team? There is a voice problem, I think. We are not able to hear the presentation. Is it same with everyone?
Yes,
Jennifer,
sir,
can
I
you
am not
speak
able to
live?
listen.
Jennifer, can you speak live?
Jennifer, is it possible to... Dr. Jennifer, are you there?
Yes, sir.
Yeah, I think your presentation's volume is... there is a problem in the voice. Can you go along with your presentation? Can you say...
Jennifer, slides are visible. You can speak now.
Yeah.
Yes, sir. So I'll start with the introduction.
No material.
If I give the control,
No, introduction, I think vendor से ये slide जल्दी बदल रहा है.
I said this is a I think recorded video.
Recorded.
Okay.
So you can start from here if possible.
So the eligibility criteria for the study participants, like the study included pregnant women without any medical or surgical disorders and who uses Android mobile phones and who can understand Hindi or English. And the study excluded participants with high-risk pregnancy and pregnant women from medical or paramedical profession. Then sample size was calculated based on the available literature, where there was 27% of respondents who gained improved practice on pregnancy without intervention. So by considering 95% of level of significance and power of 80%, sample size of 50 participants per group was calculated, given an anticipated dropout rate of 10%. Then preparation for the trial. We made health education materials on 13 minor ailments in pregnancy and warning signs in pregnancy, and dietary intake, and about self-care practices, and about postural care and antenatal exercises in the form of 18 PDF files, 40 short text messages, and 10 videos. And the materials were validated by face validity and content validity by experts from the Department of Community Medicine and Pediatrics and Obstetrics and Gynecology. Then trial algorithm, pregnant women of less than 20 weeks were
scored IT score of more than 40 were block randomized into three groups of Geo app group, the specialized mobile application, and the WhatsApp group, the common social messenger application, and the control group. And the Geo and baseline assessment was done on knowledge, attitude, and the practice in pregnancy care. Educational intervention were provided for the Geo group in the form of PDF files, weekly short text messages, and YouTube videos and teleconsultation. WhatsApp group received as like the Geo group except for the short text messages. And the control group received routine standard of care. Follow-up was done during the 32 to 36 weeks of gestation for post-interventional assessment. Statistical analysis, PAT test were
PAT test was done to assess the effectiveness due to intervention within the groups, and difference in difference analysis was done to estimate the difference in CAP scores between the pre-intervention and post-intervention. And this table shows socio-demographic characteristics of the study participants. Comparing all the three groups are similar in characteristics except for the education. Then table 2 shows pre and post intervention score on CAP and pregnancy care. There are all the three groups shows effectiveness after intervention. And table 3 shows between group difference in
after the intervention in all the three Geo app group, WhatsApp group, and the control group. Table 3 shows between group difference in CAP score and pregnancy care. Difference in difference analysis was done to assess the difference between the pre-intervention and the post-intervention, and man-Whitney test was done to assess the effectiveness between the groups. While comparing the Geo app group with the WhatsApp group, Geo app group showed significant
I think Dr. Jennifer, the volume is going again. Can you chip in?
Yes, sir. I think
You can summarize.
Okay. So we compared two mobile app groups. One is the social messenger application WhatsApp group, and other is the specialized mobile application Geo app group. And we assess the effectiveness in terms of knowledge, attitude, and practice, and also we assess their user friendliness. So while we found that both the two groups, mobile app groups, were effective in improving the knowledge, attitude, and practice. Both the two groups were user friendly, and also we assessed their satisfaction level of using the mobile app groups. So in the satisfaction level, we found that a WhatsApp group, the most commonly used social messenger application group, they found more satisfactory as compared to the specialized mobile group. So the conclusion is both the mobile apps were effective in improving the knowledge, attitude, and practice, but the most commonly used application was satisfactory among the participants.
So I'm sorry for this interruption again and again. We have speaker live. Now we can have clarifications. Chairs can ask questions. Any?
Yeah, Dr. Jennifer, it was a good topic, but unfortunately, because of some technical error, we could not follow it. But however, after seeing the slides, it's very clear that no, it's a very wonderful study. And I don't have any questions as such from my side, but um, I take this opportunity to just tell one comment, especially in the presence of esteemed Professor Amarjit Singh sir and everybody on this group. It is very clear that nowadays the use of information technology is inevitable, especially in healthcare setting and patient care. Okay, there is a lot of research work done and still it is going on regarding the use of this information technology / digital health in healthcare setting. But definitely there are a lot of apprehensions at the same time. The awareness levels about the use of this digital health is high among the individuals with a good level of education. At the same time, there are apprehensions also. So I feel personally that a lot of awareness programs are to be conducted, I think, to improve the use of this information technology and application of this digital health to improve the patient care and also to remove the apprehensions. I think that is the basic foundation stone that we should, as a community medicine professionals, we should also look into that dimension also. That's what I personally feel.
So, Dr. Rajesh, thank you very for nice comment. I have just two comments. One thing is that that today's interruption shows that these things are likely to be there in digital medicine or AI-based medicine or telecom medicine, whatever. So this is just an example. But Jennifer filled it quite nicely, and Dr. Vivek also have. Second thing is that the private players are there. General public is already using YouTube or Facebook and other things. So it is necessary that public health professionals and medical professionals also enter this area to develop SOP and all things, because if we don't, general public in any case will be using telemedicine. So we should be a part of this.
Yes.
Thank you.
Thank you, sir.
Sir, continuing with your comments, both the senior functionaries with me, I also want to say this thing that considering that digital health is such an upcoming issue, that earlier as medico, we used to stick to human anatomy or human behavior. But now definitely as CBME has also come up with this thing that there should be some knowledge of computers. We need to have some formal training of our medicos that how to run these applications, seeking those ethical issues and privacy issues, all these things are also there. So they also need to be addressed, because somewhere they create some chaos. At the end of the day, one feels that we are not secure, that one-to-one interaction was there. So that thing, I feel now it is a mandatory thing that we should be educated in computers or such, you can say, application of these apps.
This is a nice, very nice comment and very timely, because machines behavior, machine कैसा behave करेगी ये भी तो देखना है. हमारा बिहेवियर तो है ही, तो मशीन भी कभी कभी गुस्सा हो जाती है. जेनिफर से गुस्सा हो गई कि लेट हो गया, लंच टाइम हो गया है.
Sorry for that thing. Perhaps we continue with our discussions for a longer period.
Sir, I think there is a famous saying that इंसान गलतियों का पुतला है, but let's control digitalization, that we should make digital health bit more error free. So
वो विवेक का कभी बाहर निकल रहा है, वो पुतले भी गलती करते हैं. इंसान गलतियों का पुतला है, वो जो पुतले हैं वो मशीन है, मशीन भी तो गलतियां करती है.
कर सकती हैं. Yes sir.
That is very nice.
We shall try to make it more error free.
Murphy's law भी आ ही जाता कहीं ना कहीं से.
Yes. So if chairs allow me, can I propose vote of thanks?
Sure.
So it is my honor to
and so we would like a photograph with the participants. Please turn on your videos, all the participants.
Yeah, Dr. Nirmalan, can I propose vote of thanks first?
Yes.
So it is honor to propose vote of thanks, chair of the session, and also to speakers and delegates who participated in the session. Professor Amarjit sir for supporting us continuously, and for the team, and of course to the vendor. And I request vendor that please check the videos in advance so that we do not face this problem again. So thank you everyone. And now we can have photograph. Over to you, Nimra. Nimran, you can take picture now.
Okay, sir. Give me a moment. Everybody, please turn on your videos and the thumbs up. Muskan, Monica, everybody. Smile. Thank you. Done.
So thank you.
Thank you, everyone. Thank you, sir. Thank you, madam.
Thank you. Thank you, ma'am. Thank you. Thank you, everyone.
Thank you.
our offering in photoredox catalysis. Before we jump into the topic at hand, first want to give an overview of innovation that we're focusing on to accelerate drug discovery. So we have offerings in the lead discovery area, such as our off-the-shelf DNA encoder library, as well as in chemical biology with our protein degraders. We have a reaction design, we have our retrosynthetic software, Cynthia. Then today we're going to focus on the areas of small molecule synthesis and reaction platforms with the area of photoredox catalysis. So this short seminar will be broken down into 3 parts. The first we'll discuss the photocatalysts themselves. We have worked with many players in the field to develop a robust offering over the years. We will then move on to talk about our photoreactors, which we pride ourselves in having plug-and-play reactors that have been designed to bring consistency and reproducibility to any photocatalytic reaction. And the last piece, arguably the most important, is the know-how content that we provide to beginners as well as experts. So jumping into the photocatalysts, and we have photocatalysts ranging from all different types. The classical iridium and ruthenium catalysts are strongly represented. We have over 50 combined of those 2 types. We then have some of the newer organocatalytic, or the organophotocatalysts, including some acridinium catalysts brought in from the Nishevitz lab, as well as some beryllium phenoxazine catalysts brought in from Garrett Miyake's group, as well as some joiner acceptor catalysts. And as I mentioned, we source a lot of our innovation and work with, and through many collaborations, different professors throughout the world. So if you are interested in commercializing a photocatalyst, please don't hesitate to contact me. My contact information is shown on this slide. Moving on from the photocatalyst to the photoreactors, we have 3 different main reactors that all focus on different aspects of reaction design and optimization. So the first is our photocatalysis reactor focused on reaction screening. We then have the syn-led parallel photoreactor for reaction optimization. And lastly, the workhorse instrument is the PenPHD photoreactor M2. And an important thing to remember is that all of these reactors have been designed to bring consistency and reproducibility. So going into further detail with our screening reactor, it's the photocatalysis reactor. So as you can see here, we have it, the starter kit contains an LED controller allowing you to adjust the intensity of the light, and also comes with a 470 nanometer LED array. So it's a blue light source, and then the reaction block and screwdriver. The consumable part of this platform is our 24 catalyst plate. And so this is a general screening kit. You have a wide range of photocatalysts included, so some acridiniums, iridium, ruthenium, as well as a few other different types of catalysts. And each kit contains 2 plates and 4 different solvents for screening. The main features here, this is a microscale format. So the user is able to run 24 unique reactions using approximately 100 milligrams of their own substrate. As we mentioned, this has 24 pre-weighed catalysts. It's 0.1 millimole of each. And the LED controller allows for variable intensity. And there are 3 different LED arrays available, the 470 nanometer blue LED that comes with the starter kit. And then there's an add-on 527 nanometer green LED, as well as a white LED array. Moving on to our next photoreactor, we have the syn-led parallel photoreactor. This is a great reactor for reaction optimization as well as small library synthesis. So this features a 4x4 array of 16 1 to 2 dram vials, and then each slot is a 1 bottom lit LED. So these are blue LEDs with a wavelength range from 465 to 470. And then this reactor also has a built-in cooling fan to provide consistent temperature, approximately 30 degrees C. And this fits well onto a round ICA stir plate. The big selling point of this reactor is that it has a consistent temperature and light intensity to all 16 vials, allowing for, as I mentioned before, reaction optimization as well as library synthesis. Moving on to our third photoreactor, we have the PEM-PHD photoreactor. And this is our workhorse instrument. The scale ranges from GC vials all the way up to 40 mil vials. The modular design allows for a variety of wavelengths. So the instrument comes with a 450 nanometer light module, but a 365 nanometer and 420 nanometer light modules are also available. The 360-degree reflective environment is able to maximize photon capture. Other interesting aspects of this are the touchscreen, allowing easy user interface, as well as the different parameters that the user is able to define. That includes temperature, intensity, fan speed, and stirring.
गुड आफ्टरनून विवेक।
गुड आफ्टरनून सर।
कैसे हैं आप?
बढ़िया बढ़िया।
गुड आफ्टरनून सर।
Good afternoon, all.
Good afternoon, sir. So,
Vivek, what will be the procedure? I didn't get any SOP.
Okay, sir.
Just brief me. Just brief me. Don't take. Yeah, don't take much time. Yeah.
I will introduce you and the co-chair, and then you can ask speaker to
start the presentations.
Yeah.
Okay, that's beautiful.
Yeah. So,
And but I have received a PowerPoint mentioning a lot of speakers or biodatas of many renowned public health professionals, including many renowned one. But should I have to go through that, or
no,
what
sir.
I have to do?
I think
There were 8 or 9 persons were there.
I think
No.
that was sent for some other purpose, maybe. I
Okay.
do not know about that. But for this session, which is on medical education, you are the chairperson, and Dr. Varsha is the co-chair.
Okay.
May I take opportunity to start the session, sir?
Yeah.
Yeah.
It's up to you. It's up to you. I am available. Yeah, please.
Welcome to all. So this is a session of medical education, and this session will be chaired by Dr. Manish Chaturvedi. He will be the chair for this session, and he is a professor and head of Department of Community
Medical Care and Hospital Administration
and
at National Institute of Health and Family Welfare.
At National Institute of Health and Family Welfare. He is a coordinator of GOI NIHFW initiative capacity building in public health emergency management, extensive experience in teaching and developing capacity building programs, author of over 90 scientific articles in national and international peer-reviewed journals. Currently, he served as reviewer, editor of public health journals and books. Currently involved in strengthening patient safety, hospital management, and public health emergencies courses. With this, I introduce Dr. Co-chair of the session, Dr. Varsha R. Mokhasi, Assistant Professor, Shri Devraj Medical College, Karnataka. Area of expertise is geriatrics, maternal and child health. Her interest is in nutrition and tuberculosis. She has about 6 publications. She is state level IDD survey for NIDD CP. She has given guest lecture on assistive devices of elderly organized by NIMHANS, Bangalore. University funded research projects. She has university funded research projects on anemia in adolescents. So with this brief introduction, I invite chair and co-chairs to take over the session, and we can start the session.
Thank you, sir. Thank you, sir, for your kind words. Am I audible?
Yeah, you are audible, Dr. Varsha.
Good afternoon, sir. Nice to meet you, sir.
Thank you, dear. Thank you, Vivek, and thanks for the brief introduction of both of us. And I'm really thankful to the Iapsmcon conference team organizers for giving me this opportunity to at least to contribute something for the medical education in some or other way. So I invite the first speaker, Dr. Malatesh. Please start your presentation.
So may I request technical team to start the video?
Malatesh, please introduce yourself in brief.
Yeah, good afternoon, sir. This is a recorded video of mine. I am from Karwar Institute of Medical Sciences, Karwar, Karnataka. Myself, Maltesh Undi, will be the presenting author of this study. I request the team to... I'm going to present our study that is titled A Study to Assess the Effectiveness and Perceptions of Students Regarding Case-Based Learning over Traditional Teaching Methods in Community Medicine. We all know that traditional methods like lectures and tutorials are commonly used teaching method in medical schools. In these teacher-centric methods, students are passive learners and they may not take part in active discussions or critically think or apply the learned knowledge. Hence, there is a need for self-directed learning methods among the medical undergraduates, out of which case-based learning is one such method that has more interactive sessions and students are involved in thinking, analyzing, and interpretation. Also, the literature review revealed that there are not many studies related to application of case-based learning in community medicine and especially assessing it in relation to assessments. Hence, we conducted this study with the objective to assess effectiveness of case-based learning over the traditional teaching method used in community medicine among the second-year medical undergraduates. We also had secondary objective to assess the perceptions of second-year medical undergraduates regarding the case-based learning over the traditional teaching method used in community medicine department in a government medical college. We conducted this study in KIMS Karwar over a period of 6 months. It was a randomized controlled study where we included 143 medical students of phase 2 who were randomly allocated into 2 groups where Group A underwent traditional method, that is lecture, Group B underwent CBL. We obtained ethical clearance for the study and also obtained written informed consent from all the students who participated in the study. The data was analyzed using SPSS, and descriptive statistics was used for analysis like mean, standard deviation, and percentages. The inferential statistics used for analysis was paired test for within the group comparison and independent t-test for between the group comparison. This figure helps us in describing visually what we actually did. After obtaining ethical clearance, we obtained the written informed consent from the students and divided them into group A, who underwent traditional teaching methods, that is lectures, and group B underwent the case-based learning. For both the groups, we did pre-test prior to the beginning of the session, and immediately after the session we did post-test, as well as after 4 weeks of the session we did a retention test, and we compared the mean scores using the paired t-test within the groups, and between the groups we used independent t-test. We also assessed perception of the students regarding case-based learning over the traditional method for group B students. Overall, the findings were analyzed and interpreted. The results showed that both group A and B were comparable in relation to number, age, as well as sex. Hence, randomization was effective. This is an important slide which showed us that when we compared the mean scores within the groups for pre-test and post-test, there was statistical significant difference between pre-test and post-test of both the groups. However, the mean scores difference was more in group B that underwent case-based learning. It was interesting to know that group A, which underwent traditional lectures, did not had any statistical significant difference between pre-test and retention test. However, the group B, who underwent case-based learning, there was difference between significant difference between pre-test and retention test. That tells us that case-based learning helped the students in retention, that is, the students were able to recollect the learned knowledge even after a period of 4 weeks. This is also another important slide which showed us that when we compared the mean scores between the groups for pre-test, there was no statistical difference between the groups. That means the groups were comparable before the beginning of the sessions. But once they underwent lectures and case-based learning respectively, it was observed that there was statistical significant difference between the mean scores in relation to post-test and retention test. This tells us that case-based learning helps them to understand the subject better. That is, immediately after the session they were able to understand it better, as well as after 4 weeks they were able to recollect and retain the learnt knowledge. This is quite helpful, especially in the subject like community medicine. We also assessed the perception of students regarding case-based learning over the traditional methods. Students perceived that case-based learning was aroused interest in them, as well as that helped them in engaging into teamwork. It was less stressful. It encouraged them self-directed learning, and they had better retention and recall of the knowledge. However, the students also noted the limitation or negative aspect, that is, it consumed more time as compared to the lectures. With this, we would like to conclude that case-based learning was effective over traditional teaching learning method used in community medicine. Statistical significant difference was observed in post-test as well as retention test scores between the groups, and students perceived that case-based learning aroused interest and encouraged self-directed learning. With this, we would like to recommend that inclusion of case-based learning as one of the teaching learning method in community medicine shall help the students to improve their academic performance because of improved retention levels. This is particularly helpful for community medicine, which cuts across the phase right from phase 1 to phase 3, where many of the topics learnt in the first year need to be recollected and retained later. However, the study had limitation that we could conduct only in one of the phase, and further studies are needed to study the retention level across the phases so that it will be helpful in adding to the evidence gained by the present.
Is it completed?
Yes, sir. The presentation is complete. Thanks for patient hearing. Over to you, sir.
Okay. Thank you. Is there any caution from the audience? Organizing team, is there any caution?
Sorry, sir, could you
Definitely
repeat it?
not. Dr. Varsha, would you like to ask any question?
Yes, sir. Sure. Thank you, Dr. Maltesh. That was very much indeed needed based on the feedbacks that we are getting from the students regarding community medicine being not interactive and interesting. I want to congratulate you for the initiative of conducting this particular study. One doubt is that you mentioned that there were two groups, and after 4 weeks, there was a retention test taken. Am I right?
Yes, ma'am.
Sir, is there a chance of contamination or students discussing amongst each other and that affecting the final result among the two groups?
Yes, ma'am. So that is an inherent limitation of any comparison studies done in the medical education, and we do need to accept. But even without sessions also, students has an opportunity of learning from other sources, which is quite difficult to control in medical education research. And with that limitation, I think it was we did 4 sessions, and for all the 4 sessions, there was improvement in the scores, and that tells us that it may be due to the teaching learning method engaged rather than just discussing among themselves with the other group.
Yes,
Good,
Dr. Maltesh.
Maltesh.
Yes, sir.
Good, Dr. Maltesh. But I would like to ask a few questions. We are very limitation of time is the major issue. One thing, what is the difference between this problem-based learning and case-based learning? One question. Problem-based learning and case-based learning. In general, the medical education is defined in such a way that cognitive, affective, and psychomotor. Where I have learned in first year, it is focused on cognitive, second professional on the affective, and the last one is on the psychomotor, or the internship part is on the psychomotor. So how your concept is different from that? As you mentioned, we have a lot of limitations. It cannot be generalized. Final statement that I am involved at present in adult learning. So I'm somehow, some or other way, I'm involved in CMO teaching and directors teaching and DGs teaching. So I'm coordinating of such type of courses. And I realized that in aspect of, or rather to pursue interactive learning, people start using the Sholay story and other things for imbibing the interaction, which is not up to the mark. We have to start interacting with the knowledge, but people are covering their, or rather masking their lack of knowledge with such type of examples and such type of things, which is we should focus on this type of aspect. Lastly, CBME is really discussing too much nowadays, and case-based learning is part of that, I think, if I'm not wrong. MCI has also suggested that, rather NMC has also suggested that. So in that scenario, in that perspective, how much your CBL research study is practical in that scenario? Please, only 1 minute. Yeah.
Yes, sir. Thanks for those queries. So yes, I would like to, with a paucity of time, I would like to answer briefly. One thing, there are subtle difference between PBL and CBL, where PBL is, many of the researchers agree upon that it is framed loosely, in a sense that student has an opportunity or provision for framing their own objectives and continuing as per the objectives framed thereon. We use 7 steps and we continue. Whereas in CBL, it is slightly, or the tutor or the teacher will decide the objectives for the class, but interestingly, they bring in a well-framed case through which the discussion happens. And as sir rightly mentioned, rather than interacting among themselves, they have to interact with the content. With that, even systematic review of CBL states that more than PBL, CBL is quite more effective in interaction with the content, and the students will be able to achieve the objective at the end of the session as compared to a PBL session. And with respect to adult learning, right from first year to final year, we have growth stage 1 to 4 of self-directed learning. As sir said, they may be initially need handholding while performing these activities. Later on, once they achieve higher stages in self-directed learning, the case-based learning can be very effective, especially for the clinical part, which may include all the three parts. As sir said, it can be a cognitive component or affective, or even including communication skills. So interestingly, not a part of this study, we are also planning to compare this with the other inquiry-based teaching methods like team-based learning and problem-based learning, which may give us further insight into how these methods will help. The last explanation from me is this study was done mainly for the non-CPME batch, the second year, which were in the previous term. And with this first study, this led us to a platform that now we have a CBME batch. Probably we will implement it further and test whether it works with the next batch of students. So thank you, sir. Thanks
Thank
for
you,
those.
Malate. Thank you. Nice presentation and nice explanation too. Thank you, dear.
Thank you, sir. Thank you.
The next is the famous figure, Arnab Ganguly. Arnab, please unmute your mic first.
Good afternoon, sir. How are you, sir?
Fine, dear. And I was thinking of your name. कहाँ सुना है बहुत struggle करने के बाद याद आया कि he is a famous figure.
Last year.
Yeah, last year.
Last time. Wonderful to see you, sir. I'm Dr. Arnab Ganguly. I'm a junior resident MD MPH epidemiology at All India Institute of Hygiene and Public Health, Kolkata. Can I have the presentation on?
Technical team, please help.
So can we please start the presentation?
The title of my study is Dental Education and Service Practices in Context of Coronavirus COVID-19 Pandemic, a Qualitative Study in West Bengal. As we are aware that WHO China Country Office reported a disease of unknown origin from Wuhan City, Hubei Province on the 31st of December 2019. On 11th of March 2020, COVID was declared a public health emergency of international concern and a global pandemic disease. In India, on the 24th of March 2020, a complete lockdown was declared. The medical and paramedical health workers were termed Corona warriors and identified as the frontline forces for combating the pandemic. The dental settings have unique characteristics and specific infection control considerations. We need to relook at the existing dental curriculum in light of COVID-19 pandemic. Various other factors are relevant for healthcare, which include avoidance, quarantine, stress, work-life imbalance, increased expenses, and a host of complex and multidimensional problems. There are also rapid changes which are happening around the world, including the likelihood of worsening of spectrum and more complexities in near future. The objectives of my study were to find out the dental practices in context of COVID-19 pandemic in a dental college of West Bengal and to explore the views on dental curriculum in context of COVID-19 pandemic. My study type was observational and the design is cross-sectional qualitative. The study setting is a dental college in West Bengal and the study population comprised of dental undergraduate students, postgraduate trainees and faculty members. The study period was from July to December 2020. I had used sampling technique as quota sampling and 4 undergraduate participants from each year of BDS curriculum, MDS and faculty members, which totaled a total of 36 participants participated in the study. The study plan included IEC clearance, CTRI registration, informed consent obtained from all the study participants, and in-depth interviewing of the participants. The data analysis was done by thematic analysis of qualitative data, which was obtained by in-depth interviewing, and the inclusion criteria were dental students enrolled in BDS, MDS course and faculty members. This table shows the educational profile of the participants. The table shows different themes and sub-themes which are contributory towards dental service practices. The themes are before patient enters the practice area, and the sub-themes were scheduling management and telephonic screening. The next theme is patient waiting area, and the sub-themes were assessment of patients and triage, crowd control, and mandatory wearing of masks. Another broad theme was after patient enters the practice area, and the sub-themes were hand hygiene adherence, personal protective equipment, and minimizing the aerosol generating procedures. The next broad theme was after patient leaves practice area, which included sub-themes of mandatory wearing of mask, equipment sterilization and area disinfection, and information if the patient turns out to be COVID-19 positive. The various snippets are shown. This table shows the different themes and the sub-themes which are contributory towards dental education. The first broad theme was theory, and the sub-themes included training on infection control and epidemiology, and also updating of protocols in the current scenario. The next broad theme was practical training, which included sub-themes as supervised practical training and audits during training. This slide shows the various snippets which were obtained by in-depth interviewing. The conclusions of my study are a consensus among the dental practitioners and the students alike to update the dental curriculum and practices in context to changing scenario due to the COVID-19 pandemic, and also that the education training needs to incorporate patient and provider safety. There is also a need for stricter institutional infection control protocols for the practice areas and audits to check the adherence to infection control. Also, a focus on proper sterilization and biomedical waste management should be done. My references are as follows.
Dr. Varsha.
Thank you.
Am I audible?
Yeah, you're audible.
Yeah, good afternoon, Dr. Arnab. So, my only question is, what was the final outcome and what was its implication on the further actions taken based on the findings of this particular study?
Actually, the reason for conducting the study is that, you see, in context of COVID-19 pandemic, we were not exactly aware of what is the perception of the students in terms of the changing scenario. So dental practices as such are a neglected, say, branch of clinical sciences. In fact, even NABH came as late as 2010 to draft the standards for dental clinics. Now, with the changing context and the increased risk in terms of patients, I wanted to do the study, say, on the dental college, and say my findings were exploratory in nature. So this is the first findings which I could get by in-depth interviewing. You understand that? I mean, there are a lot of more steps to take.
Yes, it's a qualitative
in
study.
future.
Right.
So, yeah, it's a qualitative study, right? So the next ongoing thing, I want to pursue this particular line and come up with, say, understanding the salience as to the points, and then draft a questionnaire to analyze what exactly are the changes that will be required.
Okay. Thank you, Dr. Arnab. Thank you.
Dear Arnab, I can say only one statement, that welcome to public health. That's all.
Thank you, sir.
From dentistry to public health. It's really a big pathway and another highway. So you're welcome. But your research methods and knowledge of research requires a lot of in-depth knowledge. Okay, you need some guidance from your seniors in the institution. In addition to this, we all are facing the same problem in COVID era. Medical education as a whole is totally compromised. DCI is also trying to solve this question. NMC is also trying to solve this question, but we are unable to answer this question because as and when we give the exposure to our students with the patients, it increases the chances of getting infection. Therefore, it's a big trouble. That's all. But your study is qualitative one, which you have not interpreted properly. That's all. Thank you. Please do your best and all the best for your career.
Thank you, sir.
So, okay, all the best. The next one is Priyanka Mukhopadhyay. Dr. Priyanka, please join us. We are not able to see you, dear. Where are you? Yes. Now, please introduce yourself.
Priyanka, you are not, Dr. Priyanka, not audible. Please. Yeah, better.
You continue, please. Because after that, audio will, this video will be there. So you better continue. Just introduce yourself.
So I'm Dr. Priyanka Mukhopadhyay from NRS Medical College. I'm posted as Associate Professor.
Okay. So you are serving as Associate Professor in Community Medicine Department?
Yes, sir.
Okay. That's great. Please, technical team, please start the video. Or Dr. Priyanka.
Dr. Priyanka Mukhopadhyay from the Department of Community Medicine of NRS Medical College, Kolkata. My topic is the effect of training primary healthcare providers for providing community-based care in management of hypertension. Hypertension is a major risk factor of cardiovascular diseases across the world. Currently, hypertension and diabetes causes 1/4 of the leading cause of mortality in India. It is well known that lowering blood pressure reduces the risk of cardiovascular diseases. Although effective treatment is available, target blood pressure goals are achieved in only 10 to 25% of hypertensive patients, with the patients from rural areas being worse affected. Community-based care provided by trained primary healthcare workers can be a low-cost effective strategy in reducing hypertension in rural areas. The objective was to evaluate the impact of training primary healthcare workers in detection and providing community-based care in the management of hypertension. A prospective interventional two-group study was undertaken in 6 blocks chosen randomly in a district of West Bengal for a period of 2 years. The study participants included all new cases of hypertension with age above 40 years, able to understand Bengali, the local language, but permanent residents. Persons with pre-existing diseases like AMI, angina, and other seriously ill patients, and also those who were already diagnosed with hypertension or were on medication were excluded. The study was conducted in the district of North 24 Parganas, which comprises of 22 blocks, from which 25%, that is numbering to 6 blocks, were chosen by simple random sampling technique. Next, pairwise matching of the blocks were done with respect to area, important health indicators, and distance from the main subdivisional hospital. So 3 blocks were included in the study group, where 3 blocks served as the control. All primary healthcare workers, that is the ANMs, received training in the study blocks. To detect a 5 mm fall in blood pressure, which is deemed as clinically significant with standard deviation estimates of 15 mm at an alpha of 5% and power of 80%, assuming an ICC of 0.01 and also accounting for a 30% dropout rate, the sample size came out to be 12 clusters or 12 subcenters with 20 persons in each subcenter in each of the study and a similar number in the control blocks. Recruitment of new cases of hypertension was done through a two-stage screening process in the intervention group. First, a baseline assessment of risk factor was done by ASHAs using a household level screening questionnaire. Those detected to be positive were sent to the sub-centers for measurement of blood pressure and other clinical parameters by the ANMs. Again, those who were found positive were referred to the PHC to be managed by medical officers. Now, the ANMs in the study group, they maintain a record of the patients sent to the medical officers diagnosed with hypertension and also followed them up and provided community-based care. Now, this step was absent in the control group. The community-based care package comprised of face-to-face counseling at clinics and quarterly home visits. Counseling was about the disease and its complications and the lifestyle interventions for management of hypertension. Side-by-side monitoring of blood pressure, weight, and compliance to therapy was also undertaken. Those whose blood pressure was not controlled or developed complications were referred to the medical officer and further followed up. The primary outcome variable was the proportion of hypertensive patients with a reduction in systolic blood pressure of more than 5 mm after 12 months. 227 patients were included in intervention and 230 in control group. Mean age was 54 years versus 55.61 years and majority were females. No statistically significant differences were observed between baseline socio-demographic and lifestyle factors. 76.65% of newly detected hypertension patients had a reduction of more than 5 mm of systolic blood pressure, which is considered as clinically significant, whereas in the control group 62.17% showed no clinically significant improvement. This chart shows the reduction in mean systolic and mean diastolic blood pressure at 12 months in the community-based and the usual care groups. Both mean systolic as well as mean diastolic pressure in the community-based care showed a significantly different reduction compared to the usual care group. However, this was not observed for elevated blood sugar. The mean reduction in systolic blood pressure was 16 mm compared to 9 mm in control group after adjusting for age, gender and baseline blood pressure. The GLM analysis revealed that educational intervention provided by trained healthcare workers was strongly associated with a reduction of both systolic and diastolic blood pressure, while baseline values of blood pressure were also statistically significant predictors. Regarding lifestyle-related risk factors, statistically significant differences were found in favor of intervention group with respect to weight, addiction to tobacco, physical activity, salt intake and compliance to medication. To conclude, community-based care provided by trained healthcare workers demonstrated favorable improvements in control of blood pressure and lifestyle-related health behavior at 12 months follow-up among newly detected hypertension patients. The study was cleared by the IEC of NRS Medical College and received an ICMR extramural grant. Thank you.
Dr. Varsha, please.
Yes, ma'am, can you hear me?
Yeah.
Please unmute yourself, Dr. Priyanka.
Ma'am, can you hear me?
Yes, ma'am. Yes, we can hear you. So this study was conducted in the field practice area or the...
No, ma'am. It was done not in a field practice area. It was, we chose the North 24 Parganas district and from there we chose 25%, that's 6 blocks, by super random sample. It was not a field practice area.
And was this incorporated along with the current screening which is going on along with the national program or was it independent?
This study was undertaken when the screening was not yet started in the blocks that we had undertaken the study. The study was cleared actually long back, 5 years back, but to implement it took another 2 years. So it was done around 17, 18. So then it was actually not carried out as is being done now.
Okay, okay, ma'am. Thank you. That's all.
Thank you,
Thank
Dr.
you.
Thank you, Dr.
Thank you, sir.
Priyanka. Nice study. And it is really, your methodology is really very good. I'm impressed with your methodology. If it was implemented properly, I don't know about the implementation, but there is one more paper on self-monitoring of blood pressure by the community. And that was done in Africa by Novartis Foundation on around 5 lakh population. They involved 5 lakh population. So that is a beautiful study. You can see that on the net. So all the best, dear. Nice presentation. Thank you. The next one is Dr. Kiranjeet Kaur.
Good afternoon, sir.
Good afternoon, madam. Bataiye.
Yes, sir. I'm Dr. Kiranjeet Kaur, and I'm currently working as a project coordinator in a project by UNFPA in PGI Chandigarh.
Good. What is your qualification, basically?
So I have completed my master's in public health, and
Okay.
then
From
thereafter
PGI
from Punjab University, and
Okay.
thereafter I've been working in PGI from about 3-4 years now.
Good. All the best.
Thank you, sir.
Please, technical team, please start the presentation. Yeah.
Effectiveness of webinars for healthcare professionals on management of maternal, neonatal, reproductive and mental health services during COVID-19 pandemic. I'm Dr. Kiranjeet Kaur and I'm a project coordinator in PGI Chandigarh. The COVID-19 pandemic is becoming one of the biggest crises of our time. So stay-at-home directives were issued by the government, and as a result, colleges and universities were closed. Keeping the health professional updated with the latest evidences has become even more important now, and online classes were a key component in maintaining that continuity of education. Webinars are cost-effective, on-demand, virtual equivalent of traditional classroom-based teachings. A study by W. Paul states that online techniques are as good and as satisfactory as conventional ones, but what elements increase this educational value was still not defined. So this study was done with an objective to determine the effectiveness of webinars in engaging and improving the knowledge of healthcare professionals, and to identify the elements that increase the educational value of online webinars. 2 series of 17 webinars were conducted from May to October in 2020. Series 1 contained 4 webinars where no feedback, no certificates, and no post-assessments were done. In Series 2, there were 13 webinars where feedback was taken, certificates were issued, and post-tests were also done in 5 of them. Average duration was 1.5 hours, including 20 minutes of interactive session. They were live telecasted on Zoom and YouTube, and target audience were doctors, nurses, and healthcare professionals. And the promotion of the webinars were done via email, WhatsApp, and other social media. Topics were selected based on the need for providing information on national guidelines and training to the doctors and nurses for optimal management of patient without compromising safety protocols, of course. So some webinars were done on preparedness and management of antenatal, postnatal, and intrapartum care services, including reproductive health and family planning. Some webinars were done on research methodology to assess the evidence-based sexual and reproductive healthcare practices. Both qualitative and quantitative methodologies were discussed. Some of the webinars covered COVID-19 update topics like epidemiology, case management, vaccine update, and some youth-friendly services webinars were also conducted. Measures of effectiveness are proportion of participation, engagement level, that is average minute a person is engaged, or engagement up to 30 minutes, knowledge gain based upon the post-webinar assessment, and the perceived level of satisfaction. Data collection was done on Zoom and YouTube statistics. Post-webinar assessment form, a semi-structured 20 multiple choice questions were given via Google Forms to the participation, which are content specific. And post-webinar feedback forms were also taken, which were general in nature, containing some open-ended and some closed-ended questions, and the entries were kept completely anonymous. Majority of the, so the result shows that majority of the participants were from Maharashtra, and maximum participation was seen in the age group of 18 to 34 years. So viewership and level of engagement shows that series 2 had a better viewership and higher level of engagement. As you can see that the total viewers in series 1 were 835 and series 2 was 3,349, and average views per webinar were also better in series 2. Based on level of engagement, average minutes of participation watched the webinar was more so similar in both these webinars, but we can see that the total messages received in the chat box were higher in series 2 than in series 1. And the knowledge gain based upon the post-test results done in series 2 shows that overall 62.5% of the participants passed the post-webinar assessment tests, and overall 65.9% of the viewers were satisfied with the information shared during this webinar. One of our webinar had a highest percentage, 84.3% of the participants passed the post-webinar assessment test. Regarding perceived level of satisfaction, more than 60% of the participants said that the session delivered information that they expected, and pace and duration of the webinar was found satisfactory to 61.2%, and participants who strongly agreed that queries and questions were addressed satisfactorily were also high. So qualitative results show that the participants said that they will share the evidences with the students and nurses, and the information shared by the panelists, they suggested that it should be standard, and they also suggested that it would have been better to have less time for lectures and more time for interaction, question and answer sessions. So based upon the thematic analysis of the open-ended question asked in the feedback form, we came out with 4 themes. Dissemination of the data, which they said that they will be doing by conducting online and offline education sessions. They said that communication during the session was good because there were multiple platforms involved, old and new topics were discussed, and they suggested that more time should be given to the Q&A round. Content of the session, they suggested, should be comprehensive, practical and clear in formatting, and the teaching methodology should be adopted, which should be effective in terms of language. Short and informative session and evening timings are the best for the session. Some public health implications shows that COVID-19 is not the first and the last pandemic, and crises like these provide an opportunity for medical educators. So webinar facilitate participation, interaction and provide a communication environment, and it can be considered as a rich medium as it utilizes a number of different channels. So important element of an effective webinar are active online participation, utilization of multiple platforms, interaction during the event, pace and duration, user-friendly software, and uninterrupted internet connectivity. To conclude, the webinars served an effective online platform for disseminating information to healthcare professionals on managing maternal and neonatal healthcare services. It got stopped earlier. My conclusion was pending.
Doesn't matter. Nice presentation. Dr. Varsha, please.
Yes, sir.
Please.
Yes, sir. So, Dr. Kiranjit, I must say that I was a participant in all these webinars, in this series of UNFPA webinars.
Oh, that's nice.
Little did we know that we were a part of a study of the research, isn't it?
Actually, yes. Sorry, continue,
yes,
please.
so it will, it was very informative, all the webinars which were conducted. So coming to the study as such, so what is your conclusion as to, are these webinars really useful, or would you actually get more of these qualitative information in detail from the participants? Because most of them, as you can see from your feedbacks that you would have got, would be just a quantitative one, and the qualitative wouldn't be much in detail, isn't it? No one would spend as much time or be more honest. So how about the qualitative part of the study? How effective was it, or how informative was it?
Yes, so to sum up, we received some 5,000 and above entries, qualitative entries based upon our feedbacks forms, and majority of the entries showed that they were effective.
but some parameters some standards needs to be set, like highly professional doctors should be there who are experienced. And they also suggested that the information should be latest and to the mark and precise regarding the topics. And they also suggested, we also find out that in a qualitative findings, more interaction is needed. They said that one of the element that we found out was that majority of them said that YouTube live was really effective, because they can go back again and see the live event again. And if they have any queries during the YouTube, when they watch it, they can also send us an email, and we were able to reply and get answers from the faculty. So webinars served as a really effective method for imparting information, particularly in the webinars that we did. And based upon these findings, these are preliminary findings, we are planning a systematic review in future to basically see what teaching methodologies are being adopted during the COVID-19 pandemic to cater the whole medical education fraternity per se.
Okay, thank you, Dr. Kiranjit. I think this will definitely help us in the future for the future webinars, and all of us can take notes actually from this and improve upon in the future, isn't it?
Thank you so much, ma'am. It was nice to know that you were there. Thank you.
Yeah, thank you so much.
Thank you, Dr. Varsha and Dr. Kiranjit.
Thank you, sir.
But I am not a supporter of webinars in toto. I like offline teaching and offline classes. But yeah, no doubt, in periods of pandemics, this is the only available tool to impart training and to transform the students and transform the knowledge platforms. But you must be hearing a lot of things on the WhatsApp about the criticism of webinars. You must have seen the I don't want to quote. Okay, leave it.
I agree,
But your effort was really appreciable. I organized around 150 to 300 webinars in last 7 months.
Wow.
But I realized finally at the end, I want to quote one study which is not published, which was not allowed to publish for offline sessions. There was pre-test 10% information. There was post-test 95% information. Just immediately after the workshop and or training program. But there was one more post-test after 1 month and 6 months. So people were able to quote the title of the course after 1 month, but they were not able to quote really after 6 months. So at the end, the webinars are not able to create the impact just like offline classes.
Yes, sir.
But we have no choice in this
we have
scenario.
No choice.
We have
This is a big example, sir. Iapsmcon was virtual this year. So
yeah, I really appreciate that. And I really thankful to the organizers for managing such a huge task. I think 2,000 papers are there. I think.
Sir. Right, sir.
Yes. Tremendous task. Yeah, I really appreciate it. Thank you.
All thanks to our HOD, sir, Dr. Amarjeet, and the whole School of Public Health Department. They're doing a really good job in this conference. Thank you so much, sir.
He is champion. I know that. Yeah.
Thank you, sir.
Okay. So the next one is again Dr. Priyanka.
Good afternoon, sir. A very good morning to all of you. The topic for my presentation is perceptions of medical students regarding medical profession. Is there a change during graduation course? Now, brief introduction. So, medicine at its core, it is a human service profession, which means it is a noble profession. Now, when medical students, when they enter this profession, they have a set of perceptions in their mind towards the practice of medicine. Some of the researchers, they have shown that medical students during the course of graduation, they tend to lose their idealistic perceptions. So this highlights the importance of the perceptions in the mind of young medical professionals. So with this background, this study was conducted with objectives to study the perceptions of medical students regarding medical profession at the time of entry and at the end of graduation, to identify whether there is a change in their perceptions during this period and if it is found, to identify the reasons for this change. Now the methodology. It was a cross-sectional study involving retrospective data analysis. The study subjects were undergraduate medical students, and to be more precise, the students who passed their final professional examinations and were about to start their compulsory internship training. Now, just to make it more clear, Department of Community Medicine at our institution, it coordinates the internship training of the MBBS students, and we routinely invite the students at the start of their internship to give feedback about their perceptions and experiences about medical graduation. And based on the inferences of their feedback, we use those inputs to improve our educational programs. This is a routine. So the study tool used here was a self-designed semi-structured questionnaire which we routinely get filled from the students. It was self-administered and kept totally anonymous. It contained information regarding the demographic profile of students, and it contained open-ended questions regarding their perceptions about the profession at the time of entry and after clearing MBBS final exams. And if there was a change in perception, the reasons for change were also asked. Now, we analyzed 457 forms which were filled by the students of 3 consecutive batches in the past 3 years. Now, one student representative from each batch was responsible for collecting the filled forms and handing over them to one of the investigators. This was done to maintain anonymity of the data. Now, to address the ethical issue, the participation was kept totally voluntary. The data was kept confidential. The form was anonymously filled with no personal identifier. The permission to conduct the study was obtained from Institutional Ethics Committee, and because it involved analysis of retrospective data with no personal identifier, a waiver of written consent was also obtained from IEC. The data analysis, the responses were filled usually in a few sentences. So they were in their own verbatim. It was read many times by 2 independent investigators and categorized into similar thematic areas, which was later on grouped to deduce meaningful information. Now, any discrepancy in identifying the themes, it was resolved by discussion and mutual consensus. Now, coming on to the results, Table 1 shows the demographic profile of the students. The mean age of the participants was 22.8 years with a standard deviation of 0.76 years. Majority of the subjects belong to urban areas, and about the education of father and mother, the parents of majority of the students, they were either graduates or above. Now, Table 2 shows the perceptions of students regarding the medical profession. Now, here we identify 4 main perceptions. So, first is they considered this profession to be prestigious and respectful in the society. Second, that it is meant for serving the people. Third, that it is capable of huge financial earning. And fourth one, that there is an ease of getting an employment in this profession. Now, here we can see that at the time of entering the profession, a majority, almost 3/4 of the students, they considered that it is prestigious and respectful, and a slightly lesser proportion, they considered that it is meant for serving people. Now, the issue of financial earning, it was concerned to a lesser proportion of students, and a further lesser were concerned about the ease of getting an employment. While at the end of graduation, we can see that the almost 50% they considered it to be prestigious and respectful in the society, and similarly almost 50% considered that it is meant for serving people. So there is a remarkable drop in these 2 areas. While now 68% of the subjects, they considered the ease of getting an employment as their perception regarding the medical profession, and more than 50% they had the perception that it is capable of financial earning. So here we can see that now more of the subjects, they were concerned about their jobs and the earnings. Now, when asked for the reasons for change, almost 3/4 of the subjects, they said that this profession is very stressful, and similarly they were also worried that this is very challenging but comparatively less rewarding. More than half of the subjects, they said that It is difficult to maintain work-life balance, and a small proportion of the subjects they were concerned that it takes a very long time to settle in life. Now, to conclude, there was a change in students' perception at the end of graduation as compared to the time of entry. Their focus shifted from being in a respectful profession and serving community to getting jobs and earning money. Stress, challenging but less rewarding profession, and difficulty in maintaining work-life balance were the main reasons cited for this change. Thank you.
Thank you, Dr. Priyanka. Really a very innovative title. I should say that out of the 5, it's really very innovative. And you did very well. Dr. Varsha, please.
Yes, sir. I was very much interested from the beginning because, as Sir said, it is really a need of the hour to identify how actually our medical students perceive our medical education, and it definitely drops from being a respectful position or serving the community to earning based on the current situations and times. So, as ma'am said, that this like study or this feedback is being taken from many years, isn't it?
Yes,
So,
ma'am.
ma'am, is there any actions taken to manage the stress of the students, or is there any particular implications of this particular feedback which is being taken or action taken based on this?
Yes, ma'am. Actually, we routinely take this feedback, and there are some other aspects in this feedback form also, other than this one which I have presented. So we routinely analyze it, and then we try to improve our educational programs. So based on this, we have recommended that there should be focus on extracurricular activities in the medical schools, which is very important because we are just students. The curriculum is very large, and the students, they are already overburdened. So it is a need of an hour that extracurricular activities, we should have a focus on sports or some other activities, some cultural activities, so that the students, they are able to better manage the stress level. And plus maybe with CBME now there is a shift in our teaching style also. So that may probably also help in reducing stress for the students.
But Dr. Priyanka,
Yes, sir.
one wonderful finding was there that they were able to command something on financial aspects. What sort of MBA you are providing in this MBBS course in Lady Hardinge Medical College? And NHFW will miss that.
No, sir. It was just that emerged as one of the themes that when we asked about their perception, some of the students they had written about because by the end of MBBS, then they are concerned about getting a seat, PG seat, and then for choosing the specialty, we have found that the students, they take into consideration the financial aspect. They prefer the specialties which are better earning.
Okay,
this is a fact. And
at least some positive aspects, hidden positive aspect in this period of money earning or money crisis, or because our branch is evergreen branch, unaffected by the financial crunch and other things, no doubt about that. But feeling of this that we will be able to earn more hugely, that is really very very good finding. I appreciate that, and convey my regards to your co-authors. And beautiful presentation. Thank you. So friends, with this, I'm really thankful to all the presenters, and I'm thankful to organizers. I'm really appreciate the mentorship of Amarjit sir, who given such sort of platform to me and my presentees for sharing the scientific information and scientific thoughts on this virtual platform. And I appreciate Karanjit, Varsha, Vivek, and specifically Madam Nimran, which was coming frequently. And Maltesh, your presentation was also very good. And thanks to all. Thanks for this scientific treat. Thank you, friends.
May I take your permission to propose vote of thanks? And also,
please, Vivek. Please, Vivek.
Yeah, so it is honored to propose vote of thanks. Thanks to Chairperson Dr. Manish Chaturvedi and also Dr. Varsha for co-chairing the session. And thank you to speakers for wonderful lectures, and also all the delegates who have joined the session. Our HOD, Professor Amarjeet sir, who is here also. And I want to thank Dr. Kadrival also for putting all the abstracts in a place so that we can conduct these sessions very smoothly.
Okay.
Yeah, and also to our team, and also the vendors who is doing all this technical help for us. Thank you, everyone. And
Vivek, are you taking help of some event management group for this?
yes, sir.
Okay, okay, that's beautiful.
Yes.
Otherwise, that reduces some sort of respect to all the professionals available in PGI. But no doubt, I can think of that. But there should be some team manager. Yeah,
Yeah, we need to do that.
Event manager should be there. Yeah, beautiful. Thank you, Vivek, and thank for the vote of thanks. Thank you, Varsha, again, and
Thank you.
Yeah, please.
I'm elated at the opportunity to interact with the chairs. I would now like everybody to switch on their videos so that we can have a photograph together. With a thumbs up. Everybody, please switch on your videos.
With mask.
Nimran sir.
Nimran, with mask, without mask. What sort of
There are
message you
many
want to
people,
give?
sir, here.
Okay, okay, doesn't matter. Please go ahead.
Done.
Done.
Thank you so much.
Thank you. Thank you, dear.
Thank you so much for the opportunity. Thank you so much, sir.
On a
Thank you.
website,
All the
there
good
is a Mahasangam session also. So all the participants can look that Mahasangam. There is a lot of cultural activities there. So on the website, yeah, we have kept that one slot there. So I request all the participants to go through that also, because that is.
Okay. Well, in continuation of this particular on this the same platform, or I have to do some other link.
No, sir. There is other sessions also going on to the same.
Okay. Yeah. All the best.
So
Bye-bye.
Nimran, you can take over now.
Yes, sir. Thank you, sir. Now I am inviting the chair for the subsequent session, Dr. Anmol Gupta. He is a professor and head of IGMC Shimla. Sir is working in non-communicable diseases specifically for elimination of tuberculosis. He has more than 100 publications in journals of repute, and his important contribution is in the project of SDG WASH. Welcome, sir. I would also extend my warm welcome to our eminent co-chair, Dr. Himanshu Nigandhi. He's additional professor, Public Health Foundation of India. His research interests include human resources in health, education, health professionals, and program evaluation. He has over 15 years of experience in public health practice and research. He has served as a doctor in an urban metropolitan hospital, and he's the course coordinator for MPH program in IIPH Delhi. More than 40 publications in national and international journals. We welcome you, sir.
Okay. Thank you, Nim and Dr. Himanshu. You're welcome. Good afternoon. Am I audible?
Yes, sir, you're audible.
Okay. So we are starting this session. This session is on communicable disease, and I welcome Dr. Himanshu from Public Health Foundation of India. We have got 7 e-oral papers in this session, and I think most of them, they are present here, and every speaker will get 7 minutes to speak, and then they're followed by 2 minutes discussion. So may I take this opportunity to start with the first speaker? Himanshu, can we start? Or you want to say something?
Sir,
Dr.
we'll go by
Himanshu,
your
please.
advice. No, sir. Please, I think you've already given us a good prelude. And without wasting any further time, let us dive deep into the presentations and listen to what our presenters have to say.
Okay. So we are starting with first presentation, and the first presentation is by Dr. Rashmi Sharma. And the topic of her presentation is an operational research on depression among multi-drug resistant TB cases registered under national program in Ahmedabad city. Rashmi Sharma, please go ahead.
Good afternoon, everybody. The title of my study is Prevalence and Determinants of Depression Among NDR-TB Cases in Ahmedabad City. This was an operational research which was supported by State TB Department of Gujarat, myself, Dr. Rashmi Sharma, who is the presenting author of this study. As we all know that NDR-TB cases are resistant to rifampicin and isoniazid with or without resistance to other first line of drug. In the year 2019, world over 5 lakh cases developed drug resistance TB and 78% had MDR TB. And India has the largest share, which translates approximately 1,30,000 such cases. Due to prolonged treatment, multiple drugs, they are more at risk of depression. MDR TB, when compounded with depression, has low adherence and poor outcome. PMDT guideline recommends screening for mental illness at baseline and subsequently, but as such in real life there is no inbuilt system to monitor how it is being done. With this background, following objectives were framed. Number 1, to study the prevalence and determinants of depression among adult MDR TB cases registered at TU of Ahmedabad City to explore the current strategies under the program and suggest remedial measures. Methodology includes mixed method where quantitative and qualitative method was there, and reference population includes all adults MDR TB cases registered at NETU of Ahmedabad City during July 2018 to June 2019, and those who are already having psychiatric illness prior to registration not willing to participate were excluded from the study. Methodology includes for quantitative component based on the prevalence of 60% of depression among MDR TB cases from a study in India Hospital at 95% confidence interval, 80% power, 10% relative error, which came out to 228. After adding 10% non-response rate, final sample size was 251. Sampling technique was probability proportional to sample size from all 23 TUs. For qualitative component, in-depth interviews were conducted from 26 medical officers, including supervisors. This data was collected from January to October 2020. For quantitative component, the study tool was field tested, structured questionnaire in Gujarati for collecting socio-demographic details, other morbidities by means of interview. For screening depression, Gujarati version of Hamilton Depression Rating Scale was used. For quality control, all investigators were trained by Secretary Department for administering Hamilton score under the field situation. We got approval from Institutional Ethical Committee, and patient identifiers for removed data was password protected. Those who are having Hamilton scale more than 7 were linked to nearby secretary services. Out of 251, 185, that is 74, could be interviewed. Rest were not interviewed. They largely include 47 expat cases. Age-wise, mostly they were adult from 18 to 45 years. Only 2.7% were more than 60 years. They were more male than female. Education didn't show any pattern. Occupation-wise, mostly female were housewife and male were unemployed or engaged in un- or semi-skilled job. 81% were from social class 2, 3 or 4. Very few were from class 1 or class 5 social class. Regarding vulnerability factor, out of 185, 98 had past history of tuberculosis, only 23% could complete their treatment, and 9.7% had no active TB case within their family. Stressor, mainly financial and social, were observed. 30.8% had one or more type of addiction, mainly tobacco and alcohol. 69% faced troublesome issues, mostly due to adverse event, long duration of the treatment, and number of pills. 87% experienced one or more adverse event, and in 23% cases, it also included grade 4 type of adverse event, which is very severe in nature. Out of 185 screened for depression, 18 had mild depression, 4 had moderate, and 3 had severe, and 1 had very severe type of depression. 4 of them recovered from the depression at the time of interview. So overall prevalence came out to 16.2%. Then we studied what are the factors which are associated with depression. Then it was found that after doing univariate analysis, following factors were found statistically significant, like family issue, discrimination, financial stress, anorexia, pruritus, sleep disorder. Ethanolamide shows protective effect, so it was negatively associated. and much thought of the drug cyclosporine, it was not found statistically significant. These were the statements given by a few of the cases with depression, like wouldn't like to talk to anyone. No one in the community is willing to sit me. While talking to me, they keep a distance. Initially, I almost went mad. People used to say that I should be sent to mental hospital. Another dimension of the study was to know the perspectives of service providers. So in-depth interviews showed that most of them don't do screening for mental illness. They believe that it is done at Dot Plus Center by counselor because of lack of time or adequate space. Whenever it is done, it is unstructured, subjective, without using any checklist. One third had no idea about what is the proportion of depression among MDR TB cases. Rest believe it varies from 1 to 50%. More than one-fifth had no idea for any modification which is required while treating MDR-TB cases. Most of the medical officers, they refer to the nearest DRTB center, and only few first refer to the counselor. But in real practice, when we asked how many cases have you referred in last 1 year, half of them didn't refer any. This was when all have been trained in PMDT guideline. So it can be concluded high prevalence of depression was seen among MDR TB cases and more associated with adverse event or stresses. Both medical officer and counselor need to be trained on high mental scale to assess the depression. There is a need of involvement of psychiatry department from medical college wherever possible for mentoring, handholding, and monitoring of the program. These are the limitations and these are the references. Thank you very much.
Sir, you're muted. Sir, you're muted.
Thank you, Dr. Rashmi, for completing in time. And I request all the participants to note their questions in the chat box. We didn't get any question in the chat box, but Rashmi, you belong to which college, institution?
Sir, I am Associate Professor in GMERS Medical College, Sola, Ahmedabad.
Okay, Sola, Ahmedabad. Rashmi, what were the qualitative component of your study? Qualitative.
Basically, as per the primary objective, it was quantitative in nature, but to complement the quantitative study, we have taken qualitative component to know the perspectives of service provider, what are the challenges, what are the bottlenecks, what are the reasons they face, and those 26 cases which came out as suffering from depression, we took their experience through open-ended question, and they were also asked what is their experience and rank it as per the Likert scale, whether they feel good, very good, bad about RNTCP program, and what they experienced during their illness as any stigma, challenges. So some quotes were, some statements were quoted in my slide.
Okay, that is verbatim. Have you done any focus group discussion in that? No. Only IDI?
No, sir. No, sir. Our
Only
medical
that was not the
were
part.
interviewed through thematic guideline.
Okay. Thank you, Rashmi. Dr. Himanshu, please. Dr. Himanshu? Sir?
Sorry, I seem to have a little bit of a break there in the connection. Thank you, Dr. Rashmi, for a very fantastic presentation. I would just like to say one thing. That when we are talking about improving any program, you've added a very important dimension to it. Before we make any assumptions, we have to learn the facts. Before we pass any judgments, we have to understand why. Your study was nice and novel, that it was at scale, included multiple TUs. And I'm very happy that as part of operations research, that the TB program is funding and supporting. This is a fantastic work that has been undertaken. There's clear program and policy implication.
Thank you so much, sir.
Thank you very much.
So, thank you, Rashmi.
Thank
now
you,
we are
sir.
starting with the second participant, and second participant is Dr. Vidya. And the topic that she is going to cover is the assessment of patient compliance to daily regimens of DOT therapy and factor influencing the non-compliance in Bengaluru. Dr. Vidya, you can start. And I request to the other participants, if they have any question, they can write it in the chat box or can ask directly after the presentation.
Good morning, everyone.
My topic today is assessment of patient compliance to the daily regimen of directly observed treatment short course therapy and factors influencing the compliance in Bengaluru Rural District. My name is Dr. Vidya R. So coming to the introduction, tuberculosis is a disease present globally and has become a global health problem with an estimated of 10.4 million new cases worldwide in 2016 and 1.7 million deaths. The recent update in tuberculosis treatment by the RNTCP in 2017 has changed the DOTS treatment schedule from alternate day regimen to the daily regimen. Up to half of all of patients with TB do not complete treatment, which contributes to prolonged infectiousness, drug resistance, relapse, and death. One of the objectives for introduction of daily regimen in TB treatment was to improve the treatment compliance. This study studied the level of compliance amongst tuberculosis patients and the factors affecting the compliance. So the objectives of the study was to determine the compliance to daily regimen of DOTS therapy among tuberculosis patients registered in tuberculosis unit in Devnalli, Bengaluru Rural District, Karnataka. To identify the factors influencing non-compliance for the treatment amongst the same. So coming to the methodology, the study design, it is a cross-sectional study. The study was conducted amongst patients registered in the tuberculosis unit in Devnalli, Bengaluru Rural District, Karnataka. The study duration was for about 6 months from February 2019 to July 2019. The study population were all the patients who were registered and undergoing treatment under the new daily regimen of DOTS in tuberculosis unit in Devnalli, and those who have also completed the treatment or have finished the treatment course or have even been lost to follow-up, and this was in Bengaluru Rural District, Karnataka. So the selection method, all the patients who were undergoing or had undergone treatment for tuberculosis from the tuberculosis unit in Devnalli were part of this study. Amongst these, 10% of the patients were chosen using simple random sampling to be interviewed during the house visit. So the sample size was 202. This was the entire number of people who were on the new daily regimen treatment in Devnalli. And amongst them, 41 patients were selected for the interview after obtaining consent from them. So the inclusion criteria the first inclusion criteria was all patients registered in the tuberculosis unit in Devnalli, Bengaluru Rural District, Karnataka, who were aged between 18 and 60 years. And the second inclusion criteria was all patients who have been on treatment for a minimum period of 1 month as on the date of data collection. So the operational definition of non-compliance was that any patient who has missed more than 2 doses in a month were considered as non-compliant to the treatment. The study was conducted in 2 parts. So the first part was treatment form data, which was obtained from the treatment cards which were available at the tuberculosis unit in Devnalli. The second part was the patient interview, which was collected by interviewing the patients during the house visit after obtaining a written consent from the patient. So coming to the results, the socio-demographic profile, when it comes to age, most of our population, that is 57.9% of the population, fell between 31 years to 60 years age group. Amongst the gender, 66.8% of them were male. 87.6% of our patients were belonging to the Hindu religion. 96.5% of the patients were on category 1 treatment, and 90.1% of them did not have any history of previous TB treatment. So in our study, we found out that the compliance amongst these patients was about 88.6%. So when we started assessing the factors associated with compliance, first thing we assessed the age, and it was found to be not significant. When we assessed the sex, we found that it was statistically significant and was associated with compliance. When it came to religion, it was again found to not be associated with compliance. Coming to the previous history of treatment, that is, if the patient was having history of TB and treatment for TB previously, it was found that it was statistically significant and was associated with compliance. When it came to category of treatment, again, whether it was category 1 or 2, it did not play a role in associating with compliance. The knowledge about
TB treatment, that is regarding the duration of the treatment, also played a role and was associated with compliance, and the p-value was found statistically significant. The side effects of drugs also played a major role, and it was found that it was statistically significant and was associated with compliance. Improvement in symptoms after starting treatment. This led to discontinuation of treatment in many people and was found to be statistically significant. Alcohol consumption also played a role. It was found to be statistically significant and associated with poor compliance. Smoking did not play any role, whereas unwillingness to take medication daily was found to be statistically significant and associated with non-compliance. Administration of the drug by A&M and ASHA or by self did not play a role. They were all, any of them, whoever administered, it did not play a role. But visit from healthcare workers, it was found that people, when doctors visited, there was a higher chance of compliance when compared to nurses or ASHA workers. So based on these, the implications and conclusions were that compliance to TB treatment was high after introduction of the daily regimen. So improving the knowledge of the patients regarding TB treatment, regarding the duration of TB treatment, and counseling at the time of start of treatment regarding the necessity to continue the treatment irrespective of improvement in symptoms, and reduction in the alcohol intake during treatment, and contacting the medical officer in case of any kind of side effects, so that the doctor can counsel them or change the treatment, and common side effects associated with the drugs can improve the compliance. Regular visits or consultations from the medical officers can also improve the compliance amongst patients. Thank you.
Thank you, Dr. Vidya, for nice presentation on DOTS therapy and factors influencing the non-compliance in Bengaluru. How many factors did you study?
Sir, I studied about, actually my questionnaire consisted of about 65 questions, out of which the various factors included included the socio-demographic history and about all the various aspects such as distance of the DOT center or distance from, the patient, whatever they have to travel, regarding all that, and regarding the drugs and their side effects, and also regarding their basic knowledge about the treatment and nutritional aspects. I even actually included a HIV component, whether people who are HIV TB associated, HIV TB collaborated cases, but then there was no findings in that, so I haven't included it in this study.
Thank you, Dr. Vidya. Dr. Himanshu, please.
Observation and a comment. Vidya, I see the work was done in 2019. You're presenting it 1.5 years later.
Yes, sir.
Do you think anything has changed in the program in the interim period, which has probably addressed some of the limitations and handicaps that you have highlighted? And point number 2.
Probably yes, sir, because first thing is that when I was doing the study, this newer treatment regimen, that is the daily treatment regimen, was still a little new because it was introduced only in 2017. So it was still a little new. So because of that, I believe that there were some hiccups initially, but now as the time goes by, all the program officers, they start realizing that what are the drawbacks, and they keep continuously making these changes. And as far as I know,
Thanks, Vidya. I mean, that satisfies me. But my other question is for you to think over. Yes. It's that once the daily regimen has now come in, do you think there is a change in the attributed factors which are actually causing the side effects? Do you think that has changed in any way substantially or not? That could be scope for further work. Thank you very much.
Yes. Thank you so much, sir.
Thank you, Vidya and Dr. Himanshu. Now we'll start with the third presentation. And the third presentation is the assessment of on implementation of antimicrobial stewardship program in Karnataka, a situation analysis by Dr. Apurva E. Patel. Dr. Apurva, you can start.
Greetings. The abstract ID is 09399. My name is Dr. Apurva E. Patel. The title of the study is Assessment on Implementation of Antimicrobial Stewardship Programs in Karnataka, a Situational Analysis. co-authors being Dr. Sunil Kumar Diyar and Dr. Girish Talanki. Introduction. Antimicrobial resistance threatens the very core of modern medicine and the sustainability of an effective global health response to the enduring threat from infectious diseases. Without harmonized and immediate action on a global scale, the world is heading towards a post-antibiotic era in which common infections could once again kill. A growing body of evidence demonstrates that antimicrobial resistant stewardship programs, or AMSPs, are found helpful in improving the quality of patient care and safety through increased infection cure rates, reducing treatment failures, increasing the frequency of correct prescription for therapy and prophylaxis. The study was conducted with the objective to assess the level of implementation of antimicrobial stewardship programs in various tertiary care hospitals across Karnataka, including the corporate hospitals. Materials and methods. A cross-sectional study was conducted between July and November 2019 in 20 tertiary care hospitals across Karnataka, which included 10 corporate hospitals and 10 private medical college hospitals. Members of the Hospital Infection Control Committee, or the AMS committee, were interviewed using WHO checklist of essential healthcare facility core elements for AMSP in low and middle income countries. View of the head of the Hospital Infection Control Committee was considered as final. Data was collected and analyzed. The situational analysis for AMS readiness focused on the following aspects: structures, policies and guidelines, human resources, antimicrobial use and resistance data, AMS activities. Results are as follows. Structures, policies and guidelines. Overall, 65% of tertiary care hospitals have AMS committee, which included 80% of corporate hospitals and 50% of private medical college hospitals. They also have an action plan or a written document for ensuring the appropriate antibiotic use and specific recommendations with antibiotic selection for common clinical conditions based on the national guidelines. Second aspect, human resources. Key support was provided by clinicians, microbiologists, nursing and quality improvement staff in 61.5% of the tertiary care hospitals, included all the corporate hospitals and none of the private medical college hospitals. Only 30.7% of the tertiary care hospitals have either a dedicated physician or microbiologist as an AMS leader, which includes their 50% of the corporate hospitals. None of the private medical college hospitals have a dedicated physician or microbiologist AMS leader. Third aspect, antimicrobial use and resistance data. Overall, 38.5% of tertiary care hospitals, which includes 50% of the corporate hospitals, receive dedicated financial support for AMS activities, which include laboratory and imaging services to support AMS interventions, production of facility aggregate antibiograms, sharing specific reports with the prescribers. None of the private medical college hospitals receive any form of financial support for the AMS activities. None of the prescribers receive any personalized communication regarding specific reports. No trainings are being conducted for optimal antibiotic use in any of the facilities. Fourth aspect being AMS activities. Only 30.7% of the tertiary care hospitals, which includes 50% of the corporate hospitals, performed regular audits on the compliance with the AMSP guidelines and review of prescriptions at the respective facilities. None of the private medical college hospitals performed audits. None of the facilities did adhere to specific treatment recommendations. Implications and conclusions. Overall, the compliance to AMSP was very low in both the type of settings, although Corporate hospitals have implemented AMSP better than the private medical college hospitals. Our study shows that despite the advocacy by WHO and the clear directions by Government of India, implementation of AMSP is still at a budding stage in our country. This is quite alarming and could lead antimicrobial resistance to be the future global public health threat. AMSP can actually help the clinicians improve their clinical outcomes by optimizing the use of antibiotics. Hence, it is the need of the hour that our government mandates on the better implementation of AMSP for the accreditation of the healthcare facilities. The government should also take stringent actions against those healthcare facilities without the AMSP, which in turn would go a long way in reducing the antimicrobial resistance in the country. Thank you.
Thank you, Apurva, for your wonderful presentation. May I know why why the compliance was low in AMSP? Did you try to find it out? Apurva, are you able to listen me? Hello?
Please unmute yourself.
Yeah, Apurva? Not able to listen her. Unmute.
You're not audible.
Okay, Himanshu is not audible. She is not audible, and we have no questions in the chat box. Any comments from your side, Himanshu?
Sir, Dr. I think Ritu Mishra wants to ask something. She has raised her hand.
Okay.
So I guess she has a question.
Ritu, go ahead, please. Ritu, go ahead. Yes.
Yes, Dr. Ritu Mishra, was there a query or was it? Dr. Apurva, you're not still audible. Either remove your headphones, remove the headphones, try to remove them. Speak directly with the computer.
I think she stepped out. Maybe we can move on to the next candidate in the interview.
Hello, Dr. Himanshu, you have the list? Hello?
Yes, sir.
You can introduce the next speaker.
Sure.
If you have the list. Okay, Himanshu, please.
So can you introduce this one person? I'll introduce for the next one.
Okay. So next is the Nagamba Akam, and is going to present the patient and health system delay among the pulmonary tuberculosis cases, a cross-sectional study from Imphal, East Manipur.
Yes,
Dr.
sir.
Nagamba, you can start your presentation, please.
Please start with the next presentation.
Warm greetings and welcome to all. The title of this presentation is Patient and Health System Delay Among Pulmonary Tuberculosis Cases, a cross-sectional study in Imphal East, Manipur. Myself, presenter, Dr. Ngamba Akam, a postgraduate trainee at Community Medicine Department, Jennings, Imphal. Coming to introduction, India has the highest TB burden in the world with an estimated incidence of 26.9 lakh cases, which account for 2/3 of the world total TB incident cases. And out of this 26.9 lakh, 24 are notified, giving a notification rate of 89%. Despite the existence of effective drugs and treatment regimen, TB happens to be the most persistent important public health issue in India. This is according to India TB Report 2019. An infectious pulmonary tuberculosis case can infect 10 to 15% in a year. Now, according to National Strategic Plan of TB 2017 to 2025, they are targeted at a reduction of TB incidence 80%. The delays in diagnosis and treatment is not being considered as indicator for program evaluation. Coming to the Manipur picture, 2,553 incident cases were identified in 2019 according to India TB Report 2020, giving a notification rate of 86 per lakh population, although the estimate was 94 lakhs. The studies regarding exploring risk of delays in diagnosis and treatment is scarce in Manipur, and hence the need of present study. The primary objective is to evaluate delays in diagnosis and treatment among pulmonary tuberculosis patients, and secondarily to test association of delays with selected variables. Coming to materials and method, the study was a cross-sectional study and setting was community-based study. The study population is among registered TB, pulmonary TB cases registered under District TB Center, Imphal East. The study was conducted from November 2019 to November 2020. Participants aged more than or equal to 18 years and who gave consent were included in the study and excluded those who were not able to contact after 2 home visits critically ill or mentally unstable patients. The sample size was calculated to be 105, considering a previous prevalence of 50.98%, according to Bhatt A.N. et al. At 95% confidence interval, considering an allowable error of 10%, taking non-response rate 5%. The sampling design, the Imphal East district was chosen by adopting the convenient sampling method, and the eligible participants were consecutively enrolled from the registered sequence from the District Tuberculosis Center until the required sample size was reached. A pre-designed, pre-tested, semi-structured interview schedule was used as a study tool. And regarding the operational definition, a patient delay is considered if the period from onset of first symptom or symptoms of suspected pulmonary tuberculosis to death, when patient first contacted any healthcare services facility more than 30 days. Healthcare system if the period from patient's first contact with a healthcare service to date of final diagnosis and initiation of anti-tuberculosis treatment more than or equal to 7 days. Moving on with the results, the number of participants was 104, giving a 99% response rate. The mean age of participation was 50.15 with a standard deviation of 16.6 years and giving a median age of participation 52.5 years. The median patient delay was 36.5 days and the median system delay was 14 days. Coming to table number 1, which describes the characteristics of study participants, considering the first variable, sex, male constitute more than 80% of the participant. And the secondary level of education, it gives 40% of the participants. Regarding place of residence, 70% were from the urban, and around 70% of the participation gave negative history of smoking history. And regarding socioeconomic status, more than 60% of them belong to upper middle class, giving according to BZ Prasad classification. And coming to table number 2, it describes the logistic regression of analysis of risk factor for patient delay. Now, let's look here at the place of residence. A rural place of residence has 70% less likely to have patient delay compared to urban place of residence, and it is statistically significant. And regarding education level, secondary level of education is found to be 70% less likely to have patient delay as compared to participation with no formal education. Coming to third table, which describes the determinants of health system delay, here the place of residence is found to be associated with the health system delay, giving a chi-square value of 6.43 and is found to be statistically significant. Now, coming to the conclusion, according to the study, the prevalence of median patient delay was 36.5 days and health system delay 14 days, and it is found out that lesser risks of patient delay with higher level of education and rural residents, and the risk of health system delay is associated with the place of residence. Coming to the recommendation, public health education and awareness such as mass education and health camps, they can bring down barriers in healthcare seeking, barriers such as stigma, knowledge of the disease, and health facilities provided under various schemes. This will help them sensitize, and intersectoral coordination such as public-private partnership in disease notification, treatment, and IEC activities in the rural areas can help strengthen services and resources, especially human resources, to narrow down delay and reduce transmission. This brings to the end of my presentation. Thank you.
Thank you, Dr. Akam. That's really a nice piece of work and a very interesting question that you've highlighted from Manipur.
Thank you, sir.
Could you let us understand a little better as to why do you think the patient delay continues to be over 1 month long in a state like Manipur, where we believe that there is a lot of awareness within the local population as compared to some other states? Could you highlight upon those couple of issues, please?
True, sir. Some of the important issues can be due to lack of when the patient perceptions regarding these common respiratory tract infections, when they overlap with the tuberculosis patient, when they cannot segregate out, or maybe because of their health seeking behavior, they do not understand the gravity of the situation. Perhaps this some of the highlights.
And what are your understanding about the 2 weeks of delay that is happening in the healthcare facility? Is it more of an issue of training, or is it a question of capacity?
I believe it is the capacity because of constant referral, especially from the private sector to the public sector. The time gap is almost there.
All right, thank you. Do we have any comments in the chat box? Any questions? Professor Anmol, sir?
Thank you, Dr. No questions.
Okay.
Go ahead.
Thank you very much, Dr. Akam. Now, can we have the next presenter, please? Can I request Dr. Reena Mohan to talk about the loss to follow-up during diagnosis of tuberculosis patient using a mixed method design?
Good afternoon. I'm finally a postgraduate, Department of Community Medicine. I'm Dr. Reena Mohan. I'm here to present an oral paper on the topic loss to follow-up during diagnosis of tuberculosis patient, a mixed method study on determinants and potential solutions. Coming to the introduction, as we all know, tuberculosis has remained as a major public health problem. Tuberculosis patients who are lost to follow-up have high mortality rates and can spread infection to other people in the community. Loss to follow-up can occur at multiple stages of TB care pathway. Those includes patient who received a diagnosis of tuberculosis on basis of only one sputum smear positive and who failed to provide second sample are known as loss to follow-up during diagnostic period or diagnostic default. Coming to the objective of the study is to find out the factors that influence the loss to follow-up during diagnostic period among the TB patients and to explore the stakeholders' perspective, the challenges and solution to reduce loss to follow-up cases. The study protocol was approved by Institutional Ethics Committee of SMEMCH. Sequential explanatory mixed methods study was carried out. The study was held at designated microscopic center of Sri Manaklava Nagar Medical College under the supervision of RNTCP State Task Force. For quantitative method, record-based cohort design was adopted to extract the determinants of loss to follow-up cases. And for qualitative method, in-depth interview from loss to follow-up cases and free listing was done with stakeholders to identify the challenges faced. Coming to data source and collection, the smear positive pulmonary TB patient was extracted from RNTCP laboratory register and TB notification register from period of 2014 to 2018, and it was found 1678 patients were positive for pulmonary TB, and among the 1678, 90 patients were lost to follow-up cases. To know the reasons contributing to outcome of loss to follow-up during diagnosis was explored by conducting in-depth interview with lost to follow-up patients, and these patients were purposefully selected. Free listing was conducted with stakeholders. They were TB health visitor, senior treatment supervisor, laboratory technician, and core committee member were asked to list down the measures taken to reduce the proportion of single sputum sample at SMVMCH. And data was entered and analyzed using EpiInfo version 7 software. An audio recorded transcript from in-depth interview were transcribed into English, and transcription were proofreaded and edited before it was thoroughly read, and manual content analysis was done. Statements were quoted in italic, which indicates the direct statement from the participants. Consolidation criteria for reporting qualitative research guidelines were used for reporting the findings. So coming to the results section. So in this table, it is clear that among 1,678 positive TB patients, 90 patients were lost to follow-up of cases. And majority of lost to follow-up cases were found to be adults, and next the pediatric age group, and around 8.8% were residing from more than 75 kilometers from the hospital. And on adjusted analysis, it was found that people residing from more than 75 kilometers from medical college and year of diagnosis were identified as significant risk factor for positive pulmonary TB patient to become lost to follow-up during diagnosis. So this figure 1 shows the trend analysis of year-wise distribution of cases. We can see clearly that in 2014 and 2015 there was increase of loss to follow-up of cases, which was steadily declining because of the interventions taken by the stakeholders. So table 2, which states the key statement emerged from in-depth interview, and among in the in-depth interview conducted among the patients, 5 categories. Main reason for not giving second sputum sample and for not starting on treatment were the lack of awareness about the TB, and second category was addictions. People were scared if they start treatment they will not be able to drink alcohol, hence they didn't want to give second sputum sample and not start treatment. And third category emerged was stigma towards TB, and most of the patients stated that they were feared that their own family would neglect them. And fourth category emerged was employment related barriers. People were scared that if they start TB treatment, they will not be able to go work, and people will be thrown out from the work. And fifth category was perspective on drug side effect. People were scared about the size of the tablet and the side effects. So table 3 illustrates stakeholders' response evolved from free listing. So these were the interventions adopted by stakeholders to reduce this loss to follow-up cases. Some of the important interventions were counseling was given to TB patients during first sputum sample, and counseling was also given to the caregivers. Phone calls were made to the patients, and if phone numbers were not there, alternative phone numbers from nearby houses were also collected. And very important is house visits were made by TB health visitors for Puducherry patient to make them treatment adherent. And disclosing the result was done only after receiving the second sputum sample, and second sputum was received with a gap of 2 hours apart from the patient if they are coming from distant places. So coming to the conclusion, the proportion of loss to follow-up of TB patient was less than 5.3% when compared to other studies. Identified risk factors were male gender, increased age group, and people coming from far distance. Intensive active measures taken by stakeholders could have been the reason for decline of loss to follow-up cases. Hence, proper counseling at multiple levels will help in reducing the loss to follow-up cases and will ensure treatment adherence and help to move towards ending TB by 2035. Thank you. These are my references. So hence, we should all join hands and help the world to move towards TB free. Thank you.
Thank you very much, Dr. Reena, for highlighting an issue that all program managers should be very carefully paying some attention to. I have a few questions for you from my side first before I open it up for the rest of the people here in this room. Number one, could you highlight as to what was the theoretical approach towards doing the qualitative analysis of the in-depth interviews, and what were the thematic areas that actually emerged? And the second question is, if you were able to get hold of the LTFUs, why couldn't the system locate them at that time?
Sir, am I audible, sir?
Yeah.
So, can I answer the first question? Second one,
Yes,
I didn't.
please do. Please do.
Please switch on your video too.
Ma'am, it's on, ma'am.
Anyways, answer first question, please.
Okay, ma'am. The thematic areas were lack of awareness, addictions, stigma, employment-related barriers, and drug side effects, sir.
Okay, and the second question is, if you could trace the LTFUs, why couldn't the government do it?
So now the scenario has totally changed because of the initiation of Nikshay. Previously, there was delay in hospital side as well as patient.
All right. My only suggestion for improvement would be that when you're presenting a graph with raw numbers, instead of doing that, please present the rate of LTFU rather than giving us raw numbers of LTFU. The rates would be far more informative.
Sure, sir. Thank you for the input.
Professor Gupta, sir.
But, thank you. I have the same comments as Dr. Himanshu. Thank you.
Yes. Thank you, sir. Thank you for the opportunity.
Okay. Thank you. Thank you, Dr. Reno. Can I now have the next speaker, please? Dr. Parth Modi, who is going to be talking to us about the utility of mobile phones for health communication among TB patients. Can we start the next video, please?
Please start Dr. Parth's video.
Myself, Dr. Parth Modi, second year resident doctor from Department of Preventive and Social Medicine, Medical College, Baroda. The topic of my oral presentation is utility of mobile phones for health communication among tuberculosis patients. Health communication is the study and use of communication strategies to inform and influence individual decisions that enhance health. So here we will talk about the role of cellular communication in the treatment of tuberculosis patients. Due to poor compliance to DOTS treatment of tuberculosis patients, RNDCP has started 99 DOTS treatment among tuberculosis patients from October 2017. An important component of 99 DOTS is not simply the administration of correct drug, but also to ensure patient compliance for the whole course of the treatment. India has the world's second largest mobile phone user base, and the number of mobile phone users are expected to rise over 730 million. Low-cost mobile handset and affordable airtime rates made it easy for anybody to possess mobile. Despite 99 DOTS relying heavily on mobile technology, there is lack of studies being done. So we had done this study with objective to understand the current pattern of use of the mobile phone and its uses among tuberculosis patients. My study was cross-sectional study held in tertiary care hospital attached to Medical College Baroda, Vadodara Central, Gujarat, including all the adult patients attending the hospital OPD from August to December 2020 diagnosed with tuberculosis. Total 207 patients were recruited for the study via consecutive sampling method who were eligible for the study, and they were informed about the purpose of the study in their local language, and data was collected by a structured questionnaire entered in Microsoft Excel 2019 and analyzed using EpiInfo 7. Key output analysis was summarized as mean, proportions and percentages, and results has been expressed in tables and appropriate graphs. Total 207 patients were diagnosed and started treatment during the data collection period with mean age of 36 years, and among them 58% were males. Area-wise distribution of tuberculosis patients showed that a nearly equal distribution in urban and rural area, and most commonly affected age group was 21 to 40 years of age group. 52% were new tuberculosis cases, 32% were drug-resistant tuberculosis cases, and 16% were retreatment tuberculosis cases, where 72% were pulmonary tuberculosis cases and 28% were extrapulmonary tuberculosis cases. Among all the total tuberculosis patients, 164 patients were using mobile phones. Among them, 83 patients were using smartphones and 81 patients were using featured phone. Among all the smartphone users, 74 patients were using social media platforms. Most commonly used social media platform was Facebook and WhatsApp, and Twitter was the least commonly used social media platform. Among all the tuberculosis patients, 107 patients contact their healthcare person, and most common reason for that was counseling for the treatment, followed by doubts and doubts about side effect of the treatment. They were contacting their healthcare person as and when needed through phone calls. Among all the recruited tuberculosis patients, 135 patients got call from their healthcare worker, and most common reason for that was follow-up or general checkup, followed by the reminder for visit. Among all the tuberculosis patients, around 79 tuberculosis patients got call from their healthcare worker by regular basis, by weekly or by fortnightly or by monthly, and 8% were got call from their healthcare worker by daily. So the study concludes that majority of the tuberculosis patients had mobile phones, and more than half of them were using smartphones. Among smartphone users, 19% is using social media platform, and Facebook and WhatsApp were the most commonly used social media platform. 2/3 of them used their phone for the information seeking regarding tuberculosis. So here we would suggest that IEC materials and advertisement for awareness of tuberculosis diagnosis, tuberculosis treatment or tuberculosis prevention can be conducted over social media platform, and government can provide a toll-free number for tuberculosis patients to getting information easily on their mobile phones. Thank you.
Thank you very much, Dr. Modi, for presenting this study to all of us. I hope you're aware that a call center facility has been initiated under the National TB Elimination Program as well, which does a lot of this work that you're actually mentioning. Beyond that, what are your observations regarding communication TB patients के साथ किस तरह से या mobile phone से क्या better किया जा सकता है beyond what has emerged here? Any thoughts here?
Unmute yourself, please.
Parth, you're muted.
सर यहाँ पे वडोदरा में ऑलमोस्ट अर्बन एरिया कम है और रूरल एरिया ज्यादा है, और रूरल एरिया में भी ट्राइबल पॉपुलेशन ज्यादा है, तो उनके पास स्मार्टफोन से ज्यादा वो फीचर फोन ज्यादा होता है। कुछ पॉपुलेशन सर ऐसी भी है कि जहाँ पे फीचर फोन भी अवेलेबल नहीं होता है, तो वो लोग MPHW या STS के फोन थ्रू वो लोग कम्युनिकेट करते हैं। तो हम सर ये करके मैं ऐसा बोल सकता हूँ कि या तो SMS या तो कॉल, पर सर अगर वो फोन ही यूज नहीं कर रहे तो वहां पे हो नहीं सकता। पर सर हम रेडियो या टेलीविजन या जो होर्डिंग्स होते हैं वो कॉर्नर ऑफ द ट्राइबल एरिया तक अगर पहुंच सकता है तो ये सर इम्प्लीमेंटेशन अच्छा रहे।
थैंक यू डॉक्टर मोदी। अनमोल सर।
थैंक यू फॉर द वंडरफुल प्रेजेंटेशन। आपने ये टोल फ्री नंबर का कंक्लूजन में बताया, टोल फ्री नंबर नहीं है क्या स्मार्टफोन में?
सर स्मार्टफोन के लिए जैसा हमने जो डेटा लिया उससे यही कंक्लूजन निकला है कि अभी तक तो वो लोग यूज नहीं कर रहे, या तो है तो उनको पता नहीं है और अभी तक वो लोग यूज नहीं कर रहे हैं सर टोल फ्री नंबर।
ठीक है पार्थ, ओके
थैंक यू सर।
डॉक्टर हिमांशु, ये इसका आ रहा था कोई मैसेज, इसको देख लो जरा। अपूर्वा है ना, शी वांट टू।
Yes, Apurva, you had some connectivity issues and we were not able to hear you at that time. Can you unmute yourself, Apurva?
अपूर्व, मेरे ख्याल अब फिर दिक्कत होगी अपूर्वा।
I don't think she can, sir.
She's not in the meeting room.
I can't see her.
But she has given a message in the chat box. That's why.
She's been repeatedly messaging, but she's not here in the chat room anymore, sir.
Okay.
Sir, but there is a last moment addition. We have Dr. Ritu Mishra speaking on the novel host-directed therapies for the treatment of tuberculosis and observational study. So we will have her. This will be the last presentation, sir.
Okay, ask her to present her.
Okay. Please start, yeah.
Very good morning to all. Today I am here to discuss my PhD research work, that is novel host-directed therapies for the treatment of tuberculosis and observational study. Abstract ID is Iapsmcon 2021 ABS S3602. Introduction. Tuberculosis is a chronic granulomatous infectious disease causing morbidity and mortality worldwide and approximately.
Could you unmute yourself and present, because this is not audible?
Nivrin, we are unable to hear her. There's a lot
of yeah, this is inaudible, so please unmute yourself and present.
Tubercular infection. Rationale behind the study: possibility of new drugs being discovered. As we all know that from the last so many years, novel.
Dr. Ritu, please unmute yourself.
Yes, ma'am. Rationale behind the study. So I was talking about the novel host-directed therapies for the treatment of tuberculosis. So rationale of aims and objectives to study novel host-directed therapies for the treatment of tuberculosis and observational study. The next slide is rationale behind. Actually, ma'am, the slides are not in.
Your presentation is running. You have to be with the presentation. So present it as it is running.
Okay, ma'am. Study area and population, I have selected a total number of 80 patients with confirmed tuberculosis and type 2 diabetes mellitus. Study design is prospective and observational. Data is collected from patients' interview. The criteria of patient selection is age less than 30 years, confirmed positive cases of pulmonary tuberculosis and microbiologically confirmed TB, West Bottom smear, age less than 30 years, incomplete in exclusion criteria is incomplete information regarding the patient, improperly diagnosed patient, and patient who are not willing to participate. This is the methodology. So I have just taken the patient at Hakim Abdul Hamid Centenary Hospital on the basis of inclusion and exclusion criteria. A total number of 80 patients have been included. After that, the total study participants were divided into two groups. One group was taking ATT plus anti-diabetic drugs, and the other group was taking ATT plus metformin. So I have just focused whether the metformin can be used as a adjuvant anti-tubercular drug. After that, I have just taken the follow-up. First follow-up is after 2 months, and the second follow-up was after the 6 months. And then afterwards, I have compared the clinical outcomes in both the groups. So these are the results. First of all, I have seen health-related quality of life score in metformin users was significantly increased. So this I have assessed with the help of DR12 scale, that is Dhingra and Rajpal scale. So according to this, there were two domains that was basically studied. First one is symptom domain, and the second one is social, psychological, and exercise adaptation score. And on the basis of these two domains, we have calculated the total score, and we have found that among the metformin users, there was significant improvement in both the domains as well as the total score. So we can say that metformin users has improved better in terms of quality of life when compared to the metformin non-users. So this is the health-related quality comparison of health-related quality of life score among metformin users and metformin non-users. So we have compared among the metformin users and non-users, and we have found that there is a significant increase at second and third visits respectively. And we can conclude that metformin users was improving better in terms of quality of life in comparison with the metformin non-users. So the next is comparison of the mean change in the p-value. So we have compared among the metformin users and metformin non-users. So there is a significant change in terms of p-value at second and third visit respectively in terms of metformin non-users.
Nimran, is the presentation over?
Yes, sir. I think there might be a glitch in the presented submitted file.
Few slides didn't came, ma'am. Conclusion.
Probably the submitted file was not appropriate. Yeah.
Okay, no problem, ma'am.
Okay, Ritu, what was your conclusion?
Sir, conclusion was that if we would add metformin as a adjuvant drug along with the anti-tubercular therapy, then the patient outcomes would be better.
Would be better. Okay.
Yes.
How did you come for 80 sample size? Is there any specific
Sir,
method?
No, sir. Actually, the study is ongoing. On the we have calculated the sample size statistically, and the total sample size was 120 patients. But sir, till now we have enrolled only 80 patients, so I have concluded only 80 patient data here.
Okay, up to 80 patients.
Yes, sir.
Dr. Himanshu, please.
Ritu, thanks for this presentation. I understand this is interim work. There are two things that I have serious concerns on, so please take it in a positive way.
Yes, sir.
Number one, when we are comparing that with metformin or without metformin, that there is differences in outcomes. We are not sure whether there is baseline similarity between the two groups because they're not created through randomization. So unless you convince us that the two groups were similar in their quality of life, measured on DR12 at baseline, and now they're different after the addition of metformin, till that time, I would not be completely convinced of the conclusion that you're drawing. The second point, whenever we talk about an interim analysis, the level of significance is appropriately adjusted by a statistician to say whether or not the results are significant, given that you have less power because of a smaller sample size. So although we couldn't hear your presentation completely, it is a possibility you could have included some of these points subsequently in your slides, but these are two suggestions from my side for you to consider. Thank you.
Thank you. Thank you, sir.
So Nim, I think now it's time to conclude.
Yes, sir. So
Yes,
I am
so-
elated at the opportunity to having been interacted with such eminent chairs. And I thank you, sir, for enriching our knowledge with your in-depth comments and patient listening. So I would just request the participants to turn on their video so that we can have a group photograph for the thumbs up. Everybody, Reena Mohan, Muskan.
Ma'am, there's a problem in my video in my system, ma'am.
Okay, so let's have a photograph. Done. Thank you so much.
Thank you all for presenting their wonderful presentations. I'm thankful to the School of Public Health, Dr. Amarjit Singh, under whose dynamic leadership this conference is going on. I'm also thankful to Dr. Himanshu, who is from Public Health Foundation of India as a co-chairperson. And thank you to Nim for organizing this wonderful session. Thank you.
I'm
Himanshu,
humbled, sir. Thank you.
Himanshu, from your side, you.
Thank you very much, everybody. It feels nice to be here interacting with the team virtually from PGI. It happens to be my alma mater. 2004 is a far way away, but I see myself doing the same work when we had the last conference there organized a long, long time ago. Thank you very much. Congratulations to all the presenters for articulating their thoughts and sharing their ideas with all of us here virtually. Thank you very much to the organizing team, teachers, Professor Anmol, and everyone in the PGI team. Thank you very much. Thank you.
Thank you so much.
hospital. The role of mythology in molding popular public opinion can be attributed to, firstly, the fact that its outreach to the masses is unparalleled. Face mein namak hai. But they still maintain dental hygiene using neem twigs because its knowledge has been passed from the Vedas and through the generations to everyone. Secondly, trust. Mythological beliefs are so widely accepted as true that you can get better compliance to drinking cow urine from your patient than to anti-tubercular drugs. This is where we need to be careful. Correcting myths that have been considered indubitable in society since generations is a Herculean task. From convincing a mother not to feed her newborn child gutki, to addressing the public's widespread refusal to build toilets in their house due to its proximity to the kitchen, mythology will continue to influence public health. It is the job of the medical community to delicately present to the public both good and bad implications of such beliefs. Thank you.
I was 15. Worlds of smoke rose from father's lips, but my first smoke felt like lung whips. Yet routine, ritual, habit it became, and life would never be the same. I continued. They, the heroes, took the puff, and I bought it on the cuff. It seemed cool, till I knew I was made a fool. I smoked. I was 20, colleagues with teeth stained red. Try it, they said. Red stains, pan and gutka stains, tobacco stains. And alas, it brought all these pains. I chewed. Bitter it tasted, and my money was wasted. Yet I spat out red, until the day I spat out blood. I bled. I understood. Importance of life's most is realized not till it's lost. People, time, money, love, air. No, this isn't fair, I gasped. Every breath a struggle. Machines giving all oxygen they could smuggle. Now it's too late to create a new slate. I knew. I left. A warning note to my son I wrote. Slow death, painful death, breathless death. This tobacco steals your breath. I cried, little packets of lies, your pocketed rice. To life I bow, thanks to tobacco, I died.
Hello everyone, I am Dr. Vivek Sagar. I am Assistant Professor at Community Medicine, School of Public Health, PGMR, Chandigarh. I am presenting here my few lines to promote guidelines of social distancing, specifically mask adherence. This creation has got recognition in Jan Andolan competition. where I had submitted this as a written draft. Now I am upgrading it by giving it my voice and expression so that I can convince people in better way to follow COVID guidelines. If I could able to convince at least 10 people, I will be happy. The title of my creation is Mask आज का कीमती गहना. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. कोविड जैसी महामारी से गर दूर रहना है तो मास्क पहन हाथ धो के 2 गज की दूरी को भी सहना है. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. बदल गया है जमाना थोड़ा जनाब, बदल गया है जमाना थोड़ा जनाब, दिल से हैं पास लेकिन जमघट या पार्टी को फिलहाल दूर दूर से ही हेलो या बाय बाय कहना है. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. वैक्सीन भी आज आ गई है मेरे दोस्त, वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में देखो जाके हर रोज. वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में जाके देखो हर रोज कि मास्क मैंने अच्छे से पहना है. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. थोड़ी सी असुविधा है मास्क में हम मानते हैं, थोड़ी सी असुविधा होती है मास्क में हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है. थोड़ी सी असुविधा है मास्क में हम मानते हैं, थोड़ी सी असुविधा है मास्क में हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. कर रहे हैं गुजारिश आपके भले के ही लिए, कर रहे हैं गुजारिश सब आपके भले के ही लिए, तो ऐंठ में आके ऐसे इतने असावधान क्यों रहना है. कर रहे हैं गुजारिश सब आपके भले के ही लिए, तो ऐसे ऐंठ में इतने असावधान क्यों रहना है. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. माना तुम फिलहाल स्वस्थ हो सबकी दुआ से, माना तुम फिलहाल स्वस्थ हो सबकी दुआ से, लेकिन घमंड करने से पहले अस्पताल में जाके देखो. माना फिलहाल स्वस्थ हो तुम सबकी दुआ से, लेकिन घमंड करने से पहले अस्पताल में जाके देखो. एक मरीज से लेके फ्रंट लाइन वर्कर्स को पड़ता क्या क्या सहना है. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है. थोड़ी सी तो उम्मीद की है आपसे सबके भले के ही लिए, थोड़ी सी तो उम्मीद की है आपसे सबके भले के ही लिए. इलाज से परहेज बेहतर, इलाज से परहेज बेहतर, बरसों से सबका ये कहना है. मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे बहना है. करनी होंगी ये चंद बातें अपनी जीवन शैली में शामिल, करनी होंगी ये चंद बातें अपने जीवन शैली में शामिल. मास्क, हाथ की सफाई, 2 गज की दूरी एवं योग और व्यायाम. करनी होंगी ये चंद बातें अपनी जीवन शैली में शामिल. मास्क, हाथ की सफाई, 2 गज की दूरी एवं योग एवं व्यायाम. अगर कोविड जैसी महामारी को जल्दी जल्दी गुड बाय कहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। धन्यवाद। Hello everyone, I am Dr. Vivek Sagar. I am Assistant Professor at Community Medicine, School of Public Health, PGMR, Chandigarh. I am presenting here my few lines to promote guidelines of social distancing, specifically mask adherence. My this creation has got recognition in Jan Andolan competition, where I had submitted this as a written draft. Now I am upgrading it by giving it my voice and expression, so that I can convince people in better way to follow COVID guidelines. If I could able to convince at least 10 people, I will be happy. The title of my creation is Mask आज का कीमती गहना। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। कोविड जैसी महामारी से गर दूर रहना है, तो मास्क पहन हाथ धो के 2 गज की दूरी को भी सहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। बदल गया है जमाना थोड़ा जनाब, बदल गया है जमाना थोड़ा जनाब, दिल से हैं पास लेकिन जमघट या पार्टी को फिलहाल दूर दूर से ही हेलो या बाय बाय कहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। वैक्सीन भी आज आ गई है मेरे दोस्त, वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में देखो जाके हर रोज। वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में जाके देखो हर रोज कि मास्क मैंने अच्छे से पहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। थोड़ी सी असुविधा है मास्क में, हम मानते हैं। थोड़ी सी असुविधा होती है मास्क में, हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है। थोड़ी सी असुविधा है मास्क में, हम मानते हैं। थोड़ी सी असुविधा है मास्क में, हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। कर रहे हैं गुजारिश आपके भले के ही लिए, कर रहे हैं गुजारिश सब आपके भले के ही लिए, तो ऐंठ में आके ऐसे इतने असावधान क्यों रहना है। कर रहे हैं गुजारिश सब आपके भले के ही लिए, तो ऐसे ऐंठ में इतने असावधान क्यों रहना है। मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा
Lucknow, the land of Nawabs, sits right in the heart of Uttar Pradesh, India. It enchants our eyes with royal charm, which extends to the picturesque green villages. Lives in these villages have improved with construction of free toilets under the Swachh Bharat Abhiyan, the Clean India Mission. India was declared open defecation free in October 2019. But during our fieldwork, we found a hidden dimension of sanitation in these villages: unsafe child feces disposal. So we decided to look more into this matter.
मान घर में बच्चे ने टट्टी कर दिया, अब उठा करके कहीं किसी गंदी जगह पर उन्होंने छोड़ दिया।
तालों में फेंकते हैं, कूड़ा में फेंकते हैं, डस्टबिन में बाहर डालते हैं। और जो बच्चे के ड्राइवर है वो अभी भी पेपर में लपेट के ये लोग में नहीं डालती हैं।
क्या आपके घर में शौचालय है? आप बच्चों का मल कहाँ पर फेंकते हैं?
खेत भी जाते हैं बाहर भी।
अच्छा, इनको जब टॉयलेट कराना होता है बच्चे को तो आप कहाँ पे कराते हैं?
ये डायपर पानी रहता है वो पन्नी में करके बाग में डलवा देते हैं, और फिर जैसे ऐसे कर देता है पॉटी वोटी तो नाली में पानी बहता है, नाली में डाल देते हैं।
According to the World Health Organization, a child's stool is considered to be disposed safely when the child uses that latrine, or the feces is put or rinsed into the latrine or buried. Unsafe disposal is harmful because children's fecal matter is a source of contamination because they are prone to many pathogens while crawling, playing, etc. Many infections like diarrhea, hepatitis A and D, typhoid, polio, and worm infestations can be transmitted. Repeated infections lead to reduced immunity and damage to intestinal cells. This leads to reduced absorption of nutrients, leading to stunting and poor brain growth. This in turn leads to a vicious cycle of malnutrition and poor performance in life. Breaking the fecal-oral disease transmission cycle is important to reduce the under 5 mortality. We tried to find the reason behind this unsafe practice.
इनका टॉयलेट क्या लगता है आपको? क्या इतना कीटाणुजनक होता है कि
होता है मतलब कम जी, क्योंकि अभी दूध पीता है।
Some were even shocked.
इतने जागरूक तो है नहीं, इतना जागरूक नहीं, इतना प्रचार प्रसार नहीं है।
अभी उनको हैबिट में नहीं लिया गया है, इससे इन्फेक्शन भी बढ़ता है, लेकिन मोटिवेट कर रहे हैं लोग लेडीजों को।
Realizing the need for awareness, a campaign was started promoting children's health via safe excreta disposal, or in short CHE, for the term chi used by mothers to indicate a wrongdoing by their children. Focus group discussions were conducted and mothers were taught to dispose their children's fecal matter in a safe manner in latrines, and in case diapers were used, to cover it and throw in closed dustbins. This campaign started with one village and is now extending to many others. Ashas, the community health workers, have been advised to reinforce this good practice during village health, sanitation and nutrition days, and also immunization sessions. Safe disposal of children's feces, along with hand hygiene and safe drinking water, will improve nutritional status and health of our children. This campaign is a small step, a tiny drop in a large ocean, but perhaps this can form a tide that can wash away malnutrition and suffering.
स्वच्छता ही सेहत की निशानी है।
नमस्कार, मी एकता कम्युनिटी FM रेडिओतर्फे आपल्या सर्वांचे सामुदायिक हितार्थ जनजागृती कार्यक्रमात सहर्ष स्वागत करीत आहे. व्हॉट्सॲप किंवा सोशल मीडियाद्वारे चुकीचे संदेश आपल्यापर्यंत पोहोचविले जातात. त्यांना कसे ओळखायचे त्याविषयी माहिती प्रस्तुत करीत आहे. व्हॉट्सॲप किंवा सोशल मीडियाद्वारे आपल्यापर्यंत चुकीच्या औषधी उपचाराविषयी माहिती पोहोचविली जात आहे. ही माहिती खरी आहे किंवा नाही हे बघण्याकरिता काही शासनाद्वारे मंजूर असलेल्या साईटवर जाऊन बघू शकता. उदाहरणार्थ, आयुर्वेदिक औषधीची खरी माहिती जाणून घ्यायची असेल तर आयुष मंत्रालय लिंकवर जा, किंवा ॲलोपॅथिक औषधीविषयी खरी माहिती जाणून घ्यायची असेल तर शासनमान्य लिंकवर जाऊन माहिती काढा व त्यानंतर विश्वास ठेवा. शक्य असेल तर डॉक्टरांचा सल्ला घ्या. व्हॉट्सअपवर येणारी चुकीची माहिती फॉरवर्ड करू नका. आता आपण कोरोना होण्यापूर्वी कसे वाचू शकतो हे जाणून घेऊया. आतापर्यंत कोरोनावर लस आलेली नाही, म्हणून या गोष्टीचे कटाक्षपणे पालन करा. 2 फुटाचे अंतर, नाकातोंडाला मास्क लावणे, वारंवार साबणाने हात धुणे ही आजच्या काळाची गरज आहे. कोरोनाबद्दल लोकांच्या मनात असलेले काही गैरसमज जाणून घेऊया. लोकांच्या मनात कोरोनाविषयीची भीती निर्माण झालेली आहे. ती अशी की कोणत्याही आजाराकरिता दवाखान्यामध्ये गेले की कोरोनाची टेस्ट करून पॉझिटिव्ह दाखवतात. त्यामुळे दवाखान्याला फायदाच होतो व त्या पॉझिटिव्ह पेशंटमागे भरपूर दवाखान्याला पैसे मिळतात, असा गैरसमज लोकांच्या मनामध्ये निर्माण झालेला आहे. या भीतीने लोक दवाखान्यात जात नाहीत. हा गैरसमज चुकीचा आहे. त्यामुळे आजाराचे प्रमाण जास्त वाढतच चालले आहे. या आजाराची लक्षणे बघूया. सर्दी, खोकला, ताप, थकवा येणे, तोंडाची चव जाणे आणि वास न येणे ही लक्षणे दिसल्यास उपचार घ्यायला वेळ लावतात. तर माझी ही नम्र विनंती आहे की यातील कुठलीही लक्षणे दिसल्यास त्वरित दवाखान्यात उपचार घ्यावा आणि कोरोनाची तपासणी करून घ्यावी. तरच आपण कोरोनाची लढाई जिंकू शकतो. ही तपासणी सरकारी दवाखान्यात निशुल्क आहे. आता दिवाळीला सुरुवात होईल तेव्हा सुना किंवा मुली आपल्या माहेरी येणे जाणे करतील, तर त्यांना संदेश देण्याकरिता एक गीत सादर करीत आहे. तोंडाला मास्क लाव ग सुनबाई, मग जा आपल्या माहेरा माहेरा. तोंडाला मास्क लावलं ग सासूबाई, आता तरी जाऊ द्या ना जाऊ द्या ना. साबणाने हात धुव ग सुनबाई, मग जा आपल्या माहेरा माहेरा. साबणाने हात धुतले ग सासूबाई, आता तरी जाऊ द्या ना जाऊ द्या ना. कोरोनाची लस येऊ दे ग सुनबाई, मग जा आपल्या माहेरा माहेरा. धन्यवाद. जय हिंद, जय महाराष्ट्र.
भारत एक ऐसा देश जहाँ पेट्स को जानवर नहीं बल्कि घर का सदस्य समझा जाता है, और शायद इसीलिए हम इतने लापरवाह हो जाते हैं कि वो कब हमें चाट रहे हैं, कब एग्रेसिव हो रहे हैं, कब काट रहे हैं, हम इस पर ध्यान नहीं देते और अंजाम ये होता है रेबीज, एक दर्दनाक दास्तां। हर साल इंडिया में 20,000 डेथ्स रेबीज के कारण होती हैं, और इस लॉकडाउन में जानवरों को फॉस्टर करना, उन्हें अडॉप्ट करने वालों की संख्या काफ़ी बढ़ गई है। तो आइए हम आपको एक ऐसा ही किस्सा सुनाते हैं। मिलिए मिस्टर दुबे, मिसेस दुबे और बंटी से।
आभा, जरा चाय ले आइए। अरे बंटी, बेटा आप आ गए? ये क्या लेके आ गए आप अपने साथ?
पापा मुझे पपी रखना है पापा, प्लीज। पापा ये दौड़ रहा था मेरे पीछे पीछे, प्लीज मैं इसको रख लूं क्या? प्लीज प्लीज पापा।
आभा, आइए देखिए बंटी क्या लाए हैं।
अरे अब क्या हो गया?
मम्मी मम्मी प्लीज पापा को बोलो ना, प्लीज मम्मी, प्लीज पापा को बोल दो ना कि इसको मैं रख लूं प्लीज, वरना इसको कोई गाड़ी ठोक जाएगी। प्लीज, कितना क्यूट है ये, देखो प्लीज प्लीज।
बंटी क्या है ये? मना किया था ना कोई डॉग्स अंदर नहीं आने चाहिए, रेबीज हो जाता है इससे। एक बार हो गया ना, बहुत सारे इंजेक्शंस लगेंगे। मुझे कोई आर्ग्यूमेंट्स नहीं चाहिए, जल्दी वापस करके आओ जहां से लाए।
बेटा मम्मी सही बोल रही है, इसे छोड़ आइए।
तो क्या बंटी अब पपी अडॉप्ट नहीं कर पाएगा? लेकिन बंटी को तो ये बात पहले से पता थी कि उसके मम्मी पापा ज़रूर मना कर देंगे, इसलिए उसने अपने अंकल आंटी मिस्टर एंड मिसेस शर्मा को बुला लिया था।
अरे मिस्टर एंड मिसेस शर्मा, आइए आइए।
बंटी ने हमें बताया था मिसेस दुबे, मैं आपका कंसर्न समझ रही हूँ। रेबीज बहुत ही खतरनाक बीमारी है। मतलब इसके इनिशियल सिम्टम्स बहुत नॉन स्पेसिफिक होते हैं, बुखार, दस्त, उल्टी, थकान, सर दर्द, पर धीरे धीरे बीमारी बढ़ती चली जाती है। मतलब बंदा बेचैन होने लगता है, हेलुसिनेशंस, इवन पैरालिसिस तक हो जाता है, और लास्ट स्टेजेस में हाइड्रोफोबिया, एरोफोबिया, यानी कि ही इज इवन अनेबल टू स्वॉलो, दौरे पड़ने लगते हैं विद इन 10 days, एंड देन डेथ। और अगर किसी डॉग को रेबीज हो जाता है तो उसके मुंह से झाग निकलने लगते हैं, बहुत अग्रेसिव सा हो जाता है, वो सबको काटने दौड़ता है। और रेबीज सिर्फ डॉग से नहीं होता है, किसी भी मैमल से हो सकता है, कैट, बैट्स, फॉक्सेस, किसी भी मैमल से। और सही ट्रीटमेंट ना मिलने की वजह से मौतें इतनी ज़्यादा होती हैं।
आंटी, मेरी जो टीचर है ना, उन्होंने भी बताया था कि जब भी कोई कुत्ता काट ले ना तो उसको ऐसे झाड़ फूक और ये उस पर ऐसे नहीं दिखाना चाहिए, घर पे कुछ स्टिचेस भी नहीं लगाने चाहिए, सीधे डॉक्टर के पास दिखाना चाहिए।
कुत्ते के काटने के बाद तुरंत जितना जल्दी हो सके 15 मिनट तक साबुन एंड पानी से अपने हाथ अच्छी तरह धोएं। एंटीसेप्टिक्स का यूज करें, इरिटेंट सब्सटेंसेस का यूज बिल्कुल ना करें। बेयर हैंड से घाव को बिल्कुल ना छुएं और ना ही उसे कवर करें। पेशेंट को जितना जल्दी हो सके हॉस्पिटल ले जाएं, और अगर सुपरफिशियल स्क्रैचेस हैं तो रेबीज वैक्सीन, और अगर बहुत ही गहरे घाव हैं खून निकलते हुए तो रेबीज वैक्सीन एंड रेबीज इम्यूनोग्लोबुलिन यूज किया जाता है।
और अपने पेट्स का इम्यूनाइजेशन कराना, इट इज़ द मोस्ट इम्पॉर्टेंट वेपन इन रेबीज कंट्रोल। मतलब जब पपीज 3 या 4 महीने के होते हैं तो प्राइमरी इम्यूनाइजेशन होता है, और उसके बाद रेबीज के बूस्टर्स लगते हैं जब पपी 1 साल का हो जाता है, और उसके बाद जब 4 साल का होता है तब। एंड एज पेट ऑनर्स हमें प्रिकॉशन के तौर पे स्टैंडर्ड वैक्सीनेशन करा लेनी चाहिए।
Dogs are definitely our best friends and therefore we need to take best care of them.
मम्मी प्लीज मैं इसको रख लूंगा।
ठीक है बेटा, रख लो, लेकिन एक कंडीशन पे, पढ़ाई अच्छे से करनी होगी, ठीक है?
थैंक यू।
ये तो हुई हैप्पी एंडिंग, मगर इंडिया को हैप्पी और हेल्दी रखने के लिए हमें एक बहुत लंबी रेस दौड़नी पड़ेगी। हमें हमारे पपीज़ को इम्यूनाइजेशन करवाना पड़ेगा। वो काट दें तो हर्बल रेमेडीज़, इरिटेंट्स, बैंडेज, सूचरिंग या मैजिकल प्रैक्टिसेस से दूर रहना पड़ेगा, क्योंकि गलत ट्रीटमेंट ही हमारी जान ले जाती है। कुत्ते के काटते ही उसे साबुन से धोएं, एंटीसेप्टिक लगाएं और डॉक्टर के पास जाएं। इम्यूनोग्लोबुलिन के शॉट्स लगवाएं, वैक्सीन लगवाएं, पूरा कोर्स कंप्लीट करें, क्योंकि रेबीज़ का सिंगल डॉट वैक्सीन आज तक नहीं बना है। पूरी और प्रॉपर ट्रीटमेंट ही आपकी जान बचा सकती है।
So the poem goes like this. The first wave of COVID-19 at the beginning of pandemic terrified us to live each moment in panic. In days it reached the crest, although we tried our best. Lost in the unknown quest, then started hiding in our nest. It was just to console the lost soul, like someone denied after playing for. What scared us most, standing close to anyone in a row, seeing the mask lying on the jaw, disobeying the hand washing law. A breath of relief when we flew off the cage. Cases were low, post peak, so is our inner sage. Sad, we took it for granted. A wicked witch enchanted. Our path again got haunted. We did everything unwanted. Before we celebrate came the second wave, reminding the forgotten lesson we have. Things will never remain same. Nature will find ways to tame. We humans are just a name. She's the one playing all the games. What we can do is abide by the rules, understand the dark side of the jewel. Living with it is not a choice but very essential. needs contribution which must be to fight the crisis that could be of existence here. To avoid the waves, which distancing a norm, hand washing to kill all the germs, wear the mask and do not roam, practice social solidarity to deal with the storm. Thank you so much.
आज की इस दुनिया में लोग क्या कहेंगे पे बहुत जोर है। ये कुछ और नहीं, हमारी अंदर की अस्थिरता का शोर है। मैं ये नहीं कह रही कि सहमति है नहीं ज़रूरी, पर तब तक ही जब तक वो बन ना जाए एक मजबूरी। बाल अवस्था, किशोर अवस्था और फिर प्रौढ़ अवस्था, हमेशा दूसरों ने ही की है हमारी भावनाओं की व्यवस्था। दूसरे की राय सुनकर तो 10 कदम की दूरी को 20 कदम में तय किया। विचारों का इतना बोझ हमने अपने ऊपर व्यर्थ ही लिया। तुम्हारा तन, मन, धन और विचार सिर्फ और सिर्फ तुम्हारा है। इनको पूरा कैसे करना है ये कर्तव्य भी तुम्हारा है। अपनी मर्यादा आप खुद ही तय कीजिए, पर दूसरे क्या करते हैं उस पे टिप्पणी मत कीजिए। जिंदगी बहुत छोटी है छोटे विचार रखने के लिए, इसलिए बड़े विचार रखें इसका मजा चखने के लिए। दूसरा अपना सही गलत खुद ही सोच लेगा, आप अपने पे समय दीजिए, वो ज़्यादा लाभ देगा। आलोचना और मजाक में फ़र्क समझिए, बोलने से पहले थोड़ा सोच लीजिए। निष्पक्ष रहना एक गुण है बड़ा, जीवन में आए कई नकारात्मक विचारों से यह है लड़ा। एक दूसरे को जीवन में बढ़ाइए आगे, फिर देखिए कैसे जुड़ते हैं ये सुनहरे धागे। तर्क वितर्क करना गलत नहीं, पर दूसरों की भावनाओं को दबाना भी सही नहीं। जो आपका सच है वो दूसरे का झूठ हो सकता है, इसलिए दूसरे की सोच को इज्जत देने से बहुत फ़र्क पड़ सकता है। और अंत में मैं यही कहना चाहूँगी, इस समय किसी को ये ना बोलिए कि देश जल रहा है और तुम हंस रहे हो, कि देश जल रहा है और तुम हंस रहे हो, क्योंकि याद रखिए इसी हंसी को बरकरार रखने में आंसू उन्होंने भी बहाए हैं। इसी हंसी को बरकरार रखने के लिए आंसू उन्होंने भी बहाए हैं, क्योंकि हंसी तो बस चेहरे पे है, अंदर सबके लिए दुआएं हैं, सबके लिए दुआएं हैं। धन्यवाद दोस्तों, आशा करती हूँ आपको मेरी ये कविता पसंद आई हो। इसी तरह मैं अगले हफ्ते फिर एक नई कविता लेकर आप सबके सामने आऊँगी। तब तक के लिए शुक्रिया, गुड नाइट।
The discussion on mythology in public health is particularly relevant in a country like India, where the average man relies on home remedies based on myths, unless it is absolutely necessary to visit a hospital. The role of mythology in molding popular public opinion can be attributed to, firstly, the fact that its outreach to the masses is unparalleled. For example, even the most relentless ad campaigns by toothpaste brands may not reach the uninitiated villagers. They may not have heard the phrase "क्या आपके toothpaste में नमक है," but they still maintain dental hygiene using neem twigs because its knowledge has been passed from the Vedas and through the generations to everyone. Secondly, trust. Mythological beliefs are so widely accepted as true that you can get better compliance to drinking cow urine from your patient than to anti-tubercular drugs. This is where we need to be careful. Correcting myths that have been considered indubitable in society since generations is a Herculean task. From convincing a mother not to feed her newborn child gutki, to addressing the public's widespread refusal to build toilets in their house due to its proximity to the kitchen, mythology will continue to influence public health. It is the job of the medical community to delicately present to the public both good and bad implications of such beliefs. Thank you.
I was 15. Whirls of smoke rose from father's lips, but my first smoke felt like long whips. Yet routine, ritual, habit it became, and life would never be the same. I continued. They, the heroes, took the puff, and I bought it on the cuff. It seemed cool, till I knew I was made a fool. I smoked. I was 20, colleagues with teeth stained red. Try it, they said. Red stains, pan and gutka stains, tobacco stains. And alas, it brought all these pains. I chewed. Bitter it tasted, and my money was wasted. Yet I spat out red, until the day I spat out blood. I bled. I understood. Importance of life's most is realized not till it's lost. People, time, money, love, air. No, this isn't fair, I gasped. Every breath a struggle. Machines giving all oxygen they could smuggle. Now it's too late to create a new slate. I knew. I left. A warning note to my son I wrote. Slow death, painful death, breathless death. This tobacco steals your breath. I cried, little packets of lies, your pocketed rice. To life I bow, thanks to tobacco, I died.
Hello everyone, I am Dr. Vivek Sagar. I am Assistant Professor at Community Medicine, School of Public Health, PGMR, Chandigarh. I am presenting here my few lines to promote guidelines of social distancing specifically mask adherence. This creation has got recognition in Jan Andolan competition, where I had submitted this as a written draft. Now I am upgrading it by giving it my voice and expression, so that I can convince people in better way to follow COVID guidelines. If I could able to convince at least 10 people, I will be happy. The title of my creation is मास्क आज का कीमती गहना. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे भैया या बहना है. कोविड जैसी महामारी से गर दूर रहना है तो मास्क पहन, हाथ धो के 2 गज की दूरी को भी सहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे भैया या बहना है. बदल गया है जमाना थोड़ा जनाब, बदल गया है जमाना थोड़ा जनाब. दिल से हैं पास लेकिन जमघट या पार्टी को फिलहाल दूर दूर से ही हेलो या बाय बाय कहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे भैया या बहना है. वैक्सीन भी आज आ गई है मेरे दोस्त, वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में देखो जाके हर रोज. वैक्सीन भी आ गई है मेरे दोस्त, लेकिन फिर भी आईने में जाके देखो हर रोज कि मास्क मैंने अच्छे से पहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे भैया या बहना है. थोड़ी सी असुविधा है मास्क में, हम मानते हैं. थोड़ी सी असुविधा होती है मास्क में, हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है. थोड़ी सी असुविधा है मास्क में, हम मानते हैं. थोड़ी सी असुविधा है मास्क में, हम मानते हैं, लेकिन लापरवाही दिखा ऐसे सस्ते में तो मरते नहीं रहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे भैया या बहना है. कर रहे हैं गुजारिश आपके भले के ही लिए, कर रहे हैं गुजारिश सब आपके भले के ही लिए. तो ऐंठ में आके ऐसे इतने असावधान क्यों रहना है. कर रहे हैं गुजारिश सब आपके भले के ही लिए, तो ऐसे ऐंठ में इतने असावधान क्यों रहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे भैया या बहना है. माना तुम फिलहाल स्वस्थ हो सबकी दुआ से, माना तुम फिलहाल स्वस्थ हो सबकी दुआ से, लेकिन घमंड करने से पहले अस्पताल में जाके देखो. माना फिलहाल स्वस्थ हो तुम सबकी दुआ से, लेकिन घमंड करने से पहले अस्पताल में जाके देखो. एक मरीज से लेके फ्रंट लाइन वर्कर्स को पड़ता क्या क्या सहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे भैया या बहना है. थोड़ी सी तो उम्मीद की है आपसे सबके भले के ही लिए, थोड़ी सी तो उम्मीद की है आपसे सबके भले के ही लिए. इलाज से परहेज बेहतर, इलाज से परहेज बेहतर, बरसों से सबका ये कहना है. मास्क बन गया तन का एक जरूरी गहना है, जिसे पहने सब, बच्चा बूढ़ा, चाहे बहना है. करनी होंगी ये चंद बातें अपनी जीवन शैली में शामिल, करनी होंगी ये चंद बातें अपने जीवन शैली में शामिल. मास्क, हाथ की सफाई, 2 गज की दूरी एवं योग और व्यायाम. करनी होंगी ये चंद बातें अपनी जीवन शैली में शामिल. मास्क, हाथ की सफाई, 2 गज की दूरी एवं योग एवं व्यायाम। अगर कोविड जैसी महामारी को जल्दी जल्दी गुड बाय कहना है, मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। धन्यवाद। Hello everyone, I am Dr. Vivek Sagar. I am Assistant Professor at Community Medicine, School of Public Health, PGMR, Chandigarh. I am presenting here my few lines to promote guidelines of social distancing, specifically mask adherence. This creation has got recognition in Jan Andolan competition, where I had submitted this as a written draft. Now I am upgrading it by giving it my voice and expression so that I can convince people in better way to follow COVID guidelines. If I could able to convince at least 10 people, I will be happy. The title of my creation is Mask आज का कीमती गहना। मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। कोविड जैसी महामारी से अगर दूर रहना है तो मास्क पहन हाथ धो के 2 गज की दूरी को भी सहना है। मास्क बन गया तन का एक जरूरी गहना है जिसे पहने सब, बच्चा बूढ़ा चाहे भैया या बहना है। बदल गया है जमाना थोड़ा जनाब, बदल गया है जमाना थोड़ा जनाब। दिल से हैं पास लेकिन जमघट या पार्टी को फिलहाल दूर दूर से ही